Two, 1, 2, 2, 2. Ask them if they can hear us talking. Check testing, testing 1, 2, 1, 2. Check 1, 2, 1, 2, 2, 2, 2, 3, 3, 4. Check testing. Testing 1, 2, 1, 2. Check testing, testing 1, 2. 1, 2, 3, 4, 5, 6. Check testing. Testing 1, 2, 1, 2, 2, 2, 2, 3, 3, 4. Check testing. Testing 1, 2, 1, 2, 2, 2.
I can hear audio.
Thank you.
You're welcome.
advancing or reverse. Point at the little box right there. And like I said, I don't know the direction of the power, but all more or less communicate when one is over. So you can switch. Sound good? Yeah. Check 1, 2, check, check. 1, 2, testing. 1, 2, 3, check, check. Check 1, 2, 3, 4, 5, 6. Testing 1, 2, 3, 4, 5, 6, 7. Check, check. 1, 2, 3, 4, 5, 6.
I can hear you.
Check 1, 2, 3, 4, 5, 6. Check, check. 1, 2, 3, 4. Testing microphone 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You good with that, Dave? Check 1, 2, 3, 4, 5, 6, 7, 8, 9. Check, check. 1, 2, 3, 4, 5, 6. Audio check 1, 2, 3, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4. Today we're here at the PPA Event Center. Check 1, 2, 3, 4. Test 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Check 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Check, check. Check 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Check 1, 2, 3, 4, 5, 6, 7, 8, 9. Kind of sounds like it's coming from stage right a little bit, Dave. Check 1, 2, 3, 4, 5, 6, 7, 8. Check, check. Yeah. 1, 2, 3, 4. Testing handheld for Q&A. Check, check. 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4. I can still hear it faintly if I'm a little louder, but check 1, 2, 3, 4. There it is. 5, 6, 7, 8. Yeah, it's gone now. Check 1, 2, 3, 4. Check, check. Sounds pretty good. What do you think? Okay. Do you want me to go back to the other Q&A? Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Check, check. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Check, check. Check. Testing handheld Q&A microphone. for the PPA event. Check, check. 1, 2, 3, 4, 5, 6. Check, check. 1, 2, 3, 4, 5, 6, 7, 8. You want me to go back to that one? And are we leaving these powered on or off?
Check testing, testing 1, 2, 1, 2. You leave them on for now.
I appear to the favorable for Should I start? Hello? Hey, everyone, welcome. Thanks for taking your seats. My name is Palat, and I have the privilege of being the president of CMDA. Welcome to our conference. Oh, wow, already. Thank you. Thank you for being here. I wanted to start off by letting you know that if I had been in charge of picking the title for this year's conference, it would have been called something like CMDA's 28th Annual Conference, Nursing Homes Are Cool. I think they are. Or come get your CME. Or at least parking is free. I had one more idea. I want to run this by the board, maybe for next year, but it depends on how this audience likes it. Why can't the conference be in Hawaii for once? Yeah? All right, well, we will add that to the minutes. Thank you. We ultimately voted on PALTC 2023, Stronger Than Ever, because that was the best title. And I'd like to tell you a little bit about what that title means to me. So PALTC medicine stands for post-acute and long-term care medicine. This is the whole spectrum of care, from long-term acute care hospitals to acute rehab, subacute rehab, long-term care, your assisted livings, group homes, independent living, even including home health and hospice. And just like everyone in this room serves somewhere on that spectrum, the name of our group, PALTC, reflects that diversity and the unique nature of this setting. So there you go. If you didn't know what PALTC means, that's what it means. And hopefully you're still at the right conference. PALTC is strong. We are stronger than ever. Our skills are strong. 3 years ago, I never even thought about the difference between antigen and PCR testing. I couldn't even pronounce, much less know how to order monoclonal antibodies. And I certainly had never had to walk with nursing home staff who were losing resident after resident after resident due to a virus. We'll hear later how managing trauma is a skill. Our purpose is strong. Everyone in this room on some level cares about improving the lives of people in PALTC. And whether you've been in our space for 2 months, 2 years, or 2 decades, PALTC needs you right now more than ever. It needs us to be present. PALTC needs our expertise, our innovation, and needs our deep sense of purpose. I also think that our connections are much deeper now. I can't forget about 2 years ago, working with Jennifer Conley. Dr. Conley is right here. She is a long-term care pharmacist. And she and I were trying to figure out how to get this box of monoclonal antibody treatment over to a nursing home 3 hours outside of Denver. And we had to get it there quickly to help with the outbreak there. And we were texting and emailing back and forth. And it was a Saturday. And the whole time I just kept thinking, I'm so lucky to have this wonderful professional to work with and to help me find a solution to this issue at the last minute on a Saturday. I hope that everyone here has people that you can count on, like Dr. Connolly. And if you don't, I hope you meet your people today. Today, we're showcasing experts who make PALTC stronger. We will hear from seasoned medical directors and physicians and pharmacy, nursing, PA, public health, rehabilitation, quality improvement, administrative, and legal experts. As you're learning today, make sure that you collect your CME. You can use the QR code that's here on this slide. There's also one copy on every table in here on the other side of the agenda, where you can go to the website. This is also available on the online conference program. And the website will be up through May 2nd, which is this Tuesday. Besides this annual conference, CMDA holds a monthly meeting on the first Tuesday of each month. This is our time to get together by Zoom for education and updates from our partners at CDPHE and CHCA. You can also check out our website to catch up on past presentations, and we have 2 podcasts. And if you think CMDA should have more than 2 podcasts, find me and we'll think of some ideas. CMDA also has representation and open invitations to community meetings, the long-term care ethics meeting, geriatric journal club. Both of those meet on the first Thursday of every month, and the University of Colorado geriatric grand rounds. So you can join those mailing lists and find out more by contacting the people on this slide. And this slide, as well as all the slides, are available through your the room. And there may or may not be questions about hyperthyroidism, PER, and hypodermoclysis. And if you're thinking, oh no, I missed the CMDA meeting last December, that's okay. You can go to our website at cmda.us, go to meeting archives, and scroll down to the December of 2022 meetings, and you can read all about hyperthyroidism and hypodermoclysis. And then you can pass that quiz later today. I'd like to say a word of thank you to our sponsors and exhibitors. We could not do this conference without our sponsors and to the trade show. Thank you. Running. Later.
just because we forget, it's because we also remember what we have come through before and during that has affirmed, like Singh said, that we have partners in what we do, and those people bring us continuous affirmation of the value to what we do. So where do we see growth? We are going to talk a lot about workforce today, as I understand it, and I wanted to highlight just a few things that I'm seeing across the care continuum, but particularly trying to be embraced in long-term care and post-acute care. We're trying to improve compensation, both legislatively and as in market innovation. Responsive management is obviously essential, and people are finding it to be even more essential as we move along and try to retain our workforce. We're building bumpers around agency. It's
a very to age in place. People want, and of course, supportive kind of further and
It's recording.
People obviously. And, very much study is the push. Since again. Plus your own person. Anticipating
That
issues. Will some sort of with a combat to we've there is still a the clinical advice for what we family members who can't for increased medication our bill to push for a 10% increase.
now take in mind. That does not mean extra money. That means pull it out of the base rate and make us earn it. It's an interesting caveat. None of us would say that the pay for performance objectives are not something we would like to do, but it's going to require us to push our Medicaid thing that is closer to cost reimbursement. Currently, we've been at about an 85% reimbursement for the cost that we provide or the care that we provide. Other legislative positives, dementia care training. We're all excited about that, actually. There's going to be mandated dementia care training, and you will become a card-carrying member of I have had 4 hours, and no matter where I go, I can show that I have that training. And then 2 years, or every year, 2 hours re-upped dementia care training. And then our relationships with our agencies are getting a little bit more controlled, where they will now disallow, if this bill goes all the way through, buyout clauses. Employees will be given more freedom of movement to go from an agency to a permanent placement in a nursing home. Guardianship bill was introduced. We'll see if that goes anywhere. At this point, we are not sure that they will expand that program. It was the pilot program that's been in 3 districts to provide guardianship for those that are unfriended. So I also wanted to highlight that there are things that we're hearing within our membership, and you are, of course, hearing it from the people you work with. We are getting back to root cause analysis. We are getting back to restorative justice employment models and empowering our caregivers with deductive reasoning. We have a lot of reasons to hope for our future. And we, of course, most importantly, are in it together. And I thank you very much for your time today. So big. Well, I'll just try both. That's okay. Oh, okay. Galen, are you? It's okay. I think I went
Okay. So I'd like to introduce Dr. Lea Watson, who's going to speak to us on trauma-informed care. She's a visiting professor of psychiatry and geriatrics at the University School of Medicine. Works closely with the long-term care community to integrate behavioral health and optimizing psychiatric prescribing. And she is a frequent and well-known speaker for CMDA. So please welcome Dr. Watson.
Thank you. Seeing Leslie. Conference I go to all year. Thank you. And Jenny, you always make the boring and hard stuff seem so human. Like, isn't she just the greatest? Like, you really do. You always start us off and give that context. So thank you. So I'm excited to be here again. Thank you for inviting me. These are my people. It's fun to be here and see all of these faces after COVID. It means so much. And please come talk to me if I haven't spoken to you yet. It's so fun to see you. So I like to give the punchline early in my talks, just like what it really means. And the nuts and bolts of trauma-informed care are, this mural of it is on a restaurant near where I live. It's probably been seen by everyone everywhere. And if we all did this every day, we wouldn't have to talk about this anymore, right? So everyone you meet is fighting a battle you know nothing about. It sounds a little trite, because we've seen it so much, but it's so true. I can't remember the ad campaign where the thought bubbles were over people's heads. I think it was a healthcare ad, and it showed people walking through the hospital and what they're actually thinking about. Like, my loved one was just in a car wreck, or I just got a divorce, or my kid just was having trouble at school. And it just really hit home to me and brought me to recognize this quote even more. So keep this in the back of your mind. I could stop right here. This is the end of the talk. Okay. Who's heard of Gabor Mate? Very, very impressive and famous psychologist that has a New York Times bestselling book out right now called The Myth of Normal. I'll encourage you all to read it. I haven't actually finished the whole thing yet. It's very dense, but very good. He's a trauma expert. And he says that trauma pervades our culture, from personal functioning through social relationships, parenting, education, popular culture, economics, and politics. In fact, someone without the marks of trauma would be an outlier in our society, and that is true. And there's this book. I just want to stop for a second and say that Allison and I, along with Paige Hector and big AMDA, as we comes from, so I really want to give credit where credit is due. Paige Hector made a lot of these slides that I'm using. Talking about this in so emotional and psychological trauma are the result of extraordinary stressful events that shatter a sense of security, making you feel helpless in a dangerous world, and they often involve a threat to life or safety. But any situation, and this is really important to remember, that leaves you feeling overwhelmed or isolated can result in trauma, even if it doesn't involve physical harm. The more frightened and helpless you feel, the more likely you are to be traumatized. And this can begin in childhood with childhood bullying. It can accumulate over life, divorce, there's pandemic, there's medical crises. You may have just had an emotionally charged interaction with a staff member. And all of these things go together to accumulate to create what may be a traumatic experience and ongoing trauma for people. So it can be cumulative and impact a person throughout their life, no matter how long the event occurred. And there's a myth that trauma has to have been recent to actually be active. That, of course, is not true. This is the slide that everyone's going to pay the most attention to because you all have the most direct experience with feeling this. So emotional exhaustion among healthcare workers is a huge problem post-pandemic. 40% of nurses and 23% of physicians plan to exit their practice in the next 2 years. Just let that sink in. Completely related to what Jenny was talking about. Even comparing to post 9/11 combat veterans, when you compare to healthcare workers, show equivalent rates of moral injury in both groups. So we already knew that there was a lot of moral distress in healthcare. We have a broken healthcare system. That's not news to anybody, but the pandemic has put us in a much more vulnerable state. And in case anyone needs to understand it, in case they haven't experienced, emotional exhaustion is a chronic state of physical and emotional depletion that results from excessive job demands and continuous hassles. A huge issue for everyone, and just deep sympathy and empathy and respect for all of you that remain in this field when it is such a hard place to be. There are also losses related to aging and illness that can create trauma for people that I think we under-recognize sometimes because we're like the fish swimming in the water. But in the long-term care space, we take care of people that are having losses all the time, losing their independence, where they live, losing their ability to function, losing their ability to have the money they thought they were going to have, because it turns out nursing homes are expensive. That they lose spouses, they lose their meaningful roles and purpose, they can lose their cognition and their health. And then, of course, they get placed, as we say, a very derogatory term for what we do when we put people and put them into nursing homes. There are many sources of medical trauma, and for the clinicians in the room, I really want you. Every time people interact with a system, there's a risk for trauma. We communicate in ways that are technical and vague. There's certainly medication side effects, all of the illness-related symptoms. When people are in the hospital, it's loud, it's noisy, people have nightmares. Privacy is a barrier for people. People feel isolated and powerless. I won't read the whole list to you. By the way, all of these slides are going to be available to you. Some of them are very dense. Please refer to them later. And then hospitalization. I am a huge advocate, as are most of you in the room, for keeping people out of the hospital. Avoid doctors and hospitals at all costs is my advice to everyone I meet, unsolicited, often on street corners. And for people that live with dementia, you really want to keep them out of the hospital because they decline every single time and they rarely, if ever, get back to baseline. Just waiting in the emergency room can be traumatizing, right? You're stuck on a gurney in the side of the room and no one's even attending to you. And if you've ever had any experience with neglect or abandonment, it can be a trigger, of course. Fragmented care, you go and they don't send your orders back to the nursing home. So no one even knows what happened to when you were in the hospital. And because we have no clue what's wrong with you, because you might have dementia and your family member's not there, why don't we just test for everything? Because that's helpful. Transfer and transitions, we know there's a lot of discomfort in that, uncertainty, overwhelm, and most importantly, goals of care that have been clearly articulated about people's preferences for end-of-life care may have actually been completely uprooted and interrupted if they get sent to the hospital. So what is trauma-informed care? It is the adoption of principles and practices that promote a culture of safety, empowerment, and healing. It is person-centered. It is a fundamental perspective. It's an integrated framework. It's a relational posture towards everyone, no matter what their role, and it is a workplace culture. It is not just training on PTSD, which many people think it is. It is not solely based on a medical model. It is not just a prescribed set of skills and check boxes that we can all say that we've met the criteria for CMS. It is not just for residents. It is not just for people that have PTSD. When people are traumatized and re-triggered, our nervous system reacts. So we know that we have a fight, flight, or freeze reaction. And when we get into these areas of our brain, the limbic part of the brain, we sort of cut off the part of our brain in the frontal part that helps us with processing and logical thinking, where we kind of hit the pause button. So trauma is in fact a psychic injury lodged in our nervous system, mind and body, lasting long past the originating incident, and it can be triggerable at any moment. I love this slide. Paige put this together, and I've looked for one this good everywhere, so I'm so grateful for her for sharing it. But the limbic brain is where the fight, flight, or freeze things happen. This is where you're saying, am I safe? Is someone going to hurt me? All your emotions live here. The prefrontal cortex up here is where we, have executive function, where we have empathy and insight, where we regulate ourselves, where we think before we speak, where we have our moral compass, our intuition, and attuned modulation. Well, when you're completely triggered and stressed out, you don't have time for all that part in the front of your brain. Okay, so that's what people need to understand when people are having a trauma response. Who's heard of The Body Keeps the Score? A classic book on trauma written by Bessel van der Kolk. I cannot recommend it highly enough. And we know as clinicians in this space that people manifest physical symptoms related to psychological and emotional pain. So trauma lives in the body. This is a great cartoon that shows where trauma can show up in the body. It can be headaches, it can be emotional flashbacks, it can be fatigue syndromes, it can be immune system compromise, it can be eating disorders, it can be chronic pain, it can be GI issues. It can live everywhere, and it turns out the brain and the body are actually connected, in case that any of you didn't know that. And so it lives everywhere, and it's a reverse thing. So the body feeds the brain and the brain feeds the body. And so what happens sometimes when people have a lot of emotional and psychological trauma is they can seek healthcare more than those that do not, because healthcare seeking and getting attention and support in that way can be a proxy for getting emotional needs met. And this creates risk for iatrogenic harm when we overtest or perhaps send for more referrals when they're not necessarily
That's going to be public places on the street, places of high risk.
things that happened in the past. Triggers can come without warning and can be anything. And they can be very puzzling for caregivers and family because something could just tip somebody off out of blue for no reason. The person may not even associate the trigger with the event or even know it's happening sometimes. Their body posture will stiffen. They could become combative. If they're living with dementia, they could cry out. So triggers can happen all the time in different ways for different people, but they are typically interpreted as being a feeling of not being safe, a feeling of not being able to protect yourself, or a feeling, in fact, that I'm going to die. Expressions of distress are a means of communicating unmet needs. And this is when safety or trust or choice is interrupted. So behavioral expressions, we all see these in our patients, certainly those living with dementia, yelling, arguing, anxiety behaviors, isolation, withdrawal, aggression, resistance to care, the things that I get called about all the time, right? Dr. Watson, someone's resisting care, what should I do? Self-injurious behaviors, drugs, alcohol, unwelcome sexual expression, which we see sometimes in our clients. These are all behavioral expressions that may in fact be representing a trigger related to a past trauma. So what this typically means for people is they're coping mechanisms that may have made perfect sense at a time when a traumatic experience was happening for people, and they are no longer suited to them in the circumstance. For those that have been to therapy or know much about psychology, really the whole goal of resourcing yourself and going down the path of becoming a more whole human being is figuring out the coping mechanisms you used to have that didn't work. You need to let those go, right? Because they're no longer serving you in the present moment. And of course, they're not character faults. So it's really important to remember when people are expressing unpleasant behaviors from a caregiver's perspective that they may in fact be triggered. How could this behavior make sense? Reliving their trauma in the future. So we're going to switch gears here and talk about the 6 principles of trauma-informed care. So peer support, trust, cultural, historical, and gender issues. Facility culture is really the way we do things around here. And this is a really helpful scale if you're an administrator or have employees under you to help understand how they feel about the culture that you work in. And I won't read this to you, but it's basically about how to create a sense of safety. And I will encourage you to use this resource in your facilities as you think about how to go about creating a trauma-informed culture. SAMHSA's concept of trauma and guidance for trauma-informed approach is in this slide. And again, I won't read it to you. It's very, very helpful. Unlike that F66 definition, I find this slide to be super helpful. And so I would encourage you to refer to it as a way to start the dialogue about creating a trauma-informed culture. If a resident does disclose a traumatic event, sometimes people panic. Don't panic. It's okay. Just say, I'm really glad you told me about, this horrible thing that happened to you. It's going to help us take better care of you. You don't have to immediately make a report about something. You need to be a human being and listen and try to take that information and uphold the resident's privacy, even if the information is unusual, and then bring it to the team to see how you can accommodate that resident in a better way. This is a PTSD-5 screener that I encourage you to use for yourself and others. It's very simple, 1 through 5 scale. You can do it yourself and do it for your patients. There's not a particular threshold. It's mostly an informative thing to help you understand what's happening with your patients. And of course, the best thing we can do is do indirect screening as we take care of people. We can see how they're reacting to things in the day-to-day care of them, what seems to trigger them, what seems to comfort them. This is what we all do as good caregivers and good providers already. So we talk about universal precautions for infection. COVID was a great example. We glove and we hand wash. And I think talking about having universal precautions with regard to trauma is also super important. We should assume that all individuals have a history of trauma, and we should metaphorically glove up to reduce the possibility of re-traumatizing others. Again, it comes back to that very first picture of the mural. Assume people are going through trouble and try to be kind. It's very simple, but it's amazing when we get reactive how we don't do it. So the best way to provide trauma-informed care is actually to pause. When in doubt, be quiet. It's hard for me, hard for most of us. Pause, listen. Mind your tone and your body language, which are inevitably more important than the words that come out of your mouth. And don't react, respond, which means that you engage that frontal part of your brain to use the pause button and to really think before you speak. And I think that's my last slide. Thank you, guys.
Thank you, Dr. Watson. I think I figured out where I'm harboring my trauma. You need this?
Yeah.
Next, I'd like to introduce Dr. Nicole Orr, who's going to speak about managing heart failure in post-acute and long-term care. She's assistant professor of medicine at Tufts University School of Medicine, Division of Cardiology, also founder and president of post-acute cardiology care, and has written and co-authored several articles. And she's dedicated to improving heart failure education and management in the skilled nursing facilities, and serves as staff cardiologist and consultant doing rounds in several skilled nursing facilities, and also speaks nationally. Thank you.
Thank you so much. I'm obviously very excited to be here. I do and echo the sentiments of Lee that I've given a lot of chapter talks, and this is quite a society. So thank you very much to the organizers for the introduction and invitation to speak today. These are advanced. Oh, here we go. Okay. So I am tasked with talking to you about heart failure management in 25 minutes. So it is quite a broad topic. I really want to emphasize first that this is a very difficult subject, so I empathize with all of you if you have difficulties. There's a lot that goes into management of heart failure. There's multidisciplinary care team, there's lifestyle modifications. I would argue that probably many of you in this audience are probably very knowledgeable in those facets and domains of care already. So as a cardiologist, I'd like to impart to you some information about why these particular comorbid geriatric SNF patients with complexity of heart failure are difficult to manage, understanding why the symptom of dyspnea is hard to tease out in the SNF setting in heart failure patients, and really spend the majority of the time talking to you about how the updated 2022 heart failure guidelines for heart failure with reduced ejection fraction and HFpEF guidelines, which came out 4 days ago, which is why I have my laptop with me, how those are relevant, safe, and probably underutilized in the SNF setting. And I hope if I can impart anything to you is that the new therapies that we have can and should be applied to select SNF patients to help improve the difficult outcomes that we've all been struggling to improve. So I can't, as a cardiologist, get away with a talk without talking about physiology. So I will just review what is heart failure. It's actually quite a difficult question. It's anything that impairs the ability of the heart to pump enough blood to meet the demands of the body. So it's a clinical syndrome related to structural abnormalities associated with signs and symptoms of this inadequate cardiac output. It's not just volume overload. It's not just edema. It's not just shortness of breath. It's a clinical syndrome of signs and symptoms related to structural abnormalities of the heart from an underlying chronic disease process. It comes in various phenotypes related to that structural remodeling, and it's not just one entity. It's not just one diagnosis. The universal heart failure definition starts with symptoms and then requires either one of either elevated natriuretic peptides or objective evidence of cardiopulmonary systemic congestion. So we start with symptoms, then you have to have one or both of objective evidence, elevated natriuretic peptides, and the objective evidence is echo findings, chest X-ray findings, or invasive cardiac testing with right heart catheterization. The gold standard is actually a right heart catheterization, which invasively monitors pulmonary and left atrial pressures, pulmonary capillary wedge pressures with rest and exercise. Now, I don't know about your SNFs, but we don't do that in my SNFs. So we do not have the luxury of making that diagnosis definitively. We do also have a really hard time of understanding what are symptoms of dyspnea. We don't have the luxury of just with these younger 65-year-old ischemic cardiomyopathy patients of applying the Framingham criteria over orthopnea, PND, lower extremity edema. Our geriatric heart failure patients and SNFs can present with heart failure with overlapping symptoms that seem like geriatric syndromes: fatigue, exercise intolerance, nocturnal cough, altered mental status, worsening congestion, lethargy, restlessness, worsening appetite, edema that can be multifactorial from chronic venous stasis. And all of these symptoms not only have multiple etiologies, but they're also very heterogeneous, very fluid and overlapping. So it's not an easy job. I will give you some tips. We still do try to apply the classic Framingham criteria for understanding what heart failure is, despite the fact that these patients are so complicated to assess at the bedside. We still try to rely on the Framingham criteria, 2 major or 1 major and 2 minor criteria listed there. And I'll let you know that still, if the most sensitive sign for patients, even though they have concomitant pulmonary disease, is still an elevation of jugular venous pressure. So if you can try, I'll always put in this point, if you can try to assess jugular venous pressure, you will see that in most patients with fatigue or altered mental status or congestion or just lower extremity edema, if they don't have an elevation of neck veins, it's more reassuring that it's not actually increase in filling pressures in the left ventricle. One bedside tip I will encourage you to use is looking at peripheral vasculature. And I showed this picture of an engorged hand vein. And if you think about it, the heart and the veins, it's all just plumbing, right? So if you see someone with engorged veins and you think that they might just have old distended veins because they have lack of their venous tone, and you actually lift their hand up and you don't see a reduction in the venous filling, it's all plumbing. So that fluid can't go anywhere. It's stuck in the heart. So if you actually want to have a quick bedside test and you see someone with engorged veins, you lift up their hand, it goes away. Probably they have normal filling in their right atrium and then their left and probably their global filling pressures. And if you lift it up and it stays congested, more likely a quick, easy bedside tool that there is increase in filling pressures. So, oops, I did not mean to do that. Among patients with the clinical syndrome of heart failure, EF is a very useful phenotype, indicative of unique pathophysiologic mechanisms. And this is important because of its response to therapies. We all struggle with understanding what the ejection fraction is in our patients because of lack of communication, poor documentation. But it is really important because it determines what the response to therapies are. Therapies targeted at improving structural abnormalities of heart failure with reduced ejection fraction are not effective in patients who have the process of heart failure with preserved ejection fraction. And for review, hopefully this is at this point well known to most people in the audience, but heart failure with reduced ejection fraction is defined as an ejection fraction of less than 40%. Heart failure with preserved ejection fraction is heart failure with an ejection fraction of greater than 50%. And those individuals with EFs between 40 and 50 are noted to have heart failure with mildly reduced ejection fraction, and that can encompass patients who have heart failure with recovered ejection fraction or heart failure with HFpEF that is slowly declining in their systolic function. It is not, HFpEF is not synonymous with diastolic dysfunction. While it's often seen, you'll see on an echo that someone has diastolic dysfunction on an echo. That doesn't mean that they have heart failure with preserved ejection fraction because that is just an echo finding. It is not the clinical syndrome of heart failure. We know that the aging population has an increasing prevalence of heart failure. And in our older SNF patients that we see, particularly octogenarians, it's important to note that we will predominantly be seeing the HFpEF phenotype after heart failure hospitalization. And while this data is very old, I have to say I've given this talk so many times, but I've never actually given it in Colorado, at University of Colorado. So I don't have time to talk about it, but it's Larry Allen's study from here. So I just have to put the plug because I've referenced this so many times and I'm here. So you probably know that this showed among 15,000 patients looked at in the Get With the Guideline registry with an index hospitalization for heart failure, discharged to a skilled nursing facility or home after heart failure hospitalization, after controlling for patient factors, those with that were discharged to SNF were older, elderly, had concomitant renal disease, multiple comorbidities, but even after controlling for those factors, patients discharged to SNFs had a much worse outcome. 50% were dead in a year, and there was a higher 30% heart failure readmission rate. And so that led to the question of what are the systemic causes? Why are we not treating patients well? What is happening in SNF? Is it a systemic? Is it a systems program? It's not just that the patients are more difficult and more sick. One of the interesting things to consider, and this was a published study in 2015, is that we often think about patients getting with heart failure, getting volume overloaded and going back to the hospital for heart failure exacerbation. And this study by Harlan Krumholtz in 2015 in the New England Journal of Medicine showed that actually patients with heart failure aren't readmitted for heart failure. They're readmitted for their comorbidities. only 1/3 of the time are patients readmitted for heart failure. 2/3 of the time they're admitted for other things, lung disease, renal impairment, infection is a big one. And so how do we think about that in terms of SNFs? Harlan Crumpel has had this really beautiful summary stating that the index hospitalization for frail patients with heart failure creates this sort of frailty exacerbation where you have a lack of systemic reserve, and your inability the effect of heart failure systemically lends to a period of vulnerability, making your other comorbidities equally likely to exacerbate. So patients with heart failure, they don't require any longer just daily weights and diuretics. They require comprehensive care because we don't worry about, at this point, I don't think our SNFs are even looking at the secondary diagnosis for why they're readmitted. It's just if they're readmitted, and they will get admitted for other causes. So how do we broadly think about managing these patients? We need to improve or maintain their medical stability. We want to try to prevent hospital readmission. And interestingly, unlike in any other cardiac practice where it's the hospital or outpatient, we are thinking about a limited time as well to improve function. Cardiologists don't think like this. You guys think like this. It's a whole new paradigm of thinking about managing heart failure because a lot of the medications that we add on in the hospital don't necessarily help improve function. Beta blockers, diuretics. Oops. Am I, oh, I'm not advancing. Sorry, this is a lot of, I'm like, yeah. Sorry. So it's a really unique and fascinating way to think about managing heart failure. It gets me up every morning, but it's really hard to sort of find that sweet spot between optimizing medical therapy at the same time improving function. And for some of these patients who have an index hospitalization and are very sick on a lot of cardiac meds, and they have a Medicare window of 2 weeks to improve, and they have side effects of their important cardiac medications, but we're expecting them to get up and exercise and be out the door in 2 weeks, that's really challenging. And so hopefully I can impart a little bit in management right now to tell you about how to try to think about that. And of course, we're always trying to prepare for community discharge as possible. The AHA and the HFSA came out with this great statement. I encourage you all to read it if you haven't, on the management of heart failure patients in SNFs. And I just point this out because we think of heart failure patients that come in as sort of this rehab group that is sort of this, they have an index hospitalization, they come out and they have a destination to be discharged home. But the population is really heterogeneous. We have long-term care patients, as you know, and those who are in that really high-risk readmission pool who have an indeterminate discharge destination. They're often not able to stay home because they're frequently in and out of the hospital. They have multiple comorbidities. They're admitted for renal dysfunction, sepsis, COPD, heart failure, and those are patients that are particularly difficult to manage. But these general principles should be applied to each of the categories of patients. Along those lines, we think about in maintaining medical stability, we're probably going to need to up titrate when appropriate the medical therapies that we have on hand. Treat residual or new congestion. Obviously, as I can't emphasize enough, addressing comorbidities, and engage select subspecialists, even in the duration of the SNF period. If they're there for just 2 weeks, it might sometimes be difficult to arrange for that, but sometimes it's a necessary evil. Optimizing their goals of care, considering side effects of medications, and using the daily management that we do of weights and measuring and assessment as daily education to help improve their discharge care when they go home. So it goes without saying, the mainstay of managing heart failure patients, you have to know who's able to treat in your SNF and who's not. And there are various thresholds for treating SNFs. There are some SNFs that are really good at managing patients with IV diuretics and some that have a lower threshold for readmission. I would say it's probably safe to say that if you see an unstable patient with heart failure who is hypotensive, tachycardic, in clear cardiogenic shock with altered mentation, these management strategies don't apply to them. They're probably patients that are appropriate if they're not deemed not hospitalized to be transferred, or if there's just medical management failure despite all of your best efforts. But what do we try to do? Well, we need to reduce congestion. We need to determine the etiology of their exacerbation. We need to try to figure out what their ejection fraction is, and then apply guideline-directed, patient-centered medical care. What do we do to reduce congestion? This is not something that should be taken lightly. It is really hard to reduce congestion in some patients with renal insufficiency who have been on diuretics for years, who might have diuretic tolerance. But there are some strategies that you should not be afraid of. That is, if you have IV diuretics and a patient is on an oral dose, double the dose and give it IV if you can. If not, continue to diurese, double the dose, triple the dose, add an additional diuretic like metolazone or hydrochlorothiazide if you need to reduce congestion, understanding that you might have some expected and non-permanent, non-harmful impairment in renal function. But reducing congestion is important because patients will get more sick and decompensate if you don't aggressively diurese them. But what about guideline-directed medical therapy now? And why, again, do we need to know about this? We need to know because these upfront therapies, one, are going to be used more and more that we're going to be seeing. But oftentimes patients come to the hospital, come out of the hospital, and they're still frail, they're still hypotensive, and you get these discharge summaries that say, when they're stable, start this. And we say, well, they're only here for a week. We don't really want to take the risk of starting SGLT2 inhibitors and Entresto, sacubitril, valsartan. We'll send them to their cardiologist. We'll just get them to go through their restorative rehab course. But that's not the best thing for the patient. We know that upfront use of guideline-directed medical therapy will improve their outcomes and reduce readmissions. And I will ask that if you guys can think about knowing that this will improve, to have a little bit less hesitancy to take ownership and to start the medications without fear in the facilities. So we now know that there are 4 pillars of heart failure. So it's no longer ACE inhibitor, beta blockers, diuretics. The 4 pillars of our ARNIs, sacubitril, valsartan, beta blockers, SGLT2 inhibitors, and mineralocorticoid antagonists. And the updated guidelines recommend at first use of an ARNI, which is sacubitril valsartan, in place of an ACE or an ARB because of the improved outcomes in reduction in mortality and morbidity, along with one of the approved beta blockers for heart failure therapy. Sacubitril valsartan is a combination of an ARB and a neprilysin inhibitor. It inhibits the breakdown of biological circulating levels of BNP. We think of this as BNP as a bad marker of distension, but it's actually a helpful vasoactive peptide. Sacubitril valsartan will increase vasodilatation, decrease proliferation, hypertrophy, and has multiple beneficial effects on the left ventricular myocardium. In this trial of 884 patients with heart failure with reduced ejection fraction, we found that it found sacubitril valsartan versus enalapril, a standard therapy, on a background of already optimized therapy, had a 20% reduction in cardiovascular death and a 21% reduction in heart failure hospitalization. And importantly for our patients, thinking about this novel therapy, we worry about the effect on older patients, but this post hoc analysis showed that benefits across the spectrum of cardiovascular death, hospitalization, and all-cause mortality were still improved among the oldest patients greater than 75. So it's safe and effective in older patients. And importantly, a marker that's that we think about in geriatrics is quality of life. And sacubitril valsartan improved quality of life by the Kansas City Cardiomyopathy Questionnaire, which is the gold standard for heart failure symptoms. So To reiterate, the guidelines now recommend upfront use of ARNIs and beta blockers. Subsequently, mineralocorticoid antagonists, SGLT2 inhibitors, then diuretics, and in select patients, hydralazine and ivabradine, which I don't have time to get into here. But don't be afraid of sacubitril valsartan in older patients. It works among all of them. SGLT2 inhibitors is a class of medication taking the cardiovascular world by storm that has benefits across the spectrum of heart failure. It is not just used in diabetics. We know that it causes natriuresis, glucosuria. It reduces glomerular pressure. It has multiple benefits across the spectrum of the pathophysiology of heart failure. And it's shown that versus placebo, a 20% reduction in cardiovascular death and heart failure hospitalization in heart failure patients. Really striking data to add to the armamentarium of heart failure patients. And similarly, SGLT2 inhibitors have shown to improve across the spectrum of patients in Kansas City Cardiomyopathy Questionnaire. So SGLT2 inhibitors for our SNF patients will also improve their symptoms. So I'm running out of time. Sorry about this. But so the HFpEF population similarly is a very heterogeneous population. Unfortunately, we don't have the robust data for mineralocorticoid antagonists, beta blockers, and sacubitril valsartan for HFpEF patients. But we do now, in addition to understanding the pathophysiology and the importance of treating comorbidities, just 4 days ago, SGLT2 inhibitors are now recommended first-line therapy for all HFpEF patients with or without diabetes. I cannot emphasize this enough. HFpEF patients have difficult time diuresing. They have dyspnea. They have systemic symptoms of poor exercise tolerance. And all of our HFpEF patients now should be on an SGLT2 inhibitor. I will quickly show you the data that shows in the Emperor Preserved trial that patients with an ejection fraction greater than 40% treated with empagliflozin or placebo had a 26% reduction in the endpoints of heart failure hospitalization or cardiac death. This was seen to be safe in older patients, and it also improves heart failure symptoms and quality of life. We know that diuretics work. There's scant data, these slides are for your reference, showing that sacubitril valsartan can be helpful in a select group of patients on the lower spectrum of ejection fraction, so EF of 50 to 55%. There are guidelines of when you can start to use sacubitril valsartan in HFpEF patients. But if I can impart one thing to you today, based on the reduction in cardiovascular mortality and the reduction of heart failure symptoms, is the use of SGLT2 inhibitors for all of our comorbid, very complex, frequent flyer HFpEF patients. And in fact, I will point out that the guidelines, this red box here, this blue box at the bottom here is important. First, if you have a patient with HFpEF and you've treated all their comorbidities, you've stabilized their arrhythmia, you've treated their hypertension to a goal of 130 or 80, you've gotten them on other diuretic therapies, they ask, number one, is the patient on an SGLT2 inhibitor? If not, why not? And you should always say, why not? There are very few, besides recurrent UTIs, that are a significant problem with some of our older patients. Very few contraindications for HFpEF. Mineralocorticoid antagonists should be used, particularly in women with a lower spectrum of ejection fraction as well. We can monitor their potassium in SNFs. It's not a scary setting for that, so we should use those. That has been shown to reduce heart failure hospitalization. And again, the use of sacubitril valsartan in select patients because it can reduce heart failure hospitalization, which is a marker of quality for all of us. So I urge you, these guidelines came out April 23rd, to read them and ask yourself this question of whether or not you're following the new guidelines, SGLT2 inhibitors for HFpEF. I'll finally say we have a lot of patients on beta blockers with HFpEF. And in understanding the pathophysiology of endothelial dysfunction, it is associated with chronotropic incompetence. It has a side effect of fatigue, which is, optimally, which is what these patients are presenting with. There is no indication for the use of beta blockers in HFpEF. Unless patients have angina or uncontrolled arrhythmia, HFpEF does not require the use of beta blockers. We see so many patients on it for hypertension, and the side effect profile is so much worse. If you want to control blood pressure, use sacubitril/valsartan, an ARB, an SGLT2 inhibitor can help if they're volume overloaded, and try to think about taking off a beta blocker because there is data that shows that it worsens exercise capacity in HFpEF patients. So I'll leave you with the final points. Sacubitril/valsartan will be seen more frequently. They do have diuretic properties. When you see patients on it that started up front in the hospital and they come on also on diuretics, as the medications have some time to work in the SNF, think about, I'm going to likely change diuretics then maintain the dose. We have to think about the way that we used to think about this. If a cardiologist put them on a medication, they're going to stay on that for the duration of the SNF stay. Not with these new medications. There's so much fluctuation. So think about changing the diuretic dose. And make sure you monitor your patients daily with assessments, check their weights, treat their comorbidities, and don't be afraid to ask for help. Thank you very much. Thank you, Dr. Orr. So many pearls in that talk. Appreciate it. We are going to go into our Q&A session, and would the previous three speakers come up to the front? And we invite anyone from the audience to come up to the two mics here and ask your questions for the next few minutes. At this time, because we've been having some issues with Zoom, we are going to reboot Zoom. So there will be what? We're not rebooting? Oh, we're not rebooting Zoom. I just want you to know we're not rebooting Zoom. Amazing. Okay. Oh, sure, yeah. Hello, Dr. Birmingham. What's your question?
Super. Thank you very much for the CHF talk. That was great. When new studies come out like this that you just went over recently that look at reduced cardiovascular endpoints, I get a little worried about, are we going to have studies that show reduced all-cause mortality? Has that happened at all? Because the trade-off between UTI, urosepsis versus CHF gets me a little bit worried. So is there any data on reduced all-cause mortality?
Great question. So there in the DAPA-HF in the heart failure with reduced ejection fraction, there was an all-cause mortality was one of the primary endpoints. And it did show a 17% reduction in all-cause mortality. That was in heart failure with reduced ejection fraction. The HFpEF data looked predominantly at heart failure, time to first cardiovascular death, time to heart failure hospitalization. And what they looked at was really quality of life. So I don't have all-cause mortality, but I think when you think about salient outcomes for our patients, the quality of life is one that's very compelling. But I will, if I can find an all-cause mortality for the recent HFpEF, I'm happy to circulate it to see.
Hello.
Other questions?
Oh, you go ahead first.
Sorry, just one for Dr. Orr. What we're finding in long-term care is that the facilities will come to, I'm sorry, in SNF, well, the facilities come to us right after admission, especially with the RNAs and the SGLT2s. The first question is, can you change a medication because we can't afford it? So for RNAs, these are the administrators, these are the folks at the facilities. Are there other alternatives besides the RNAs?
Oh, that's such a great question. So, we still have the older data that shows enalapril, losartan, valsartan, having an additional benefit on top of a backbone of beta blockade. So if you can't afford the neprilysin inhibitor proportion, you can still use ARB therapy. And oftentimes that's recommended in SNF patients because if you look about the risk of angioedema, particularly in Black women, which is higher, and the increased vasodilatation leading to hypotension and orthostasis. Oftentimes there is a sort of selective algorithm when you're discharging a patient who's frail and on the hypotensive spectrum to still maintain valsartan versus the ARNI part.
How about for the SGLT2s? Any thoughts?
We
Any
just keep
suggestions?
fighting, just keep
Right.
fighting.
That's all we can do. Thank you.
Dr. Orr, I just want to ask a question. There's a lot of people in the room that are not clinicians necessarily, or they're administrators, or they're on the nursing continuum that may not be prescribers. So how can the non-prescribing caregiver team help do better at recognizing heart failure exacerbation, or to help improve the rehab potential for someone with heart failure? Just some like pro tips.
Wow. So yeah, I don't know how much time I have. There's a lot. It's a really great question because, and if you think about like the caregivers really are the first line, right? So what do you do? I think, caregivers, the benefit is that they see the patient, they can see change in clinical status. The change in clinical status for heart failure is it's really complicated, but you can still sort of use volume overload and just say, are you getting puffy? Are you having early satiety? They're really not eating. And early satiety is gut congestion from right heart failure. So, and if they can, get a weight. In terms of improving activity, I think really the most important thing is, and I have a discharge consultation. I see patients every week until they're discharged, and then I do a discharge planning. And in that is someone has a follow-up appointment. So they can either, call, but making sure that they follow up with someone who treats their heart failure, a nurse practitioner, their primary care, if they feel comfortable, or a cardiac specialist. That's really going to be important when it's beyond your own assessment. Thank you for your questions, and we appreciate your responses. Thank you.
Good morning. I just want to do a shout out to everyone who's participating virtually for hanging in there. So thank you for sticking with us. I'd like to introduce our keynote speaker, and I'm really honored to do so. Michael Wasserman is a geriatrician and a nationally recognized leader in the care of older adults. He chairs the Public Policy Committee for California's Association for Long-Term Care Medicine and served on the Game Changer member of the National Academy of Science Framework for Equitable Allocation of Vaccine for Novel Norovirus Committee. He's the editor-in-chief of the upcoming textbook, Geriatric Medicine, a person-centered, evidence-based approach. He is also the previously served as the chief officer overseeing the largest nursing home chain in California. He also has roots right here in Colorado as the co-founder of Senior Care of Colorado, one of the very first geriatric provider groups that specialized in post-acute and long-term care medicine. It is an honor to introduce my friend and colleague and welcome him back home, Dr. Michael Wasserman.
Wow, this is so cool. Here's the excellent. So good to be here in Colorado. I came here almost 30 years ago, and it's still my home in so many ways. Those of you who know me won't be surprised. I'm going to challenge you today. I'm going to make you feel a little uncomfortable, but at the same time, I'm going to give you great hope because there's a lot of great stuff that we can do. And I'm going to talk about that and see my title here. So this is a photo. 2 days ago, I was flying into Midland, Texas. Why? At the AMDA annual meeting 7 weeks ago in Tampa, I met a colleague, certified medical director from Andrews, Texas, and his administrator. So they are in rural America with a 5-star nursing home with low turnover of staff and people who want to work there. And I'm like, okay, all we hear is we can't find staff, we can't do this, blah, blah, blah. And especially in rural facilities that are shutting down. So I got on a plane and I went down there to see what they were doing. And the cool thing is what they were doing, and it's Permian Regional Medical Center. I'm going to be talking about today. So it really flows with our discussion today. And actually, this is a photo of the head of social services for the hospital. She's also the unpaid volunteer mayor for the last 10 years of Andrews, Texas, which I thought was really cool. Social worker for the hospital there. So I'm going to start the story in 1974. Those of you who remember 1974, Billie Jean King and Jimmy Connors. The Sting came out. My favorite TV doctor, Marcus Welby, MD, he only saw one patient a week. Really cool. And The Godfather 2 was out in 1974. So why does 1974 matter? Well, in 1974, the Subcommittee on Long-Term Care for the Senate Committee on Aging came out with a report, Nursing Home Care in the United States, Failure in Public Policy. We are going on the 50-year anniversary of this report. And they made a number of recommendations to get U.S. medical schools to establish departments of geriatrics, to give training to PAs and NPs in geriatrics and care of nursing home residents, to improve training of all the interdisciplinary team in geriatrics. This was 49 years ago. They told us what to do. We haven't done it. Okay, shame on us. And I'm going to talk about that as part of my presentation here. And as I like to say from George Santayana, those who cannot remember the past are condemned to repeat it. And so some of you may recall in 2014, the OIG put out a report, Adverse Events in Skilled Nursing Facilities. Okay, 40 years after the report that said, we got problems in nursing homes, what do we do? 40 years later, we kind of said, well, we really haven't done anything and we still have problems. These were the findings of that report. I don't need to review them. And then COVID. You know, if you have time, Google the 2021 June OIG report on COVID. This number is etched in my brain. In 2020, there were 169,291 more deaths in nursing homes than would normally have been expected. Okay, 2020, 169,291. The CMS website to this day doesn't even have that number covering nursing home deaths. There's so many issues, and then we have the report that recently came out on infection rates and stuff like that in nursing homes. COVID has got us to think about a lot of things, and we still have a lot of work to do. I'll say one thing is, I don't know why it took us all these years to have expected death numbers in nursing homes. So we could actually judge for those who said, well, they were just nursing home patients who died, they were going to die anyway. 169,291 were not of that ilk. So, and like Dr. Watson, I'm going to give you the gist of my talk in this slide, because I'm going to lead up to it. And at the end, I'm going to talk about my favorite metaphor, which also in 1974, this is Dr. Richard Feynman, noted professor at Caltech. He gave the commencement address at Caltech and brought up this concept of cargo cult science. And I read about this about a decade ago, and it really resonated with me. And I'm gonna tell you what cargo cult science is at the end of my talk. But it relates to nursing home care today. Is there anyone here who works for CMS? No? Okay. Was there? It's all right. I have a lot of good friends there, incredible colleagues, but I'm going to point out CMS has had the care coordination demonstration, the nursing home value-based purchasing demonstration, the QAPI demonstration. All these studies showed negative results. So what happened? CMS implemented them. Now, we really need to think, I mean, there's a lot more than that. I could give an entire talk on it, but it should make us think. That's my goal here today, is to get us to think. So I'm also going to tell you what this talk is all about right here in one slide. What's missing in order to make all three of those programs work? So number one, gosh, I've talked about this for decades, my favorite topic, the geriatrics approach to care. Number two, the structure to allow the geriatrics approach to care. And number three, the leadership to implement it. And I'm going to come back to all of these items. I'm going to start with the geriatrics approach to care. And I literally have a whole talk on this, so I'm going to go through them. I have stories for each of these pictures, but I'm not going to give them to you. You can ask me about them sometime. Function. That's with my former patient and good friend, Pete Peterson, who lived through the 1919 flu pandemic and lived through the first year and a half of COVID before dying at the age of 102 and a half. 15 years after I took him off of his prostate cancer killing treatments that were going to kill him, and having the urologist say, gosh, you can't do, I put the guy on testosterone. The urologist freaked out. And I said, you know what? Let's see what happens. The guy lived to 102 and a half. Person-centered care. Honestly, geriatricians invented person-centered care. And it's true, if you look at the seminal study on person-centered care, it's in the Journal of American Geriatric Society with a number of noted geriatricians, managing chronic disease, the psychological and social aspects of care. This is all part of what we do. All of us in geriatrics, spirituality, listening and communicating, realistic optimism and hope. That's something that's always really resonated with me, that even someone on hospice, up into the final days, they have optimism and hope in the moment. And we shouldn't forget that. Wellness, which finally, I think our government is realizing, Medicare was all about illness. We're finally starting to think about it as wellness. Teamwork. I would also argue that geriatrics invented the interdisciplinary team approach. We've been doing it forever. And now everyone else is picking up on it, which is great, because I love the audience here, because we're from the entire team. Respecting dignity and autonomy. Probably the one thing I learned in my medical ethics class in medical school 40 years ago that still resonates with me. Purpose. I mean, there's so many studies on the value of purpose affecting morbidity, mortality, things like that, and being sensitive to our patients' financial conditions. That's the social determinants of health matter so much. This is the geriatrics approach to care. This is what we need in our entire healthcare system, not just long-term and post-acute care. So I'm going to go through some of the next slides fairly quickly. And excuse me, I always joke that the cardiologists and the orthopedic surgeons, they don't need studies. We just assume that they know what they're doing, and they tell us. I'll argue with some of the orthopedic procedures that don't show any benefit for people, and some of the medical devices that we're still learning about. But what about geriatrics? People always say, show us studies. Well, we've got a lot of good data on how the geriatrics approach to care works. So number one, ACE unit, acute care of the elderly units. The number of these units is going down. I would ask us to ask why. We know this works. We know that bringing geriatric approach, evidence-based geriatric care to hospital care works. Fewer falls, less delirium, less functional decline. But you know what? It's not sexy, and it doesn't bring in a lot of revenue. Okay, it doesn't bring in procedures and stuff like that. It doesn't use high-cost medications, things along those lines. But it works. We've got to do better. We got to figure out how we get these units into hospitals and bring the care. The GRACE program, Geriatric Resource for Assessment and Care. This is basically geriatrician-led team care that goes into primary care. It's got lots of good data behind it. Steve Council from Indiana University pioneered this. Again, lots of good data and studies showing that the geriatrics approach works. They did a GRACE homebound study. Again, look at this, decreased hospitalizations. One of my jokes I've said for many years, hospital CFOs would love to have their facility empty just so long as their revenue doesn't go down a penny. And we're going to come back to that because this is the problem. This is the problem with the sort of the healthcare industrial complex and trying to balance the cost needs. I've often said to, and I've validated this with many of my colleagues, if we geriatricize the entire healthcare system, we'd probably reduce Medicare expenditures by 30%. Okay, but we would devastate the healthcare industry, put people out of work. So there's a lot of interesting challenges of how we approach this. PACE, I didn't pull up the data on PACE because I assume there shouldn't be a person in this room who doesn't believe in PACE and know that PACE works. And then optimistic, my good friend Kathleen Unroe from Indiana did a program bringing geriatric trained RNs into nursing homes. Guess what? It works. Lowers hospitalizations, improved care. We know all this stuff works. So again, I'm going to remind us, the geriatrics approach to care is foundational to everything we're trying to do. And if we ignore it, we get the negative trials on care coordination and value-based purchasing and everything else. Honestly, I think the geriatric approach to care is probably the single most important secret sauce of what we do. And by the way, the number of geriatricians in this country, board certified, peaked in the mid-90s at 15,000. And today we have fewer than 3,000 full-time practicing board certified geriatricians. And we need the geriatrics approach to care. So we've got a problem. Again, the structure to allow it, that's what I'm going to talk about next. So I sent an op-ed to the Wall Street Journal a week before COVID, or actually when COVID was announced as a pandemic, titled "COVID Unmasks Underlying Issues in the Nursing Home Industry." They didn't publish it. These are the things I'm going to cover with you in terms of the structure of the nursing home industry. And keep in mind, there's a lot of great nursing homes out there. There's great for-profits, there's great nonprofits, there's bad for-profits, there's bad nonprofits. We need to look at the structure because we all know, we've all been in great facilities. And that's what I hope is going to resonate with us today is how do we raise all of the facilities up to all be good? So number one, is there enough money in long-term care? That's a discussion that goes on all the time. I'm going to talk more about that. Are there enough trained staff? We heard earlier we've got staff issues. I'm going to challenge folks on that. I've heard so long, we can't find staff. People don't want to work in nursing homes. I'm going to tell you a story. 4.5 years ago, I was the CEO over a nursing home chain, about $1 billion nursing home chain. I got in my car over 6 weeks and visited 74 nursing homes in California as the CEO. I talked to CNAs, I talked to nurses, I talked to residents, I talked to administrators. And I came out of those 6 weeks invigorated because the people I talked to loved what they did. And I'd even have nurses say, we can't find staff, they don't want to work here. And I said, wait a minute, you're here, you love what you do, look in the mirror. So I think there's some disconnects we need to, and this is why I want us to feel uncomfortable. We know the great staff obviously they've been challenged the last few years, but the people who work in nursing homes are the most incredible human beings on the face of the earth, in my opinion. Okay. And I think there's a lot of folks out there who would do that. And we need to address why we're having struggles to get there. And then who's responsible and accountable for quality? This is a whole complex issue. Again, I could talk for a whole day on that. So we published a paper a couple of years ago on transparency. Okay, and there's a lot of discussions. There's a proposed rule right now on nursing home ownership transparency. And the bottom line is there's a lot of money that goes into nursing home care in the United States. Where does that money end up? How much of it ends up in the direct care of residents? And how much of it ends up in the real estate, in the medical supplies, in the wound care, in all the companies outside the walls of the nursing home? And I'm gonna highlight real estate. Okay, and there's a reason. A lot of nursing homes are set up as individual operations. So the operation is its own LLC, is its own business. Okay, and that operation has to pay rent. So I actually invested in a restaurant with my kids several years ago. It went under. It was a great restaurant though, 5 stars. But it went under. And I learned a lot about commercial real estate. So if you own commercial real estate, you pay something called triple net. So a nursing home is paying rent, okay? But they're also paying for the real estate taxes, the insurance, the maintenance. So the real estate owner sits back, they get their rent, they get their property taxes paid for, they get their insurance and maintenance paid for. It looks pretty good. And by the way, a lot of companies buying up nursing home real estate these days. So for all the folks who are worried about where the industry is going, excuse me on this one, the investors don't think it's going away because they wouldn't be buying. And there's some demographic reasons for this that go with the fact that the baby boomers are aging in. And these guys know 10 years from now, we're not going to have problems filling beds. So they're really looking at the future. The other thing that real estate owners gain is appreciation. We all know real estate keeps going up and up and up. And then finally, the folks who own the real estate leverage those assets. Okay, so they'll borrow hundreds of millions of dollars against the real estate assets. But how much of that money actually then goes back into the facilities? And that's a really fair question. And whether it's REITs, whether it's private equity, whether it's private ownership and private capital, you're going to hear folks say, oh, it's only a small percentage of private equity and REITs. Those are markers for the private capital, which is a much larger piece. But real estate does matter. You got to look at the line item on a nursing home's P&L to look at the real estate, the maintenance, the taxes, all the stuff I'm mentioning to see where that money is going. So I'm going to take a brief break in this general discussion to frame all this. Something that's I've gotten really interested in the last few years is fiduciary responsibility. Okay. And I share this because I think this is a critical linchpin for the structure of how we do things. And I don't talk to anyone anymore without understanding their fiduciary role. Because once I understand their fiduciary role, now I understand what motivates them. So fiduciary responsibility is about care, loyalty, good faith, confidentiality, prudence, but it's primarily financial. If you're on the board of a publicly traded nursing home chain, you have a fiduciary responsibility to the shareholders. If you are the CEO of that chain, you have a fiduciary responsibility to the shareholders. Now, as a clinician, when I was the CEO of a nursing home chain, I happened to have taken the Hippocratic Oath in 1985. I had a moral and ethical responsibility to the residents, to the patients. And while nurses and social workers don't necessarily take the Hippocratic Oath, we're all the same. We have a moral and ethical responsibility, and it's primary clinical in nature. And I think we have to come to grips with the balance between fiduciary and moral and ethical responsibility. And when I was running a nursing home chain, this was my North Star. A 3-sided scale that I had to balance: operations, finance, and clinical. And my clinical responsibility was moral and ethical. My operational and finance were fiduciary. And I didn't want my financial folks to not do a great job. I didn't want my operational folks to not do a great job. But I also wanted to make sure that clinical was in the C-suite with equal accountability to operations and finance. And if I would challenge the nursing home industry today, is how many nursing home companies, how many nursing homes individually have this balance where the clinical is given equal accountability and authority? How many chief medical officers have authority in nursing homes? Okay, in nursing home chains. So what's really missing? I mentioned the geriatrics approach to care and the structure to allow it. But there is one final missing piece, and it's what the talk's really about, and that's leadership. Because without leadership, I think these things fall by the wayside. And these are my mentors from 40 years ago, and someone noticed not too long ago that they're a bunch of old white guys. But this was 40 years ago, and these were my mentors, so that's is it. But I will tell you, there's a lot of great people on this. Some of you know some of them maybe, but I think of them often. But these are my mentors today and my colleagues, all leaders, all incredible, some of them in this room. And leadership is truly at the heart of everything, because without leadership, we can have all the check boxes and things in the world and they're not going to work. So I'm going to give you evidence for leadership, because everyone wants, okay, show me evidence-based literature. So first we're going to talk about the Avolio and Bass model of leadership: transformational, transactional, and passive avoidant. These are three types of leadership that Avolio and Bass developed many years ago. Transformational leadership motivates people, brings them along. My favorite two leaders on the basketball court, Larry Bird and Magic Johnson. I'll never forget once seeing Magic Johnson play, and he's pointing to his teammates where to go on the court. I mean, the other side knows what he's doing, but he knows that if they get to that spot, he's going to help make them score. Okay. So transformational leadership is really important. Rosa Parks, there's evidence that transformational leadership is associated with staff feeling better, higher job satisfaction, lower turnover, and better health outcomes. Transactional leadership. Okay. I'm not going to go into detail about transactional leadership. It is what it sounds like. Passive avoidant leadership. That's also what it sounds like. Okay. Now, here's the challenge again, to feel a little uncomfortable. When we look at the average nursing home, and let's look at directors of nursing, which of these leadership styles do we typically see? And this study was done actually not that long ago. Head nurses and DONs scored significantly lower on transformational and transactional leadership styles. Now, we all know in the buildings that we love, that do the right thing for residents and staff, those DONs are not transactional or passive avoidant. We know they are transformational. Okay. But when we look at across the board 15,000 nursing homes in the United States, we have to come to grips with the fact that the majority of DONs and head nurses don't have that transformational leadership style. And maybe that's part of our challenge. So then there's another type of leadership style, Bonoma Slevin. I love this one. Consensus leaders are just what it sounds like. They seek input from the team. They hear, not just listen, but they hear what their team says. And then they have to make a decision, but they use everyone's input to make that decision. The consultative autocrat listens to everyone and then makes their own decision without really necessarily paying attention. The autocrat doesn't listen to anyone and just makes their decision. And the shareholder manager, and I got to tell you, when I was running the chain I ran, I'd have people tell me, corporate told me to do this. And I said, wait a minute, I'm corporate. I never told you to do this. So how many of us have ever heard corporate said this? And it's a fascinating experience because a lot of times it's a perception of corporate. It's not actually corporate. And then other times it really is. So, but shareholder manager speaks for itself. So here's the deal. Let's look at 4,000 nursing homes across the United States. What's the most common type of leader? Well, the autocratic, consultative autocratic, and shareholders, 70%. Only 30% of nursing homes had consensus leadership. Maybe that's part of our problem, okay? But let's go further. Let's look at the data. Leadership style and staff turnover. This was a remarkable study done over a decade ago. To me, this is the single most important study in the history of nursing home quality, okay? Consensus style leadership amongst administrators, DONs is associated with lower staff turnover, significantly lower staff turnover. The shareholder, the autocratic, much higher staff turnover. We all talk about turnover as a marker for quality. Well, okay, how about quality? Consensus style leadership, busy slide, but associated with higher star outcomes, higher quality metrics. Consensus style or servant leadership is another term, I think, for it. We all know that that works. And then let's bring it to COVID and vaccination confidence. This study was done a year ago or so. Guess what? In facilities where there was greater confidence in the leaders, the staff felt their leaders were good, they got higher vaccination rates. Okay, so it works, it works. So, by the way, so this is just 2 days. This was actually yesterday morning. I went to the resident council meeting in Andrews, Texas, of this incredible nursing home. They got a very active resident council. Their activities director literally makes sure that they don't leave the room every week without sharing any complaints that they have. And they're all like, we love this place. But she makes sure. Leadership matters. So now I get the fun part. I used to start with this and realized it goes over everyone's head. So now I'm finishing because it's fun to do. What is cargo cult science? Why did I use that as a metaphor? So, and this is all quotes from Dr. Feynman in 1974. In the South Seas, there's a cargo cult of people. During the war, they saw airplanes land with lots of cargo, and they wanted the same thing to happen after World War II. Okay, so this is World War II, the indigenous people of the South Sea Islands, they got all this great stuff, and then the war's over, and they're waiting for more to come. So they've arranged to make things like runways, to put fires along the side, to make a wooden hut for a man to sit in. They put together 2 wooden pieces on their head like headphones and bars of bamboo sticking out like antennas. He's the controller, and he's waiting for the airplanes to land. They're doing everything right. The form is perfect. It looks exactly like it did before, but it doesn't work. No airplanes are landing. So I call these things cargo cult science because they follow all the apparent precepts and forms of scientific investigation, but they're missing something essential because the planes don't land. And excuse me for the CMS folks, but all those demonstrations, I can see the CMS folks sitting here in front of the wooden plane. And I'm sorry for that, but we really have to think this way of, we put really great ideas together, we put great models together, but they don't often work the way we expect them to. And we have to ask ourselves why. And so to me, cargo cult science approach to long-term care over the decades is everything from regulations. Excuse me for the surveyors, you do a great job with what you have, but I think we have to look at how we do this. Checklists. Oh my God. I wrote a paper last year called Beyond Compliance, talking about emergency preparedness and long-term care. OIG study, GOA studies for 3 decades tell us that checklists don't work. There's something else that matters. Leadership matters. Penalties. When you get a penalty 3 years after you've found a problem, is that really going to change behavior? Especially when some of those times they don't even pay the penalties. Okay, so I want to challenge all of us, the industry, the providers, the clinicians, the regulators, CMS, the state survey agency, all of us. Let's not just be building runways and wooden airplanes. We have to work together to put together the geriatrics approach to care, the structure to allow it, and the leadership to implement it. And this is me yesterday afternoon with Dr. Paul Slaughter, longtime AMDA member, committee member, certified medical director, who's not only the medical director of the nursing home in Andrews, Texas, but the chief medical officer for the whole system. His administrator, Sydney Folks, who's just an incredible servant leader, who has the experience of having worked on the other side in facilities where she didn't have the ability to be in full control of doing the right thing for her residents and staff. And the new director of their new soon to be built or being soon to be populated memory care center. And so I always use this. This is my former patient and very good friend, Carol Overholt, who passed away about a decade ago, who taught me more than anyone about our system. We're the keepers of the geriatrics approach. We have to stand up for it. We have to advocate for it, because if not us, then who? And then I think I have a few minutes for questions. And those of you who know me know that my dad was one of the most preeminent Albert Einstein lookalikes. So this is my father. These days, at the age of 89, he goes to the batting cages every week and hits 90-mile-an-hour fastballs. He's fighting prostate cancer and interstitial lung disease to get to 90 years old, hitting 90-mile-an-hour fastballs. You can Google him because he was featured in an LA Times article that's gone national on the fact, I don't think there's any other 89-year-olds who can hit 90-mile-an-hour fastballs. And with that, I thank you very much.
Thank you so much. What a great keynote address. I can't thank you enough. Does anybody have any questions?
Well, the mic.
So the nursing home that you've been in this week, is it a singly owned private nursing home or is it a corporate chain?
Okay, so that's the cool thing. It's a county-owned nursing home. Okay. They actually own everything. They own the hospital, they own the nursing home, they own the home health agency, they own everything. There's really no place for related parties and real estate. The money they get, they use. There's no, and excuse the word, because not everyone does it, there's no siphoning of the money out, okay? Now, they're in oil company land, so there's money in the county and they have some great benefits, though their wages are really no different than everyone else's. But interestingly, they've got another county that has a similar setup that isn't nearly as good. And the reason is the leadership piece. And I'm actually going to invite folks from CMS down to their facility. I think we need to look at best practices. We need to look at places that do a great job with the resources they have and ask ourselves, wait a minute, how come they're working and others are not? And I will say, you really do have to look at the financing. I've been privy to a lot of details of how the nursing home industry is financed. And I will say that there's a lot of money in the system that ultimately doesn't get to the direct patient care. And we really have to ask ourselves, these are taxpayer dollars. We have a responsibility to make sure that that money is spent on the direct care of residents. And hey, I'm an entrepreneur. I believe in the profit, in making a profit. And so there is a balance, going back to the fiduciary thing, that this country has faced since its inception. We have to balance capitalism with care and greed with compassion and figure it out.
Thank you so much. We are going to. We are so grateful to our speakers, but we get to have a break now. You get to have some coffee and go see our vendors, and we will see you back here at 10:20. And we look forward to that. Enjoy.
It's mainly just that the black, it's your covering, all black. No, you're fine. You want, especially one. I'm thinking. Yeah, I was thinking maybe. Yeah, and I might slide over and try to meet somewhere in the middle if we can. What's that? I have on my screen. I'll have to look on there. I made it. Traffic wasn't too bad. I just wanted to. I'm the next. Yes, your presentation should be preloaded on this. And then this is the clicker, forward, back, laser pointer. Yes, which is covered. It's covered though. It's covered.
Oh. Yes.
One side topic save the camera.
No, I talked to her and she said, I could give you.
Okay, yeah, no, you're good. No, you're fine. You're good to edit and we're not talking about speaking. Okay. Either I'm just thinking it's going to be. Alright, so it's going back to that one. That's actually for the number. Anyway, you can say no. It won't. Just leave it, yeah. That's. I tried. That's not saying anything. Is there somebody with me? Diane? Later.
All right, everyone, we're gonna go ahead and come back in and get together. Get ready to get started again. I'm gonna learn about some COPD now. All right, our next speaker is Dr. Griffith. Dr. Griffith is an assistant professor at the Division of Pulmonary Sciences and Critical Care Medicine at the University of Colorado Anschutz Medical Campus. Louder? Oh, no one ever tells me to be louder. And a staff physician at the Rocky Mountain Regional VA Medical Center. His research focuses on understanding the current delivery of appropriate care for COPD and other chronic and acute pulmonary conditions for adults with functional and cognitive limitations, and designing new programs to improve the delivery of this care. So you guys all join me in welcoming Dr. Griffith.
Well, thank you for inviting me to speak here. I am as a pulmonologist. Normally, I just speak to other pulmonologists. So I will get through my slides, and it's possible that I may not address the things that y'all are concerned about. So hopefully we'll have time afterwards for you to ask me questions. But I'm just really excited to be here, and thank you for the invitation. So the reason why I'm speaking about COPD particularly is because there's been a lot of changes in the guidelines and a lot of confusion even us pulmonologists are struggling with. So I hope to clarify some of that with this talk today. I was asked to make some kind of educational objectives for the talk. So I think that it's important to identify opportunities to escalate care appropriately, as well as de-escalate care when maybe the care being delivered is potentially harmful or unnecessary. And then also to think about not just what medications we prescribe, but to be a little more thoughtful about the delivery devices used to deliver pulmonary medications. Because as we'll talk about, pulmonary medications are a little bit different than medications for almost any other disease in that they can't be delivered orally or via a G-tube or an injection. They have to be inhaled using a special delivery, one of many delivery devices that are often difficult for patients to use. So just as an idea of the sort of epidemiology here is there's a report that came out last year, May of 22, from the National Center for Health Statistics, and kind of characterizing COPD prevalence for the first time. But previously this had kind of been missing, and likely due to the fact that COPD specifically isn't recorded on MDS reports to know the prevalence. And in general, it's underdiagnosed in the population when we look at screening, the tools for screening. What they found, and this is kind of a busy slide, looking at the prevalence of a lot of different diseases in a lot of different settings. COPD is down here in the corner, and they estimate that about 55% of patients in kind of long-term care, nursing homes kind of missing exactly, but if you look at the other graphs, those two sort of track together, but up to maybe half of patients in these settings suffer from COPD. And so that's why we're kind of talking about it today as one of the few chronic diseases we're calling out. So how do you diagnose COPD? Typically, you have to have an exposure that puts you at risk for developing COPD. The most common here in the US is tobacco use. But secondhand smoke and then organic smoke like wood smoke are other common causes to develop COPD around the world, and even in certain settings in the US. And the only way to diagnose it formally and to differentiate it, most importantly, from other causes of difficulty breathing is with a spirometry test. And what we do is, since COPD, functionally is a scarring or kind of a sclerosis, a narrowing of airways, patients have the same lung capacity as somebody without COPD, but it just takes them longer to get it out because these airways are sort of narrowed down. And so we look at the proportion of air they blow out in the first second as a proportion of the total amount of air they blow out. And we used to have a fixed ratio. So if you blew out less than 70% of your total air in that first second, it just took you longer than a second to blow out, more than 70% of your air, well, then you probably had COPD. But what we found is, lungs, just like every other organ, age. And so what's normal for an older lung, may not be the same as what's normal in terms of this ratio in a younger lung.
So the American Thoracic Society and European Respiratory Society no longer recommend a fixed cutoff. They recommend sort of age-adjusted lower limits of normal, which is a relatively new recommendation over the last few years. And so that's one way that, you know, again, a patient that you test, you know, you may get a report saying this patient has COPD because it's less than 70%, but, you know, a lot of labs are still in the process of updating to understand that actually this person doesn't have COPD, doesn't need all these medications. There may be another cause for their difficulty breathing. And it's often well below that former cutoff. So the implications of this change in diagnostic criteria are that older adults previously diagnosed with COPD no longer meet COPD diagnostic criteria. And with that, it sounds kind of silly, like, you know, well, they had COPD and what, now they're cured because they don't meet this criteria anymore. But no, a lot of it is what we're trying to suggest is there may be other causes for their difficulty breathing. And as whereas we used to hang our hat on this one value, it just sort of unfortunately forces us to look a little bit deeper and find out other potential causes for difficulty breathing. And yeah, encourage further evaluation. So, you know, what it says is if you have a patient kind of on this borderline, especially those who aren't improving with COPD treatments, you know, what we would, you know, if you have I guess what I'm saying is you have a patient that comes into your facility and carries this diagnosis of COPD in their chart, and you're ensuring they're getting their COPD therapy, but they're, you know, still not, you know, they're still look uncomfortable, or they're reducing their activity due to difficulty breathing. You know, we would really encourage you to refer them to a pulmonologist for spirometry so that we can see if they meet this criteria. And then if they do or don't, make, you know, recommendations appropriately, as we'll get into in a sec. And so once you've made the diagnosis, you need to decide how severe it is and what the appropriate treatment was. And there have been a lot of changes over the last 10 years in terms of how we describe the severity of COPD. Many of you may recall a severity scale that was based entirely on that FEV1 proportion number, and it was put forward by the Global Obstructive Lung Disease kind of Foundation, the GOLD, and they had GOLD 1, 2, 3, and 4 based off of how little or more air they could blow out in a second. And in about 2012, GOLD sort of abandoned that approach and developed this ABCD matrix for describing severity of COPD, and it was based off symptoms, and they recommended that symptoms should be assessed at least annually. And they were based off of, let's see, here, which is the number of exacerbations the patient had in the last year and how severe they were. So if a patient had 2 outpatient or 1 inpatient exacerbation, they kind of fell into the CD box. And then we'll get into what these mean in a second. These are the sort of 2 recommended symptom assessment scores. And so based off which box your patient fell into, that was how you were meant to describe severity. But this too, you know, and this is a relatively recent change, and this too has been updated again to just A, B, and E. And so you may find you get a recommendation from a pulmonologist now that just says they have GOLD E COPD. And you're like, wait a minute, E wasn't one of the 4 letters that you guys have been using for a while. What are you talking about? And it was meant to simplify it, right? Because we have medications that we think their primary role is to prevent exacerbations. And then we have medications that you know, there's a lot of overlap between those medications and those that just help with daily difficulty breathing, but they're not quite the same. And then these patients here in the A group probably don't need regularly scheduled medications. And so that's why they just try to simplify it. These folks don't have exacerbations, but have difficulty breathing on a day-to-day basis. These folks have exacerbations and need an exacerbation-focused approach. And so there's been this move to simplify. So you may hear A, B, or E now. I don't know why it's popping up a million times here. What do those tests at the bottom of the last slide I have, what do they entail? This MMRC or the CAT score. And if you were to look at 100 pulmonologist notes, you might find these scores documented, you know, a dozen times. We've kind of looked at this in the VA and in University of Colorado settings. And even though this is a recommended part of every encounter, it's rarely completed. And I would imagine most pulmonologists don't know these tests, and maybe you all in the audience don't know these tests. So what the CAT score is, and this is a pretty complicated score or a tool to administer, even in patients who are cognitively completely intact, even for, my patients who are, employed and fully functional. It's not an intuitive score test to administer by any means. It asks 8 questions, and for each question, patients have to provide a score on a 0 to 5 scale. And so, for example, the first question is cough. 0 is I never cough. 5 is I cough all the time. And you ask a patient, where do you fall? And you often get a blank look from them of, sometimes I cough. Well, you see in the morning, I cough a lot and I have to clear stuff out. But then by the afternoon, I'm kind of okay. So doc, what score is that? And you have to just refer them back. I don't know. It's just you have to. We look essentially for internal consistency. We just ask the same, as a pulmonologist, I encourage us to ask the same question every time and see if the treatments we're giving move patients one way or another. But it's hard to orient people, again, to what these scores mean. You can see phlegm, for example. I have no phlegm in my chest at all. My chest is completely full of phlegm. Where do you fall on that scale? These tests are hard to get people, again, just to use them. And the fact that, this is how we're making, potentially diagnostic and treatment decisions. You can see how problematic this is, particularly in the patients that you all deal with who have dementia or have, or like, for example, this question here, when I walk up a hill or one flight of stairs, I'm not breathless. When I walk up a hill or one flight of stairs, I'm very breathless. How many of your patients are walking up hills, regularly? Very few. I'm limited doing activities at home. I'm not limited doing activities at home. Well, do your patients live at home? No. I mean, again, these tools need adaptation, and that's kind of where my research is heading, is how do we adapt these tools for different populations? But unfortunately, this is kind of where we're at. So, we have to think of other ways for y'all to assess these patient symptom severities than using these standard symptom scores. But I just wanted to highlight kind of what the sort of standard of care is. And this is the MMRC. I mentioned there were 2 scores here. There's the MMRC and the CAT. This one's a little easier. And actually, they've found it tracks fairly well to the dyspnea assessment in the MDS. Because all this one really asks is, do you have breathlessness or not? And then it only really asks, it's a little bit tricky because the patient is asked to kind of compare themselves here. If they have a score of 2 or higher, that's considered a fair amount of dyspnea. But it says on level ground, I walk slower than people of the same age because of breathlessness, or have to stop for breath when walking at my own pace. Well, it's a little bit awkward to ask your patients to compare themselves to people of their own age, because they won't be able to do that. But these are probably criteria that you all could use to assess your patients, and again, make that same decision. But again, there are no specific recommendations for patients with dementia or even just older adults. I don't know why these animations keep coming up. And I wanted to highlight a recent publication. This came out last year, where the authors actually looked at, they went in and evaluated about 200 nursing home patients, looked at their existing MDS assessments, and then compared, and then also, as best they could, had them perform the same questionnaires that we're asking everyone to perform for a COPD evaluation. And they found that just having, any dyspnea, which is kind of marked on the MDS, the MDS asks a few different dyspnea scores, but having any one of those be positive was highly predictive of having was highly predictive of having a positive evaluation on these standard tests. So I think what that can reassure us is, the MDS is performing fairly well at picking up dyspnea, and that may be a tool to use kind of in place of these more complex and not age appropriate or cognitively appropriate tools of assessment. And so in terms of deciding whether your patient's A or B, kind of your standard MDS assessment might be appropriate. In terms of E, you're going to have to just look at the clinical chart, but that should be something that's pretty available. Mostly, has this patient been treated with prednisone? Have they, been admitted to the hospital for an exacerbation in the last year? And those can help you make these severity assessments. So you've appropriately kind of characterized your patient into an A, B, or E categorization. Now, what do you do about that? What do you treat with? And so in terms of medications, we know there are many medications that relieve symptoms of COPD and prevent exacerbations. But looking at sort of Medicare data and other data sources that have been published in the literature, only about 25 to 35% of long-term care residents with COPD receive what we would call a LAMA or LABA containing medication regimen. And I think I have a slide explaining what these acronyms mean, but you're going to see these a lot, LAMA and LABA. LAMA is, it doesn't actually, really matter what it is, but you can think of a LAMA. Your classic one is Spiriva, and LABA is your classic are formoterol and salmeterol, and those are components usually of combination inhalers, and essentially both are long-acting bronchodilators that sort of act like albuterol but last all day. And those are the recommended medications for folks that are B or E. And so only about 25 to 35% of folks with COPD receive a LAMA or LABA. And this is compared to the general population, where we think about 75% of patients with COPD should be on one of these medications. And only about 40% of patients in long-term care with 2 or more exacerbations in the prior year were on even PRN bronchodilators, let alone something to prevent exacerbation. So that we see this, we observed, when we've looked at it, under treatment of COPD in nursing home settings. And that's kind of one of the goals of this talk, is to kind of help raise that up. And then in terms of what we know about delivery devices that have been chosen, about 25% have received a nebulized form of medication in the last year. And usually it's only albuterol. And we'll talk about what nebulized medications are available in a sec. So tracking medication recommendations onto that A, B, or E group. So in group A patients, these are patients with relatively few daily symptoms and no exacerbations. Just an as-needed bronchodilator is appropriate. For group B, this is again a recent change in the most recent GOLD guidelines that is new from last year's GOLD guidelines and all those before. We're now recommending going straight to a dual bronchodilator therapy. And so the classic one we use at the VA is called Stialto. But there are others that are various combinations of LAMA and LABAs. And then that's also now the same recommendation for folks that have had exacerbations. So again, this is kind of trying to simplify care. So pretty much if your patient has either daily symptoms or exacerbations, they should be on at least a once daily LAMA-LABA inhaler. And as a second line therapy, or if blood eosinophil count is greater than 300, we recommend adding a steroid. That's not to say you need to be checking eosinophil counts on all of your patients. It's just to say, we used to say, go ahead with the steroids. These are things like Advair, Wixela, Symbicort, a lot of these steroid contain Dulera. We used to jump straight to the steroids, and now we recommend against it. And I'll explain why in a sec. Oh yeah, I put the brand names here. Great. So Stialto and Anoro are the two sort of major brands that meet this criteria here. There's a few others that are less prescribed here in America. These are the two main ones. And so there's this complicated algorithm that, again, we hope that you'll engage pulmonary providers if you kind of if the first line therapies aren't working and you need additional help. But again, the purpose of this diagram is mostly to say we're trying to avoid steroids now when we can, primarily because we know that steroid-containing inhaled medication regimens are associated with far more adverse events for patients than medication regimens that don't involve steroids, for patients who probably don't benefit from them. So we're trying to, over the last 5 to 10 years, we've really tried to nail down who benefits from adding a steroid and who is harmed by it. And really, again, only these people that have this like very allergic kind of profile of high blood eosinophils seem to benefit. The harms of inhaled corticosteroids in the average population is we know they increase rates of pneumonia, they increase rates of severe pneumonia leading to hospitalization. They've been shown to increase fractures and in patients, long bone fractures, glaucoma, and cataracts are all, besides just the usual thrush that we think about with these drugs. So, yeah, so again, we're trying to be more cautious, and that's why you've seen this recommendation for de-escalation among patients. All right, if meds don't work, I think we have classically said switch up the medication, but we also want you guys to consider the delivery device, that each device has pros and cons. I'm getting short on time here, but actually. One of the things I did want to highlight too is the non-pharmacologic approaches to improving symptom management. Of course, the main one is smoking cessation. I'll talk a bit for just a brief moment about the efficacy of smoking cessation in this population, as well as increasing physical activity and things like pulmonary rehab, particularly for this B and E group. Pulmonary rehab can be delivered in long-term care settings, regardless of symptoms. There was a study looking just among people who had a COPD diagnosis, and they had a lot of patients they excluded, which made it a little bit troubling in generalizability. But they found it actually helped save. They had patients work for 3 hours a week for 6 to 8 weeks with exercise training, dyspnea management, and upper extremity weight training. And they found that it improved exercise tolerance and symptom scores. And so this can be integrated into services you are already offering patients, potentially to improve their symptoms. I have a lot of people come with concerns about medication side effects in terms of why these medications are held in this population. It must be said that LAMA and LABA agents do have increased risk of cardiac events, so including MI, CHF, tachycardia, and arrhythmia. However, even in people with advanced stage heart disease, when they've actually studied this prospectively, the risks were very low, and they actually had a survival benefit for patients who are on medications. Although these are associated with adverse events, the overall kind of favorability profile favors treatment over holding treatment. And again, we've talked about some of the risks of inhaled corticosteroid treatment. So there's really no reason to avoid LAMA, LABA agents in any patient population, but inhaled corticosteroid regimens should be used cautiously and de-escalated when appropriate. And they've actually done research, I want to emphasize, that de-escalating patients does transiently, over about a period of 2 weeks, increase their risk of exacerbation, but beyond that, for patients who have not had exacerbations, does not increase their risk there. So there is a potentially a period of instability, but long-term, this is a safe practice. Reminding us of the delivery devices. So the metered dose inhaler is the classic one. The advantages to this is it can be used with a spacer, but it does require sufficient force to activate. You must clean the spacer appropriately. And if you don't use a spacer, there's pretty good data that this is one of the hardest to actually get the medicine into patients' lungs. And so we always recommend, if you're going to be prescribing inhaled medications through an MDI, use a spacer. You might often know these different forms of a dry powder inhaler. What's great about these is you kind of activate them and then they just sit ready until the patient's ready to use it. They're breath activated. However, they must be held level after activation, and you have to generate sufficient force to pull the medication out of the device, which many patients we find cannot do, particularly those with dementia. There's a soft mist inhaler, which many of you probably are familiar with. Looks like this. Is one of our newer delivery devices. It's twist and then you hit the button and a mist comes out. It has a more natural breathing position. There's no need to generate inspiratory force, but it can't be used with a spacer. So if the patient doesn't time their breathing perfectly, it will wind up in their mouth, just like any other inhaler. And then there's a nebulizer. No breathing coordination needed, no need to activate it, no maximal inspiratory force needed to pull the medication out of it. However, it does require like a setup, and it requires someone with training to set it up. And there aren't any combination inhalers, just single agents. But all agents now are available via a nebulizer. So in terms of which to choose for your patients, older adults and those with dementia can rarely perform correct technique without direct supervision and coaching. And given cost and resource availability, ideally, maybe most patients would be on a nebulized therapy for all their medications, but as there are no combinations, that can be very time and labor intensive. So likely an MDI with spacer is the ideal first choice over something like a dry powder inhaler. And if patients have ongoing dyspnea despite this MDI with spacer approach, then transitioning to a nebulizer is probably the next best approach. And again, same with if they have ongoing exacerbations. In terms of smoking cessation has survival benefits, even if you're doing it after age of 80. Adults over 65 are generally less likely to smoke than younger adults. We found probably a survival kind of bias there. However, although we've seen rapid declines in smoking among younger patients, older patients have not had similar declines. And we do find that older adults are less likely to stop smoking or attempt smoking, but that doesn't mean we shouldn't be trying this population. And then older adults are more likely than younger adults to successfully quit with nicotine replacement therapy alone, which avoids some of the psychiatric side effects of other agents, and it's worth a trial. among patients who don't have any contraindications to varenicline, because that's our most successful agent. So in summary, COPD is extremely common among adults in nursing homes, often undertreated. There are a mix of pharmacologic and non-pharmacologic therapies that are effective in treating symptoms. Overtreatment with inhaled corticosteroids, for example, can have health consequences. So it's important to recognize when de-escalation is appropriate. And the choice of the device, matters a lot in this population, potentially more than in our younger patients. I just want to say thank you. I believe there are time for questions at the end. Yeah.
All right, thank you so much. Ooh, my. All right, next I'd like to introduce Dr. Sanders-Cepeda, who is the Senior Medical Director for United Healthcare Retiree Solutions. She has expertise in behavioral health solutions, social determinants of health integration into clinical models, and post-acute and long-term care medical management and system development, and hospice and palliative care models. Please join me in welcoming Dr. Sanders-Cepeda.
Thank you. And thank you, Leslie, Singh, and Allison for inviting me and harassing me to get these slides in. I really do appreciate it. I know I broke a rule already being in Colorado with the water bottle. I'm sorry, this is my third state in 5 days. And yeah, and I don't know where my water bottle is. So there's a lot more crazy things. Plus I'm from Florida, so forgive all of the crazy. So, we're going to, Allison gave you a little bit so I could speed through my disclosure of being a United Health Group, United Healthcare employee. And to Mike's point about making you a little bit uncomfortable, I might make you a little bit more. So we're just going to lean into the discomfort and hopefully learn something on the other side, remembering that we're all learning together. And to just abbreviate the learning objectives a little, there is a lot of heavy lifting that I'm going to do in the next few minutes, where we're going to try to go through and really explain some things that we're seeing as far as implicit bias, racial disparities, health equity challenges, and all of the other things that we have to talk about. But where I want to start was with a statement that left me very uncomfortable a few months ago at our national meeting for AMDA. And the statement was, it was around us trying to think about if we need policies to help staff members feel more comfortable, more supported when there is situations that are difficult in the nursing homes, hearing racial statements and dealing with that. And one of the medical directors who was there, she mentioned that there's nothing we could do. And that haunted me. It has stayed with me since March, to the point that when Singh was asking for presentations, I'm like, I don't know what to talk about anymore. Because I don't know if we're even getting through and making an impact. Like, how do we transform, and what is that missing part of this equation? We're talking about diversity, equity, inclusion, but there is something that we're trying to get to, right? And that is what has haunted me for all these days, and where I'm going to probably spend the majority of our time today. So I'm going to start with saying that, yes, we did see a lot of racial disparities with COVID. It didn't start there. I think the first time I gave a presentation around racial disparities, I was 2 years out of medical school. That was in 2003. So that, it's been a while that we've been having the same conversation over and over again, talking about it. And what we've seen is that there are many things that we're seeing as a challenge, many issues, time and time again. This was from 2019. This came out of the American Health Rankings report, where they just showed how much disparities there were amongst African-American communities, Latino communities, indigenous people. And like I said, this predated anything that happened with COVID. If you did a literature search, you will see that we've been talking about this for a very long time. The problem is, what we haven't done is connected everything. If I had to tell you that systemic racism exists in healthcare, some people would push back. But what I want us to understand is that racial disparities in healthcare is the evidence that there is systemic racism in healthcare. What we saw with COVID, and I think as part of those social justice uprisings, we started talking about these disparities that we saw. So we saw in the nursing facilities that there were disparities when it came to facilities who were impacted with COVID outbreaks. We had more of those facilities who had higher populations of Black and Latino communities had higher rates of COVID outbreaks. That wasn't the only thing. They also had higher rates of death. So when we were looking sniff to sniff, everything controlled, what we kept and continued to see was these disparities. But what I'm going to share with you now is a nursing facility that had a different outcome in those early days of the pandemic. This facility in Maryland, in Baltimore, and a very much underserved area, very small facility, has some of the best outcomes in those early days throughout 2020 into 2021. And then when we rolled out the vaccine, they had some of the better vaccination rates. The difference with what they did and the way they approached their staff and the residents there was that they really cultivated a community where everybody was seen and everybody was valued. If that facility had issues with one resident, it was everyone's issue. Those staff members were really very much supporting those residents. And in turn, not only did they know the resident's name and the residents knew their name, when they needed to do some renovations to get up to code of what we needed to have around for COVID, the staff came in on days off. Think about your facilities. Who in your building would come in on a day off where they're not going to get paid? That community was different. That the challenges that they faced, they realized they were facing them together. That sense of belonging was the difference with what we were seeing in this building. And the administrator, the director of nursing, they all were giving podcast talks and conversations, and they kept saying that word community over and over again. And that's what I want you to keep in the back of your mind. How are we creating a community in our facilities? So when we're talking about addressing racial disparities, keeping in mind the community, the things that I think that come to my mind is this quote that Martin Luther King gave. And he said, of all the forms of inequality, injustice in healthcare is the most shocking and most inhumane. That was in 1966. When we look at the way we are practicing medicine, there are some things that have been ingrained into the clinical practice of medicine, into the way we've written policies and the way we approach patients of color. So the first thing we have to do if we're going to, as a community, get beyond this, is first accept one thing to be true, that race and ethnicity is a social construct and not a biological construct. 99.9% of all of our genetics is shared. And when we see the differences, it's really in how people have moved from place to place over time. So I probably have more in common with the people who my family grew up with in Georgia than anyone in Africa right now. Because we migrated and my family has been here since those early days of slavery. That's how we need to really think about what we're saying, okay, race and ethnicity. And I looked up the word race. Race means tribe, the Latin root, family, group of people, tribe. And we've put too much emphasis on that. Think about, and we talked, I think in the news, you've seen a lot of conversations around the kidney function studies and the kidney function tests, but there was also differences with PFTs and differences with osteoporosis. All of these things, there has a race correction factor in them. And now what we're seeing is that that person who should have been picked up when they were category stage 3 with chronic kidney disease may not be picked up until they're at the point where they need dialysis. The second thing for us to get over the racial disparities is to really start targeting social determinants of health. Those social risk factors that are so critical to how a person moves and access health care in this country. I think that a lot of people, you know, I tell my group as we're traveling across the country about food and how important it is to have food in your home and healthy food options. But we live with so many groups of people who are in food deserts, where the only thing that they have access to may be a fast food option. McDonald's, Burger King. I don't know, you guys are a lot healthier than the rest of the country, but Kentucky Fried Chicken. I said that in Kentucky, somebody lost their mind. I'm like, it's not healthy, guys. I'm sorry. But they don't, you know, you go, and I think about this for my own family. When we lost the grocery store in our neighborhood, we had to go 10 minutes away. We live in Fort Lauderdale. My family's home since my grandparents came to Florida is still there in existence in like midtown of the Fort Lauderdale region. All the grocery stores disappeared in the early 2000s. So to go to a grocery store, they have to go either east to Wilton Manors, west to another suburb. And if we didn't have people who were able to do that for our grandparents, the only other choice would have been a fast food restaurant. So when I've gone into people's homes and I'm asking them, why is your blood sugar 300? And I go through and I look at what they've had over the last few days, and they're telling me that they've only been able to go to Wendy's or McDonald's or Burger King. I shouldn't be shocked because there's no other options in their neighborhood. And then the third thing, and I'm on a soapbox here, so I apologize. The third thing is we have to create a culture of trust. The issue is, I can't get to the third thing if I don't address the first two. So this is one of my favorite slides. If you've seen it before, you probably have heard a talk. It really looks at how do we look at the race-based medical construct that we have now, where race is biological. We have formulas that do race correction. We're teaching in school that certain groups of people respond to pain medicine better or less because of their skin color, muscle mass, all of these things that are not true, versus a race-conscious medical format where we are really talking to that person and saying, you know what? I know that you live in an underserved area, and that means that I may need to deliver more resources to you. I may need to bring healthcare to your home or to your facility. And someone said, well, this is all corrected once they get into a nursing home. And I'm like, no. Those upstream challenges have downstream impacts. So if I have a person who's grown up in a neighborhood that's been disadvantaged year after year, then going to schools in an area where they were disadvantaged, now living in a neighborhood, still in a neighborhood where they're disadvantaged, what makes me think by giving them room and board in a nursing home that I've now changed anything? Those traumas stay with you. The distrust that you have in the healthcare system remains with you. Your habits around food stays with you. And now I have to deal with all of that, the whole picture. So if we could get and adopt a way of thinking where first we understand that race is a social construct, it means that we're going to be able to transform every element, the medical education, the way we approach research, and the way we practice medicine. All of these disparities means that we have to first target social determinants of health, those social risks. I don't know how many facilities look at where you're, not only are you accepting a person from, so, and I'm not just saying the hospital, I'm accepting it from this nice hospital, this is where they went. Where were they at before that hospital? Where are you going to discharge them to? I've had people who we've had to discharge in buildings, and I'm sitting around the table and they're saying, okay, well, we're going to discharge them to home. And I'm like, home, where's home? And they explain, well, they're homeless, so they don't have a home. So we're discharging them to homelessness. How many days do you think it's going to take for that person to go back to the hospital? We need to know the whole picture. And I think when you're talking about person-centered care, if you don't know the whole thing, the whole picture, every part of them, that we haven't practiced person-centered care. We need to see who we're treating, and not just in this little moment of time after they've transitioned 3 or 4 other spaces. So when I think about healthcare disparities and social determinants of health, I think about where do they live at? 50% of all the information that I need to know about what disadvantages they may have could come from their zip code, because it's going to tell me what was going on around transportation. You know, do they have access to buses? Do they have access to getting to healthcare? What is their housing situation? It is very different. I looked up my zip code on this one resource called Neighborhood Atlas from where I grew up to now. It is still the same, but it's bright red in the way that it lights up, because there's still those same disadvantages and those same lack of resources that exist. Your income level. You know, I was talking to someone earlier about the flooding that we had in Fort Lauderdale. If you go and you pull all those areas that are still waiting for gas and look, it had water levels so high, you will see a map of disparities, because those areas were the last ones to be addressed. The education and then food access, as I've talked about, it could tell you a lot. But how many times are we looking at this information when we're getting a person into the hospital, from the hospital? Boca Raton is one of the more wealthy places in Florida, right? People have heard of it, I'm sure. There's a hospital in Boca that everybody wanted all the residents from, but they didn't realize that the neighboring city was a city that was very impoverished, very poorly resourced. So then they're like, why are these people coming in so sick? And I'm like, because that's their 911 hospital. And so you're getting those patients into your building, and you went after this because you thought you were going to get the most affluent people in the Tri-County area, which was horrific as it is. But that was that strategy of that building. So when we think about equality versus equity, you know, it's not really an either or. It is a before and an after. If I want to get to equality, which is everyone being treated the same, then I need to first start with equity, which means that I've given the resources so that everyone can have the same result. When it comes to health equity, it means that I have now given everyone the same ways to access the healthcare system. So if they're in the rural area and they lack broadband, what am I doing to help to solve that? If they are in an area where they lack healthy food options, how do I solve that? And some people like, yep, like they said, like the question that haunts me, there's nothing I could do, right? But there is something you could do. You know, I work on a team where we were able to deliver 330,000 meals to people in their homes. We are able to look at the nursing facilities and say, what resources do they need, and then try to deliver resources to them. So I know it's not an impossibility, but before we could get to that equality where everybody gets a bicycle, have to make sure people can ride the bicycle. So what are we standing up? And I think about this all the time when it comes to our infrastructure, especially in post-acute long-term care. Because as I think of that continuum, I believe we said aging in place. How am I going to have a person transition back to a home where they have no food, they can't get care, they have no access to leave their home once they're there, there is no transportation? That is a person who will have a readmission. The science is there, the data shows it. That is one of the drivers of our readmissions. And then, if I had to think about this whole thing with our post-acute long-term care continuum and our facilities, what is the impact on our staff? Because they too have the same battles with equality and equity. They're facing wage inequities. We're seeing in our facility staffing shortages, and there's a lack of overall value, not only for the work that's being done in the facility, but sometimes when we're thinking about the way nursing homes rank amongst all other healthcare systems, again, to a point that Mike made, we are sometimes at the bottom of that healthcare lineup. So we have it coming from two different angles. So when we're thinking about how do we look at our healthcare system and how do we address this, we really have to think about how does everything intersect with each other? You know, for the patients and the staff in our facilities, they're just not one thing. You know, I'm not just a Black woman. I'm a woman who's a mother who may also be a career, a person who has a career. I may be the person who travels the most in my home. There are a lot of things that make me me, right? That's intersectionality, where you're thinking about all the things that that person now has to deal with. And as they're all dealing with all of those things, they're dealing with the bigger system. So I'm not just seeing one person with one issue. I may be seeing a person who has a multitude of things that makes them them. Why does that matter? Because when I'm asking you to think about how do we solve this and what we could do, we have to think about not only the lived experience that we're having, but what is it of our residents and of our staff? How do we line up? You know, I put this up and people get very upset when they see the wheel of privilege, but I dare you to go actually and get it. And I will make sure you guys have a copy of this so that you can fill it out for yourself personally. It is eye-opening. When I did it to learn all of my privileges versus those things that move me further away from the power. It is something that we should do because it's an exercise that helps us think about how do we relate to the people who we're taking care of, one, as well as to the people who are working with us side by side. And I say that to share this story. Back in September, the end of September, we had a Hurricane Ian, caused a lot of damage, especially on our southwest coast, but it also rolled up the state of Florida. And as it rolled its way up the state of Florida, in Orlando, we started seeing some severe flash flooding. And one story that hit the national wire was on a nurse who was then rescued by a reporter, because the reporter bravely waded into the waters. And I know people joke, oh, there's alligators, there really are these things that are in Florida. We do live with close to the wildlife. And there's also down power lines. So yes, it was very brave. But when I saw this story, I thought about that woman and I asked myself, what is happening with her? Why would she be out so early in the morning? And immediately I said, oh, she's a CNA. She has to be a CNA going to a shift at 4 or 5 o'clock in the morning. That's a CNA. And she was. But what was most impactful in reading her story was that she was fired because her car was flooded and she no longer had the transportation to get to work. That was not something that was part of the national news story. And that's where we get back to this missing part of the equation. Are we making people feel like they belong? Because if we can't see the whole picture, then we're not getting to the place where diversity plus equity plus inclusion equals the result that we need to have, which is belonging. And when we get to belonging, in the minute that I have left, I will say that is the place where people are being seen, and valued for what they bring to the table. For our residents, as well as for our staff, this is what we need to do. This is what it means to be inclusive. And to be a leader means that we need to be inclusive leaders. We need to be aware not only of our own personal biases, we need to be aware of the impact that they may have on others, that social awareness. And then we need to say, I'm not going to stay in this place. I am going to fill that gap and seek after understanding. And so with that, I leave you with, what will you do?
Thank you, thank you, thank you, thank you for that. I actually am feeling a little emotional. Thank you. We do have a few moments for questions. I'd like to open it up. Please come to the microphone if you guys have a question. We're all speechless then. No takers? All right, well. Oh, I thought you were gonna have it be a taker. All right, our next speaker has been working with elders since 1999 by becoming an administrator of an assisted living for 8 years. In 2007, she joined CDPHE as a surveyor for nursing homes. And after X number of years, so to not age my friend, she is now the branch chief for acute care and nursing facilities. Please welcome me introducing Joe Tansey.
Good morning. It's nice to be here. Sorry about my throat. My allergies are just out of control right now, so I do apologize for that. We've had some really great presentations this morning. It's exciting to be here. Mine's not one of those great presentations. I will tell you that. So when you talk about survey and you talk about survey programs at the health department, it's not really exciting stuff. So the mission for CDPHE and health facilities is to protect the health, safety, and welfare of every person that access the healthcare system. And we want to ensure that there's quality of care across the state. So I wanted to have this slide in here for sure, because as many of you know, if you've been here and in the state for several years, you know that the mission and the philosophy for health facilities is the REACH philosophy. And I feel like we have, that's kind of gone by the wayside in the last few years. And so we are really trying to push this and make sure that we, as a survey agency, do start focusing on this more in our interactions and our work with all the nursing homes, because we know how important and collaborative that is. And so, you know, Chad and I have made it our mission to start really working on this with the nursing home surveyors. You know, we have, I think, 13 new nursing home surveyors in the last few months. And so we really want to start emphasizing this again with them. Currently, there are 222 licensed nursing homes in the state. We actually, this says 3 closures, but we actually have had 4 closures. We've had Parkmore Village, Good Samaritan Bonnell and Greeley, Cripple Creek, and then Little Sisters of the Poor. We do have another one that has notified their residents that they're going to be closing, and that's Walsh Care Center in Walsh. So that's, you know, that's a really hard one because it is in a really rural area where there are not a lot of choices for those residents to transfer to. Also, last week, heard about another one contacted us to find out what the closure procedure is for, and this is on the western slope. So we are seeing more and more closures, I think, as we go on, and people are not seeing the relief that they need, and staffing. You know, especially in these rural areas where you have a small pool. Once people get tired and burned out, there's no one there to replace them. So it's unfortunate. So from January of 2022 to the end of January, end of 2022, we completed 129 recertification surveys. We completed 350 complaint investigations, and we completed 39 state complaint investigations. As you all, many of you know, we are still behind in our recertification surveys. I think we have about 54 that we've not been to for up to 3 years. So slowly we're catching up, but it is taking a considerable amount of time. So some federal updates. CMS is still requiring that we do that 20% of the nursing homes receive a standalone infection control complaint investigation. And we still are required to do the 20% staggered survey starts, where we go in the evenings, on a weekend, early in the morning. So we are still doing those as well. And CMS has identified these areas for special consideration: behavioral health, immunizations, language and communication, and an optional, when they go out with us and they see something, they'll pick an area for us to focus on. I do know that, you know, before COVID, CMS had created a little bit of a more collaborative attitude. And so, but since COVID, that has gone away. So, you know, we are being pushed really, really hard to make sure we cite everything we see. And, you know, I think you all have seen that, because we are citing a large number of deficiencies. They are being really scrutinized by the current administration and then Congress, because they don't understand why nursing homes are not improving. They don't seem to understand why we're citing the same deficiencies that we've cited for years. They don't seem to make a correlation between perhaps funding and care. And so, you know, they're trying to say, well, if you just go out there and add more penalties, fine people more, maybe that will bring them into compliance. And we all know that doesn't work, but that's a system that we are having to operate under at this point in time. So this is for all the survey programs that we have at CDPHE. And we did 123 initial inspections for fiscal year 2021. And then for 21-22, we did 133. For relicensure for this past year, we did 361 inspections. And for state, oh golly, okay, I thought I would have a lot of time because I don't have much information. So for state infection control inspections, we did 7. We had 5,505 occurrences. And we did 1,822 complaint intakes. So if for state enforcement, and this is state enforcement only. And remember, it's for all survey types, all facility types. We did, 153 fitness reviews, change of ownership. We did 154. Cease and desist, that's 3. I think, those are usually assisted living or home health. And appeals of nursing home discharges that appealed all the way to the department. We did 1 of those. For home and community, that's assisted living and home care. They currently have 4 openings in the program, for 3 RNs and 1 generalist. Assisted living has 9 open positions. And they're really working hard to try to develop a training program. And as you know, or may know, they have regular stakeholder meetings. Behavioral health, that has been a big project for us. Okay, I'm done. And so, but behavioral health is moving to the Department of Human Services. So that's great. Okay, well, I guess, thank you all.
So good morning. This is our last presentation of the morning, and it is kind of like a game show. So it's pretty fun. And you can play here, you can play at home, and we're going to get going. This is the year in review, lessons learned from the CMDA meetings and journal club. And let's get started. So on your tables or on the screen, if you're playing at home, you'll see QR codes for Poll Everywhere for the year in review. So you can scan that on your phone, and don't be concerned, you won't see much. You won't see much until I go after the first question. So your phone hasn't failed, you aren't in disarray, but hang in there with me. All right. So the rules of participation. CMS has rules of participation, and so do we. So we have 15 questions. Everybody can play. Use information on the slide on Poll Everywhere. 20 seconds per question. The faster you answer the question, the more points you get. We'll show the answers right after the question, so you won't have to wonder, what was that answer? We have some fun questions, and there are winners and prizes and bragging rights. So, you could earn some cash here. So, all right, here we go. All right, so you should see maybe the year in review on your phone, but hang in there with me. All right. So question number 1, you're not going to see anything on your phone yet. The critical element when obtaining informed consent is ensuring the patient has decisional capacity. Which of the following is true about decisional capacity? A, it requires a mental health professional like Lea Watson. B, it's absent when someone is cognitively impaired. C, is always only about a specific decision or circumstance. C, is not fluid over time or context. Or E, is absent when someone has a guardian. So you should see it right now, and we have 15 seconds on the clock. Oh, yep. There's no pressure. Okay. All right. And so we're going to track you guys. And so a lot of you did very well. And the answer is, it's always only specific to one decision or circumstance. Okay. So our leadership board, we have a lot of leaders. Galen, yay. And Lisa. Okay, let's go on. Question number 2, which statement helps to explain why having a high IQ is not enough to promote effective team leadership? A, state regulations require that residential care facility leaders demonstrate evidence-based leadership style. Hard work and IQ are the best predictors of successful medical directors and directors of nursing. The uniquely important part of a team leader's role is their responsibility to set the emotional tone for the team. Or Daniel Goldman wrote about this in 1908, quite a long time ago. All right. So you have 16 seconds. We don't have the Jeopardy thing because you had to pay for that so yeah. Okay. And, 82%, well done. So this is the answer. It's uniquely important for part of the team leadership role is their responsibility to set the emotional tone for the team. All right, we still have a lot of leaders. Okay. Karen Leibel. All right, question number 3. Treatment of superficial venous thrombosis should be considered for which of the following? Saphenous vein, history of VTE or SVT, cancer or recent surgery, or all of the above. And the clock is ticking. Okay. Do. Okay. 5 more seconds. And all right. Wow. You guys did really well. And the answer is all of the above. All right. Galen is doing awesome. Okay. Question number 4, a TSH result of 0.3, and you can see the range right there, in a patient who is not currently receiving thyroid medication should prompt you to do which of the following? A, immediately start methylmazole 5 milligrams q.day and titrate for a TSH 4 to 6. Perform a thorough, detailed physical exam to determine if the patient has signs of treatable causes of hyperthyroidism. Order a free T4 and a total T3 levels, or both B and C options. All right, 17 seconds on the clock. All right, 5 seconds left. Wow, everyone did great. Okay, let's see. The answer is to perform a detailed physical examination, and you can also order a free T4 or total T3. Okay, Galen is still forging ahead. Okay, this is a funny question. Why should you never lie to your X-ray technicians? Anyone? Okay, because they can see right through you. Okay. Number 6. All the following statements regarding hypodermolysis are true except mild to moderate dehydration from nausea, vomiting, dehydration, or poor PO intake is an acceptable indication for this treatment. B, infusion site should be changed every 12 days on the nose. Number C, the preferred fluids for hypodermatolysis include isotonic solutions such as normal saline, D5 normal saline, half normal saline, or lactated ringers. Approximately 3 liters of fluid can be given in a 24-hour period using 2 separate infusion sites. Okay, make your best guess now. Okay, 5 seconds left, no pressure. And all right, wow, people did great. Okay, let's see. So the infusion site does not have to be changed every 12 days, but you need to monitor it every day, and that's really essential. Okay, Galen, I'm voting on Galen. Okay. Question number 7, which of the following forms of hyperthyroidism will not respond to the treatment of methylmazole? Graves' disease, toxic multinodular goiter, drug-induced hyperthyroidism, or none of the above will respond to treatment with methylmazole? And the clock is started. 9 seconds left. Okay. All right. Wow, people are still doing really well. Okay. And so the answer is drug-induced hyperthyroidism. And, well, things are shaking up now. But Lee is coming on strong, and Emily and MJ. All right. And Alicia. Okay. Question number 8. Prophylactic use of aspirin to prevent cardiovascular events is recommended for which person below? And this is a new recommendation coming out. A 76-year-old woman with high cholesterol, hypertension, and smokes, no history of MI. B, a 65-year-old obese man with diabetes, no other medical issues, and a non-smoker. C, a 55-year-old woman with peripheral vascular disease and hypertension. She had an MI 4 years ago. Or D, a 65-year-old man who has hypertension and a history of MI 4 years ago, but unfortunately, he's now on hospice for metastatic small cell lung cancer. All right. This is a tough one, I think. Okay. 10 seconds left. Remember, there are big prizes. All right, 64%. Well done. Okay. It's the 55-year-old woman with peripheral vascular disease and hypertension. She had an MI 4 years ago. This is secondary prevention, and that's when we're using aspirin. Also, the references for every answer is at the bottom of the slide in red, and you'll have these answers for you at the end of the conference. Okay. Oh, Alicia is moving up fast. Okay. Galen, I'm concerned for you. Okay. Question number 9. A subsegmental PE without a DVT does not require anticoagulation. Is this true or false? Top one answer is going to be on the board. 10 seconds left. Okay. Wow, you guys did great. Okay, the answer is true. And, oh, Galen is still holding on to number 1. This is a fun question. Why did the pharmacist walk quietly past the med cart? She didn't want to wake up the sleeping pills. Okay. Thank you for all our pharmacists that are joining us here today. We are so grateful to work with you. Of course. What percentage, number 11, what percentage of female nursing home residents have asymptomatic bacteriuria? And we know that this is really common. Is it 15%, 25%, 50%, or 75%? Make your best guess. This is really important to know. Okay, 10 seconds left. Okay, wow, 46%. Well done. 50% of females and 40% of males who reside in nursing homes will have a positive UA every time you test them. Think about that. Okay, we're going to go along to question number 12. Oh, and Galen is hanging in there, but both the Jennifers are sneaking up. Well done. Question number 12. Which of the following factors is not included in the newest version of the Simplified Pulmonary Embolism Severity Index? And this is a really good thing that we should consider when we're thinking about PEs. Is it a D-dimer, a history of cancer, age, or vital sign readings? Make your best guess. I have to say, because Galen wrote some of the questions, I'm not really sure he can win. We may need to vote on someone else. Okay, we have more than one prize. Okay. All right, you're correct, D-dimer, but there was a plethora of ideas here, but D-dimer was not included in this index. Okay. Okay. Jennifer and MG and Emily are sneaking up. So number 13, effective antibiotic stewardship programs include all of the following except a team approach, educating frontline staff, nurses, and providers by using antibiotics judiciously and the harms of antibiotics when they are not needed. B, giving feedback to providers and nurses about when to order a UA so you don't get that aseptic bacteria. C, educating providers and nurses about the appropriate length of antibiotic treatments for different infections and monitoring the patients after antibiotic treatment. Or D, promoting the use of Levaquin and Cipro for treatment of UTIs, as they are always very effective and very few side effects. Okay, go ahead. I feel like this was an easy one. All right, 10 seconds left. Okay. Wow, 96%. Well done. Okay. Using fluoroquinolones like Levaquin and Cipro are not recommended in older folks as they have many side effects, including mental status changes, which we often forget about. So pick something else. And besides Galen, we have Jennifer, MG, and Emily, and Bobo. We're doing well. Okay, we're coming around the bend here. When does the CMDA, the Colorado Society for Post-Acute and Long-Term Care Medicine, who are they, meet monthly, and why? Is it the third Tuesday of the month to see the new medical fashion attire? Is it the fourth Thursday of the month to hear Dr. Eber's dogs barking in the background? Is it the first Tuesday of the month to hear the latest standard of care in post-acute and long-term care medicine and updates from people like Joe at CDPHE and people like Jenny at CHCA, who we are both so grateful to partner with? Or is it the second Thursday of the month to practice muting and unmuting on Zoom? Okay, another difficult question. 10 seconds left. Okay. I'm looking for 100% here. Let's see. 95. All right. First Tuesday of the month, 12 to 1 o'clock. Email Dr. Palat, myself. We'll send you the email link. We'll put you on our email. Come in here for 1 hour a month, the standard of care for post-acute and long-term care medicine. And you get to hear from Chad and Joe and Jenny as well. Okay, we're going to ignore Galen now, and we're going to concentrate on Jennifer, MG, and Emily. Okay, number 15. When should gender-affirming hormone treatment be discontinued? Should be discontinued, can be discontinued after age 65. GAHT dosing should remain consistent throughout life, with only dosing adjustment for renal function. GAHT is generally continued lifelong. However, for transgendered women's age, their VTE risk increases. And so use of estrogen patches only is favored in transgendered women who are above 50, or GAHT can be discontinued once the patient is no longer sexually active. And we have a wide variety of our patients. I'm so happy about this question. So it's important information to know. We have 10 seconds left. And all right, let's see what the answer is. Okay, and that's correct. C. GAHT is generally continued lifelong. However, with transgendered women, their VTE risk increases, so using estrogen patches only is favored in transgendered women who are above the age of 50. So, hey, Jennifer and Emily. Woo! Okay, so if we perhaps have a tie break, we have a tiebreaker question. Are you ready? Okay, this is the tiebreaker. Who is the only person, actually one of the only people, there are actually more than one, but only one person on this list, who has been the president of both CMDA, the Colorado Society for Post-Acute and Long-Term Care Medicine, and AMDA, the National Society for Post-Acute and Long-Term Care Medicine. Is it Bill Solomon, Carrie Levy, Fred Feinsod, or Dr. Singh Palat? Okay. Oh, goodness. Okay. And also Karen Leibel, but you can choose any one of these. So we had changed this earlier, but it didn't take. All right. But do your best guessing. We have 3 seconds left. All right. Wow, 40%. That's correct. Dr. Carrie Levy and Dr. Karen Leibel, actually, they both were president of CMDA and AMDA, and we are thankful for their leadership. All right. Okay, so let's see that leadership. Wow. Jennifer, Bobo, MG, congratulations. Let's give a shout out to them. And we wanted to also give a shout out to Dr. Greg Gom, Travis Neal, Dr. Singh Palat, and the CMDA board, and all the presenters of Journal Club and the monthly meetings throughout the year for your education, your expertise. We are smarter and better because of you. Thank you.
So I just want to let you know lunch is here and we do have gluten-free and vegetarian, the furthest away from the registration desk. The lids sometimes fall off, so just be careful when you pick them up, but enjoy lunch.
Number 12 is the one that says CMDA telecom.
Thank you very much.
Right, right. Hi there. We're going to get going in about 2 minutes, but you are free to eat as we learn. Not yet. Not yet. Mhm. Okay, good afternoon, everyone. We are so excited and incredibly lucky to have this next presenter join us. So if you all settle down, we love the fact that you are talking and bonding with each other. We have an incredible community. But I want to introduce you to our next speaker. We couldn't be more lucky. Alan Horowitz is an innovative healthcare lawyer who's handled complex regulatory issues concerning Medicare providers such as skilled nursing facility, hospices, and home health agency. Alan is also a registered respiratory therapist and registered nurse. He served as the Assistant Regional Counsel for the United States Department of Health and Human Services. So he has some experience on both sides. The Office of General Counsel. He worked closely with and litigated cases on behalf of CMS. Currently, he's counsel to providers. Alan has successfully negotiated and litigated significant cases against CMS as well. He has co-authored and co-edited the Post-Acute Care Handbook, Regulatory Risk and Compliance Issues, and has been a profound advocate for both our patients and all of us. I am incredibly honored to call him my friend and introduce Alan Horowitz.
And thank you very much for that very generous introduction. And I just want to say that I am truly honored and privileged to be here and to speak with you folks today about medication errors in the law. There are a fair number of slides, so I'm going to talk faster than I usually do. After the presentation, if there isn't time for Q&A, my email address is on the presentation, and I'm certainly available to answer or to try to answer any questions you have. So with that, let me get started. And there are a couple of learning objectives, and among them are to understand both mandatory and voluntary reporting systems as it relates to medical errors, to appreciate what I suspect all of you already know, that medication errors or medical errors, medication errors being a subset of medical errors, are generally the result of flawed systems, not an individual practitioner. Explore how we can learn from near misses, and we'll talk about a system that the FAA introduced years ago, which is very effective and incorporates near misses. We'll talk about 2 criminal trials where a nurse was charged with criminally negligent homicide involving a medication error. In one case, the nurse was found guilty, in the other case, not guilty. And we'll talk about what I think led to the not guilty verdict. In both cases, it was an unfortunate patient death. And finally, I want to talk about something that I think is germane to you, the Colorado apology law. Just by a show of hands, how many of you are familiar with Colorado's apology law? Okay, great. Well, you all will be by the end of this. And just a precursor, there's good news, very good news. There are a number of definitions of medication errors. This is just one of several that are generally accepted. And the point here is, even if there isn't a negative outcome, it is considered a medication or a medical error. There doesn't necessarily have to be an adverse outcome. Preventable errors are more common in older adults, and I think we know that. And we'll see some statistics from OIG regarding the prevalence of adverse events in skilled nursing facilities. But how big is the problem? And I think everybody here is familiar with the landmark IOM report from 1999, which concluded that 44,000 to 98,000 deaths each year result from medical errors. At the time this came out in 1999, I worked for the Institute of Safe Medication Practices as Director of Clinical and Legal Affairs, and we were given a draft copy to comment on. One of the principal authors, Dr. Lucian Leap, said that the group that at IOM actually understated the extent of the problem. Some years later, the Leapfrog group published their results in the Journal of Patient Safety, and they estimated that there are 440,000 deaths a year that are avoidable. According to a more recent BMJ study, there are more than 250,000 deaths due to medical error in the United States alone. So again, the problem is huge. Unfortunately, it has not gone away, and we haven't made significant changes since the 99 landmark IOM report. Focusing more specifically about in terms of SNF, and this actually is the same report that Dr. Wasserman used. This was from an OIG report in 2014, which indicated that 22% of the Medicare beneficiaries in SNFs experienced adverse events during their residency. 59% of those events resulted in temporary harm and were likely preventable, according to the OIG. So again, it's not just a universally common issue, but it's particularly important in the patient population that you care for so well. So is there a disconnect? I included this because I think it's an interesting study. This was a study of 2,600 physicians from the US and Canada, and 98% of the physicians that responded indicated that they fully supported and endorsed disclosing patient errors, yet only 58% made full disclosure. So there seemed to be a disconnect between what physicians in this study believed is the right thing to do and what their actual practice was. And I mentioned the FAA, which is the Federal Aviation Administration, and they started the Federal Aviation Safety Reporting System a number of years ago. We in the medical community can learn a lot for this. This is actually a non-punitive system. It was designed by NASA, which has no law enforcement or no enforcement capabilities. It's completely voluntary. Pilots, flight crews, other workers involved with airline transportation can report not just an event, even if there's no adverse outcome, but near misses. And of course, pilots and flight crews have a vested interest. If they see that there's a systems problem, they don't want to be on a plane that has that problem and go down with it. So again, this some of the focuses of the FAA system is on human engineering or human factors engineering, which is a huge plus in patient safety movement. Because again, as we'll see in a few seconds, it's not an individual physician, pharmacist, nurse, that's the result of a medical error. It's a flawed system. Almost always it's a flawed system. So there are mandatory and voluntary disclosure requirements. There's a federal regulation that I'm sure you're all familiar with that deals with skilled nursing facilities. And that indicates, that states that a facility must immediately inform the resident, consult with the resident's physician, and notify, consistent with his or her authority, the resident's representatives, whether it's a guardian, a POA, or the responsible party. So let's say there's a medication error and there's an adverse event for a resident, not just the physician, but the family has to be notified. So that's clear. And some people feel this doesn't go far enough because this particular regulation at 42 CFR Part 483 only requires notifying the physician and the family when there's an actual change in a significant change in clinical condition. So if it's a near miss, there's no reporting in this instance. I want to talk briefly about the two medication errors that led to guilty situations. The first one, you may recall from a little more than a year ago, March of last year, where a nurse at Vanderbilt University Hospital was giving meds and she was outside the patient's room. The physician ordered Versed. She keyed in VE in the medication cart. Nothing came out. And the nurses at Vanderbilt University Hospital had the ability and in fact often would override the system. So she overrode the system, keyed in VE again. Versed didn't come out. Vecuronium did. She gave the Vecuronium and unfortunately the patient died. She lost her job, she lost her license, and she was found guilty. She had a suspended sentence.
I personally think that was unfair. I actually contacted the attorney that represented her and offered to speak with him because again, there was a systems problem. Should the nurses at that medical center have the ability to override what's a potent neuromuscular blocker doing on a med cart for nurses giving out meds unless it's in an ICU or, why would that be any place other than an operating room or an intensive care unit where you've got or a patient on a ventilator, and this clearly wasn't the case. The other case actually was a case that ISMP, the Institute for Safe Medication Practices, was involved with. And this was a tragic case actually that came out of Denver a number of years ago. It was at the time Centura St. Anthony's Hospital here in Denver. 3 nurses were charged with criminally negligent homicide of a newborn baby. And I'll go through the details quickly. Well, that's the nurse, unfortunately, who lost her license and was convicted of criminally negligent homicide in Vanderbilt University's situation. So here's the Denver nurse situation where 3 nurses were charged with criminally negligent homicide. And by the way, Institute for Safe Medication Practice does not provide defense work typically, but Michael Cohen, the founder and president, felt so strongly against the criminalization of medical errors that he agreed to testify for the one nurse who pled not guilty. The good news is the jury agreed. And here's why, and this is what Michael pointed out at the trial. The order was for penicillin G benzathine 150,000 units IM. What was given was a 10-fold increase, and to add to that, it was given IV instead of IM, and the baby quickly went into cardiac arrest. So here are some of the latent, by the way, ISMP found and documented 51 discrete errors involved with this poor infant's death. 51 errors, yet criminally, only the 3 nurses were charged with criminally negligent homicide. All 3 lost their license. The one that pleaded not guilty, it's gone around the country the last couple of decades talking about medication errors and how they shouldn't be criminalized, particularly since it's a systems problem. Here are some of the problems. The penicillin G benzathine was a non-formulary drug at that hospital. Drug facts and comparisons that was used. The pharmacist misread the dose of both sources, hence the 10-fold increase. Instead of the 500,000 units per kilogram, which would be a typical dose, the dose for newborn is 50,000 units per kilogram. So we have a 10-fold increase. Because of the increase in volume, the pharmacist dispensed this in 2 3C syringes. It's brought to the pediatric ICU. And the nurses were concerned about giving such a high volume of a medication to a newborn. The newborn had a peripheral line, and so they consulted a nurse practitioner, a pediatric nurse practitioner, who checked with one of the drug reference books in the unit and said it's fine to give this IV. So now the total dose, which was, as I said, a 10-fold increase, was given IV, and predictably, the infant died. Unfortunately, by the way, the syringes indicated, so there's fault for everyone, including the manufacturer. There was on the syringes, it said in small print on one side, do not give intravenously. It wasn't in bold type. I mean, so the labeling of the syringes could have been better. The drug monographs that were used, both in the pediatric ICU as well as in the pharmacy, could have been better. Again, while preparing for the drug administration, neither nurse noticed the 10-fold overdose. Neither noticed that the syringe was labeled by the manufacturer IM use only. And as I mentioned, that was very small. That wasn't very prominent as it could have been or should have been. They had to turn the syringe 180 degrees to see that. So unfortunately, this was a systems error. There are actually more errors. I'll just mention one other one. Unfortunately, the mom never needed this. The reason that the penicillin G benzathine was ordered in the first place, the OB that was covering, and this was a mom who came in for a normal vaginal delivery, the OB was covering her. She had a history of an STD, but that was more than 10 years ago. So she never even needed this drug. I mean, compounding
a series of errors. Here's a situation where the covering OB didn't realize that, well, the STD it's in her history, but yeah, that's more than 10 years ago. We don't need to give her penicillin G benzathine. So again, you can see, and I've just mentioned about 5 or 6 of the errors. There were actually more. We don't have time to go through all 51, but the point here is that it's a systems problem. It wasn't the fault of just the nurse. It wasn't the fault of just the pharmacist. The pharmacy should have had a computer system that would have flagged it because it was a 10-fold increase for a newborn. So in this case, the argument of the defense counsel was it's a flawed system. Don't blame the nurse. And by the way, you didn't charge the pharmacist or anybody else or name the hospital as a defendant. And the jury accepted that, and the nurse was found not guilty. So switching gears, because I'm obviously a proponent of full disclosure. I don't believe in the criminalization of medical errors, whether they're medication or otherwise. I think that's counterproductive. I think what happens, and it's human nature, when we see high profile cases like the case out of Vanderbilt University over this last year, I think it drives disclosure underground. People are less willing to come forward when they think they could lose their license or end up in jail. So is honesty the best policy? I think so. As I said, full disclosure, compensation is appropriate. Extreme honesty, which is a policy adopted by the VA hospital in 1987, works. And I'd mentioned, and this is one very good takeaway is Colorado's apology laws, and we'll talk about that. A number of states have apology laws, which statistics indicate have increased physician apologies, expedited claim resolution. And this may be counterintuitive, but it's actually decreased the number of claims and payments for malpractice claims. There are few authoritative studies about apology laws and their effects. I want to mention Candor, which is the Communication and Optimal Resolution Program. MedStar started this a number of years ago, and what it involves is engaging patients and families with full disclosure following an adverse event, implementing a care for the caregiver program for the providers, because as you can imagine, if somebody thinks they were responsible, particularly for a patient or resident's death or serious harm, that has a potent adverse effect on the caregiver. Candor recognizes the need to investigate and analyze adverse events, to learn from them, review and revise organizational processes, and establish a program of restitution or fair compensation for injured patients. According to Candor, MedStar saved an estimated $70 million between 2012 and 2017 by reducing costs related to patient safety events, including medical liability payments. And they went on to say that the programs have reduced their medical liability because the most important thing about Candor, besides open and honest communication, is that there's a requirement for learning. It does seem to work. MedStar saved, again, in that 5-year period, they saved $70 million. Similarly, the University of Michigan health system has a full disclosure program with compensation. And just some of the statistics from the University of Michigan health system, after full implementation of their program, their monthly rate of new claims decreased. The average monthly rate of lawsuits decreased. The numbers are on the slide. Median time from claim reporting to resolution decreased. The average monthly cost rates decreased for total liability, patient compensation, and non-compensated related costs. And since implementing the I'm sorry strategy, malpractice claims against University of Michigan health system fell from 121 in 2001 to 61 in 2006, which represents about a 50% decrease. Again, it almost seems counterintuitive that by making full disclosure, you're actually going to see less claims, and patients and their families are less likely to sue. It's always when people feel, well, there's a cover up, you're not telling me what really happened, that drives up the plaintiff's attorneys more than if somebody sat down and offered an apology, which by the way, can't be used in a court of law in a malpractice case here in Colorado and in 35 other states. I want to just briefly touch on University of Michigan health system again and other adopters of communication resolution programs that, again, at the same time that they're reducing liability, they're improving patient safety, because with full disclosure, the organization can look at the systems that allowed the medical error to occur in the first place. So how does Colorado treat admissions of errors and apologies? Here's a Colorado statute in the Colorado Code, and I just pulled a quote, so I'll read it briefly. In any civil action brought by an alleged victim of an unanticipated outcome of medical care, or in any arbitration proceeding related to such civil action, any and all statements, affirmations, gestures, or conducts expressing apology, I'll just skip to the end. The bottom line is anything you say in terms of an apology or condolences, and I'll read the important language at the end as it relates to legal liability, shall be inadmissible as evidence of an admission of liability or as evidence of an admission against interest. So this Colorado statute protects any licensed healthcare practitioner in Colorado who meets with a patient or the patient's family or a resident's family and says, I'm sorry about what happened. That can't be used against them if a malpractice or negligence or wrongful death action is subsequently filed, and that's prohibited by statute. There's a similar Colorado Act, which is the Colorado Candor Act. And again, just dropping down to the important language at the bottom, it's all important, but the point I want to make is candor is designed to facilitate open communication. And again, everything that's said by the clinician to the resident's family is confidential. It cannot be used in any litigation. I mentioned the VA hospital earlier. So in 1987, the VA hospital in Lexington, Kentucky adopted a policy called extreme honesty, and they decided for any medical error that occurred at the VA hospital in Lexington, Kentucky, they would practice extreme honesty, make full disclosure, and where appropriate, offer reasonable compensation. Again, this seemed pretty radical in 1987. Well, the VA hospital found that they actually had a reduction in their claims as a consequence of this policy. And it was so effective at not just reducing claims and liability and avoiding a lot of litigation, but it actually enhanced patient safety because there was an incentive to make full disclosure that the VA hospital, VA administration adopted this policy for all of its facilities. There is a handout, a VA policy handout. It's probably about 20 pages. It's referenced in this slide. It's their directive 1004.08. It is pretty much a roadmap. And if any of your organizations are considering, if they don't already have a formalized process for reporting, making full disclosure, I would highly recommend this. It doesn't have to be a cookie cutter approach, but it's an excellent, excellent guide. I mean, they spent from 1987 to the present to draft this, and it provides for every step along the way how what best practices in terms of disclosing adverse events. The Patient Safety and Quality Improvement Act is actually the first federal legislation that makes certain information, certain reporting privileged and confidential. That is, if your facility were to report it to a patient safety organization, I can spend a day talking about this. This only applies to patient safety organizations. In my experience, most of the nursing homes around the country, most of the chains or regional chains or small operators do not contract with the PSO. The primary audience seems to be the hospitals, although it might be worth considering. The Patient Safety Network is a valuable resource, which is why I included here. It's sponsored by AHRQ, the Agency for Healthcare Quality Research with operating division within HHS, and it's the valuable tool. It has a ton of resources. And I want to close briefly by just mentioning the ethics involved with self-disclosure. The American College of Physicians Ethics Manual states that physicians should disclose to patients information or about procedural or judgment errors made during care, as long as such information is material to the patient's well-being. Errors do not necessarily imply negligent or unethical behavior. And here's the part I like, but failure to disclose them may. And the AMA's Code of Ethics similarly states that situations occasionally occur in which a patient experiences significant medical complications that may have resulted from the physician's mistake or judgment. In these situations, the physician is ethically required to inform the patient of all the necessary facts to ensure understanding of what has occurred. So again, there's an ethical obligation apart from the legal obligations, and it does, again, I know I'm repeating myself, but full disclosure and apologies do seem to work. Sincere expressions of condolences. I mean, there are any number of studies
that show when a physician or other members of the healthcare team sit down with the patient or the patient's family and say, I'm sorry, here's what happened. And there's sincere remorse. Mistakes do happen. Again, they're not the fault of an individual practitioner. They're almost always the fault of a flawed system, as we saw with the Denver case and the newborn baby who died. There's something called the Sorry Works Coalition. This is actually a nonprofit organization. It's comprised of, believe it or not, doctors and lawyers. We do get along. Insurers, go figure. And patient advocates. And the Sorry Works Coalition is dedicated to promoting full disclosures. And by the way, they lobby state legislatures. There's only 36 states currently have apology laws. So they're lobbying, and they've been involved with, many of the laws that state legislatures have passed dealing with apologies. And according to the Sorry Works Coalition, if a standard of care was not met and there's an adverse or negative outcome, they believe that providers or their insurer should apologize, admit fault, provide an explanation of what happened, and how the hospital or other healthcare facility will ensure that the error is not repeated, and as appropriate, offer compensation, particularly in case of death. The Sorry Works protocol is based on the landmark disclosure program from the VA hospital. And again, I think it's worth looking into for your organizations. And I want to just close by saying there are a number of resources that I put together and on the next two slides, and actually the next three slides, just it's an occupational hazard to include so many resources. So again, thank you for all of you that you do. You guys are the real heroes. And I'll be around, or email me if you have any questions. And thank you again for your, for everything you guys do.
Thank you so much, Alan. I think that we have one question. And so we'll take one question and then we will break for a break. Go ahead.
So I've noticed since the pandemic that there has been problems with some of the ancillary services coming into facilities, particularly lab, not always showing up on days that they say they're going to, or being consistent, as well as for x-rays. Who would be responsible if there was a delay in care if the lab doesn't show up? Is it facility, the provider, or the lab, or everybody?
Okay, so that's an excellent question. And in case anybody didn't hear it, who would be responsible if a ordered service, a lab or other diagnostic procedure was not done as ordered? If the facility contracts with a particular lab service and they don't show up, and they repeatedly try to have that service show up, depending upon what's involved, if it's important blood work that you order for one of your patients, and the phlebotomist that works with the agency didn't show up, the agency can't contact anybody else, and you've explored all possibilities with that particular company or that particular vendor. Obviously, documenting everything, documentation is always going to be the key from a legal perspective. What alternatives did the facility explore? Were there other vendors that could have come in an emergency? I actually worked years ago in 1990 as in-house counsel for a facility, and there were times, and we had a 32-bed ventilator unit. There were times that we couldn't get certain equipment we needed for a ventilator from our vendor. And I would have the director of respiratory therapy contact another vendor. So the short answer is document everything all along the way. If you've explored all possibilities with a particular vendor, then obviously try to find another vendor who could provide those services, whether it's x-ray, laboratory work, or anything else. It's a great question. If the facility did not do those things, if they didn't act diligently, which was to determine alternatives, then there could be potential negligence on the part of the facility. If the facility did everything reasonable and appropriate to try to get the services in, that's defensible, and it would be beyond their control. Great question. Thank you.
I have to have my cheat sheet over here. So we are going to take a break please come and visit with each other, visit with our vendors, enjoy. We will see you back here at 12:55 for incredible presentation and the rest of our afternoon agenda. We're so grateful that you're here. Enjoy each other.
Thirsty anyway. On, can you hear it? Hello, everyone. Welcome back from lunch. Hope you enjoyed your lunch and your time for chatting. We are going to welcome our next speaker now. Thank you. Please take your seats. We're going to welcome Dr. Carrie Levy as our next speaker. Dr. Levy is currently the Division Head of Geriatric Medicine, Director of the Multidisciplinary Center on Aging at the University of Colorado, and Section Chief of Palliative Medicine at the Rocky Mountain VA Medical Center. And many years ago, Dr. Levy was the first person to welcome me to Colorado, or at least convinced me that Colorado would be a wonderful place to practice geriatric medicine. And just a few short weeks ago, Dr. Levy's choir sang at Carnegie Hall. So interesting. Please welcome Dr. Levy.
A little known and fun fact, and as did James, wherever James is, yes, we sang together at Carnegie Hall. And if you'd like us to sing, we'll be happy to today. So thank you for having me. It's always so fun to be with this group. And the topic today is do not resuscitate in the nursing home. And I'm just going to start with an excerpt from a book I recently read by David Sedaris, who many of you probably enjoy, fantastic writer. And he wrote a book called Happy Go Lucky. A lot of it has to do with COVID, and which I didn't know. Topic Happy Go Lucky. You think, oh, a happy book, this is what I need. And it starts with COVID. So beware of that if you decide to read it. But there's a portion in there where he's talking about his father, and his father is in a nursing home, and it's during COVID, and he knows that the facility's on lockdown, they're having an outbreak, and he gets the call that his father's not doing well. And so the nurse, I think there's a series of calls, but the nurse calls and says, your dad's really declining. And his response is, do something. And her response is, but he's DNR. So I just want to set that stage because it really does sort of pull a lot of what goes into these conversations together. And we can come back at the end to whether or not that was what that response might have meant to David and what the nurse was trying to communicate there. But we've all had that experience. And so we're going to talk a little bit about prognostic implications of resuscitation in several settings. We'll talk about stability of DNR orders. If somebody comes into the nursing home with, let's say, a full code order, do they continue that through their stay? Proper use of DNR orders in most forms. And then the utility of decision aids. And I have some here on the table if you would find that helpful. So I just want to start by acknowledging that this is hard. And I think we often feel a lot of emotions around these discussions. And in this conceptual framework, you'll see do the right thing is in the middle. And then there's a lot happening in those domains around the do the right thing. We've got a responsibility to protect and advocate for our residents. There's goals that our residents have. Some of them want to maximize comfort. Some want to have a peaceful and natural death. Others want life at all costs. We have our emotions wrapped into that as well, where we wish to do right by our residents. Then we have outcomes. There's emotional distress when you are the one performing CPR on one of the residents you've cared for a long time. There's emotional distress family might feel either by doing CPR or not doing CPR. And there's lots of factors that are woven into this entire conversation. So I want to set the stage that this is emotional and it's complex. And my hope is that you have some additional data points as you're navigating these difficult conversations, sometimes difficult conversations. So I want to start by just acknowledging that we really should only be having these conversations with folks who have capacity to have this conversation. Capacity is not competency. As you heard earlier, and as was part of the quiz, capacity is the ability to engage about this topic. And so for DNR conversations, that might include, can the resident communicate their preference for or against resuscitation? Do they have an understanding of what that means? And these decision aids are somewhat helpful in that regard, because it talks about you really have to compress the chest enough to manually push blood out of the heart so that it will hopefully circulate to vital organs like your brain and your kidneys. And so that's part of CPR, and folks need to understand what that actually involves. There's electrical shocks sometimes involved, and then often large IVs that are placed for medications. They also need to appreciate that if their heart stops, there's more than one choice. We can allow a natural death, or we can proceed with resuscitation, and how that will affect them directly. And then they need to be able to rationalize this decision and reason that they understand the risks and the potential benefits. And if you can have that conversation and feel like this is an informed decision, your job is done. Your emotions may not stop, but your job is done. And so, for example, if we have a difficult conversation with someone who we don't believe will do well with CPR, but yet they decide to go ahead and be full code, we can walk away feeling like we've somehow not communicated enough. We've not been, clear in our elicitation of that decision. But your job is to make sure it's an informed decision from someone who has capacity to make that decision. If it's not the one you would have made, that's frustrating, but you've done your work. If someone can walk away and say, I understand what I just decided to do, I'm able to, make this decision, have some appreciation of what that means, and a reason around that. So let's start with just some prognostic details. What's the overall survival for hospital arrests, in hospital cardiac resuscitation in a 75-year-old? You don't have to declare your answer publicly, but if you would just make a mental note of where you think this falls. Is it 40%? Is it 20%, 10%, or less than 10%? And this is in hospital cardiac resuscitation. Give you just a minute to think about that. Then the next question is, what's the overall survival for out of hospital cardiac resuscitation for an individual who's over 70? Is it 30%, 20%, 10%, or less than 5%? So just keep those numbers in your brains. And now we're going to go through a number of systematic reviews that talk about this. The first is in-hospital CPR outcomes. So this is a systematic review of 29 different studies, and ROSC means return of spontaneous circulation. So person's heart started beating on its own in 38% of individuals who are resuscitated in a hospital. And you're thinking, yeah, but those aren't my people. My people are older. So let's look then at the stratification by age. For a 90-year-old, this would be around 12%. For an 80-year-old, 15%. And for 70 to 79, 18%. Long-term survival is lower, as one would expect, but can range pretty widely depending on how ill that person was, from 5.7 to 21%. And you might look at that and go, geez, 38% of people, that's actually a lot of folks who survive an in-hospital arrest. And of those who live to the discharge from hospital, 88% of them are still alive at a year. Now, 63% don't maintain their functional status. So the majority of folks don't maintain the functional status they were admitted to the hospital with. But you start to look at that and go, oh, golly, maybe it's not as bad as I thought. So let's turn our attention to this picture that's on the slide. And you see what? A lot of people, a lot of equipment, availability of medications, resuscitation at your fingertips, ambubag at your fingertips, and probably a witnessed arrest so that you can respond very soon after cessation of heart function has occurred. So I'll let you just rest with that a minute. And now let's turn to out of hospital CPR outcomes. So this is another meta-analysis. This is 19 studies. And we have, there's a zillion studies in here, and I've tried to simplify the slide. But bottom line is, for someone who is 70 to 79, 4 to 12% will actually survive that resuscitation event. 1 month survival is lower, around 5.5%. 0.5%. And then the CPC thing here means cerebral performance category. So that's how functional is your thinking after CPR. And 1 and 2 in most of these studies is considered a reasonable cognitive function, either good or moderately good cerebral function. And then anything lower, higher than that, 3, 4, or 5 would be a poor cognitive outcome. So if you take all comers, 70 who receive resuscitation, about 10% of them will then at discharge and through a month later have a good cerebral outcome. And 1-year survival is somewhere between 3 and 10%. And then of course, all of that is less good for those who are older. Then let's turn to nursing home residents. So these studies are typically not done in the US because it's a little hard to gather our data in the US. So this one is from the German Resuscitation Registry. They had 2,900 patients, mean age of 83. These are our people for sure. And 1,880 patients died at the site of attempted resuscitation. So 65% died at the site of attempted resuscitation. 902, so 31% died in the hospital, some very soon thereafter, and some within the first 30 days. And the key number here is that 4% of patients who received CPR and were a nursing home resident survived, and 2% of them had a good cognitive outcome. So I think the number a lot of us use is 1%, but this is a little bit more granular detail of where these numbers come from. And then you have 36% of people having CPR initiated before they got the emergency medical services folks summoned. So there's a fair number of people who didn't immediately get CPR. And one of the conclusions of this study is why not? What's going on in the nursing home that they didn't initiate CPR if the person was full code? And we could talk about that in the question and answer. And the overarching message from this study was that CPR rarely leads to a good outcome and certainly not a good neurological outcome in our residents. So just to equip you with some numbers that are fairly contemporary, this was published in 2020. Then this is, let's see, that was a German registry. And then this is another one that was done in Japan. This is the Japanese one, yes. So these are individuals who are age 65 who experienced a cardiac arrest in a nursing home, and then they compared them to people who had an arrest in a private residence. Big population, 37,000 plus people. And those in the nursing home group were, as expected, older. And this is an important piece about the nursing home. They were more often witnessed arrests because we have staff and we see that something happens. And bystander CPR was initiated, as well as shock delivery. So the 1-month survival was higher in the nursing home population, 2.6% versus 1.8%, but you're still looking at that 2.6% number saying, yeah, and it was only 2.6%. So the best case scenario, somebody had a witnessed arrest, it was daytime and they were able to get emergency personnel there quickly, bystander CPR was started, those folks, so this is kind of best case scenario in the nursing home, 8% of those individuals survived. If the arrest was not witnessed, 0% of individuals survived if no bystander CPR was initiated. So again, different country, but very similar results in terms of the number of folks who survive. And again, if we had a perfect scenario, that might bring the survival up, but who knows that they're going to be the one with the perfect scenario. Then what happens so that's just our prognostic information. And then the next thing I wanted to turn to is if somebody comes in with a full code order, what's the likelihood that they'll maintain that full code order throughout their entire stay in the nursing home? And the answer is it's pretty good likelihood that they might change their mind. And so this was looking at individuals who were full code at admission, or they wanted CPR at admission, and 40% of them decided that they did want to be DNR at some point in their nursing home stay. And the reason for presenting these data is to say that with a hospitalization, with some change in condition, we should be revisiting wishes, because we know that things like hospitalizations and transitions of care prompt people to think about this again. The things that predicted that there wouldn't be any change were ethnicity, with Black race predicting no change from CPR to DNR, And those who were offered an opportunity to revisit their choices did commonly change their preference. So that was the message there. And then I just want to talk a little bit about the misinterpretation of DNR orders. So when asked, this is a study from the Journal of Medical Ethics in 2018 about individuals who had a DNR order, a quarter to a third of staff said that people with a DNR order could also not receive at least one of the following: antibiotics, physical therapy, IV fluids, pain relief, oxygen, and NG feeding. They believed that someone with a DNR order, about a quarter or so of folks believed that a DNR order could not be, a person with that order could not be referred to hospital when compared to other healthcare groups. And so this is worrisome that we are using a DNR order to mean do not treat for other things, even in the absence of guidance to say don't do those other things. And this brings me back to now a really old study, but one that has troubled me for many years, which was when we looked at people in a nursing home who had an acute myocardial infarction. And they were sent to the hospital, and this was part of a study looking at guideline concordant therapy for individuals who had an acute MI. And so we plucked out the ones who were in a nursing home, and you can see here that the overall study sample, it's a study. So 85% of them got aspirin, 60% of them got beta blockers, and 60% of them got reperfusion. And all of these individuals were ideally eligible for these therapies. So it wasn't like, oh, well, maybe they had a contraindication to aspirin, or maybe they had a contraindication to a beta blocker. These were people ideally eligible for these therapies. So now if you go to the next column, those who were admitted from a nursing home, only 68% of them got even an aspirin. Beta blockers about 43% got beta blockers, and 30% received reperfusion. And you might say, well, maybe those things wouldn't have helped them. But when you look at the outcomes, 30-day mortality for the nursing home patients who were ideally eligible for aspirin, but didn't get even an aspirin, was significantly higher. So 49% of those people died versus 26% who received an aspirin. And mortality was significantly higher for nursing home patients who were ideally eligible for beta blockers, but did not receive a beta blocker. Again, 35% mortality in those from a nursing home who didn't get the beta blocker versus 18.6% of the individuals in the study who did get a beta blocker. So these have important implications, not just for the resuscitation piece, but because of sometimes, as you heard in David Sedaris's father's example, that we use this to mean that perhaps people don't want other things, even when it's very medically indicated. And then this is just another layer of that notion, which is that in this case, if people had orders limiting aggressive therapies like a DNR order, they were less likely to get aspirin, beta blockers, reperfusion. So all of that comes together. And if you're a nursing home resident who has a DNR order, you're in a bad place in terms of getting guideline recommended therapy. And then finally, I just want to turn to most forms. So most forms in this state, so POLST you'll see used here, and our version of that is a most form. So this is a opinion piece, I'll say a special article that was written by at least one person in the room, Hillary Lum, who's here, was an author on this, as well as Susan Hickman, who I think many of you know, and Carl Steinberg, of course. And the title is POLST is more than a code status order form, suggestions for appropriate POLST use in long-term care. And what this article talks about is we should not be, one of the things it talks about is we should not be using a most form as a DNR order. And many of these reasons really follow from what we've already talked about. If we don't have additional information that person wishes to limit other therapies, then we can get confused. And code status is sometimes erroneously assumed, as you saw in that survey of providers who said, yeah, if you have a DNR order, you shouldn't get X, Y, and Z. But we should know if somebody wants X, Y, and Z before we limit X, Y, and Z. Code status alone is not predictive of preferences for other kinds of interventions. We're doing a study right now in the VA where we have definitely noticed that. You can't predict what they'll want for mechanical ventilation or feeding tube or many of those other potentially life-sustaining treatments based on code status alone. And so we really need to have a broader discussion about what people want in different scenarios. The potentially inappropriate group also includes many of the younger individuals who are being admitted to our care facilities who may not be appropriate for a MOST form or a POLST form. They're really designed for seriously ill people who have a very limited life expectancy, not someone who we expect to be there, for example, with mental illness for many years, if not many decades. And so some of these residents might be appropriate for a MOST form, but many are not. And then finally, I'll just mention that there are decision aids. There are ways to do this. And ideally, this is done with an interdisciplinary team so that there's not one person sitting there having this conversation and all of that's resting on their shoulders. Ideally, you've got multiple folks helping with this conversation. And this is one decision aid that I have here, if that's helpful for you. And then this is another one that people will often use, is some sort of a figure to represent that data we just talked about. So of all the individuals who have cessation of heart activity, you can see in the black, those were individuals who died without transport to the hospital. The gray are those who died in the hospital within 24 hours. The yellow are those who died in the hospital between 24 hours and 30 days. You get the idea. And so the tool can be then used to say there's only a very small number of folks, so 3 out of this entire group of individuals who would survive and have cognitive function at the end of that event. So this is something else folks will use to try to help with the conversation. And sometimes that visual can stimulate conversation and help with a more informed discussion. And certainly you have the person who says, well, I might be that green person, and I think I am going to be that green person. And so that's something that I wish to have. And again, going back to the capacity discussion, if they can render that choice, they understand what that means, they've reasoned out why that's important to them and understand the implications, then your work is done, except for when something else happens. And then you'll revisit it and see if any of their preferences have changed at that point. So then just back to our domain, or our conceptual framework we were working through, you want to do the right thing, and the right thing is a person-centered decision. So if that decision reflects the values of that human before you and all that capacity stuff is in place, they understand what they're doing, they understand the implications, they're able to reason, and this is reflective of their values, then you have done your job. And my hope is that it will still be emotional sometimes, but that you can feel like you've done what you can to make sure that this is indeed a preference that suits them. So we come back to our questions. What's the overall survival of in-hospital cardiac resuscitation? In a 75-year-old, you saw that 38% number for everybody, but of course, everybody includes younger folks and older folks. So it's about 20% in hospital. And again, we have people and machines and lots of stuff in a hospital. So it's a very different scenario. And then what's the overall survival of out of hospital cardiac resuscitation? That was a meta-analysis. There were 19 studies in that particular article. So it's not as though we're cherry picking an article or a few statistics. We really are taking all of that together. And in that case, we can pretty confidently say if it's Tokyo, if it's Germany, if it's the United States, survival is definitely less than 5% for all comers, and probably in the 2% range. So the take-home points are: out of hospital arrest is not the same as in hospital arrest. And sometimes we will have folks admitted who reverse their code status, and we have a good discussion about what that means. And sometimes it's very appropriate, and sometimes it's not. So, but we have that conversation related to the data and in the context of their capacity. And do not resuscitate does not mean do not treat. So if we come back to David Sedaris and the experience he had with his dad, there is a lovely discussion that happens after that first buddy's DNR. And they talk about what that would mean for him to go to a hospital. And there is a good conversation that ensues, but without that good conversation, we wouldn't have known not to send his dad to the hospital. We wouldn't have known not to do other things. So really taking that for what it means don't start compressions, don't start CPR in the arrest in a person who's had a cardiac arrest. And a most form should not be used as a DNR order. It really is designed to be discussed in the context of other care preferences. And finally, an informed decision is a person-centered decision, and that's the right thing, back to our conceptual framework. So I will stop there. And do we have a question time? Oh, okay. Okay. We might have question time later.
All right. I have the pleasure of introducing our next speaker, Dr. Christine LaRocca. Dr. LaRocca is a geriatrician, and she's serving as the medical director for Telegen. She provides clinical oversight and her expertise for federal contracts directed at improving quality, access, value, and equity for Medicare recipients. We're always really grateful for her presence at CMDA, and personally for our facilities, and I'm sure for everyone in this room too, we're really grateful for Telegen's support in our communities. So please help me welcome Dr. Christine LaRocca.
Thank you, everyone. Can you hear me all right? The audio good?
Yeah, we can hear you, Christine, and we're just waiting for your picture, and we can see it too. And Christine is going to present to us virtually, and we are thankful for that as well.
Thank you. Yep, I want to thank you for that kind introduction, and good afternoon, everyone. I am really, really sorry that I cannot be with you in person. I'm going to share that I am on the tail end of having COVID. First time in 3 years. It's been no fun, but the vaccine did its job. I didn't die and I didn't get hospitalized. And I'll tell you this, if I was eligible for a second booster dose this week, I'd get one without hesitation. So I'd like to start my updates with all of you, with a heartfelt thank you. Thank you for all of your courage, for your personal sacrifices through these backbreaking and frequently heartbreaking last 3 years. Working in long-term care, as Dr. Wasserman said earlier, is one of the most demanding occupations, and my Telegen teammates and I are grateful for the opportunity to partner with all of you amazing people. We're grateful for the relationships that have really deepened over the past year and for the trust you've placed in us to help where we can. And I'm going to use this update to celebrate. I'd like to celebrate you and your successes. And since you all know I do like to laugh, I promise not to mention any animals like the llamas that were in the COPD talk. So I'd also like to thank CMDA for their tremendous leadership and for the opportunity for Telegen to be a fixture on the agenda. So if we can go to the next slide, please. So here are my objectives for today. I'll briefly describe the role of Telegen. We'll review data and outcomes from the Telegen team's partnership with nursing homes to provide support during the past 3 years of the COVID public health emergency. And I will share our current focus areas and how we can continue to assist you to improve quality using the framework of quality assurance and performance improvement. So let's go to the next slide, please. Many of you know Telegen. However, if you are new to long-term care or new to Colorado, you may be wondering, who is Telegen anyway? So Telegen is a population health solutions company. We have over 600 employees supporting clients nationwide. We are 100% employee owned. And I'm here today to talk to you about our activities as your Colorado Quality Innovation Network Quality Improvement Organization, or QIO, under contract with the Centers for Medicare and Medicaid Services, or CMS. Let's go to the next slide, please. Telegen's name may also be familiar to you because we provide services for Colorado Medicaid under a separate contract. So in order to be a QIO, independent organizations like Telegen have bid upon and won a contract with CMS to work collaboratively with healthcare providers and professionals on data-driven, evidence-based quality initiatives in order to improve health and healthcare quality. The QIO program is actually required by the Social Security Act. There's a QIO covering every state and territory, and Telegen serves as the QIO for Colorado, Illinois, Iowa, and Oklahoma. We have a purpose that's also in statute, and that's to improve the efficiency, effectiveness, economy, and quality of services delivered to Medicare beneficiaries. So how exactly do QIOs do this? Well, we help achieve national quality goals at the local level through hands-on, one-to-one technical assistance and by convening specialized collaboratives called Learning and Action Networks. So what do we mean by technical assistance? It's not just, computer stuff. Technical assistance is the process of providing targeted one-to-one support to organizations to increase their capacity for quality improvement and to improve processes and outcomes based on their goals. Our work is local to Colorado, but we achieve efficiencies by sharing best practices across our 4-state region. We are expected to achieve results. We are held accountable by CMS for the performance of the healthcare providers that volunteer to work with us. So if you succeed, we succeed. If you don't, we don't. Our QIO services are provided at no cost. And why is that? QIOs are funded by CMS, by the federal government. Therefore, basically, you paid for us already. So in a nutshell, we are a quality improvement organization, a distinct entity. We're not a healthcare facility. We're not a trade association. We're not the regulatory part of CMS, and we're not an insurer or payer. So please think of Telligent, I don't know, think about the movie Ghostbusters, who are you going to call? We're your go-to resource for a helping hand with quality improvement. So next slide, please. So Telligent QI Connect is the name we've branded to describe our network of partners who are working with us on healthcare quality improvement initiatives. We're both a QIO and a hospital quality improvement contractor for which we are working with rural and critical access hospitals in 15 states, and 10 of those hospitals are here in Colorado. Next slide, please. Here you see our wide-ranging focus areas, including improving nursing home quality and responding to the COVID-19 public health emergency. Thank you to the over 200 nursing homes across Colorado who are partnering with us to improve the quality of care they provide. Achieving our goals is only possible through the power of relationships, and we are so grateful for the many Colorado associations and stakeholders, too many to name here, who are collaborating with us. But I'd be remiss if I didn't give a big shout out to CMDA, CHCA, the Colorado Department of Public Health and Environment, Leading Age, the Colorado Dementia Collaborative, the Alzheimer's Association, and my good friends, Dr. Singh Palat, Dr. Greg Gom, Dr. Leslie Eber, Dr. Carrie Levy, Dr. Lea Watson. And another reason, frankly, I couldn't come in person is because I knew I'd want to hug you all and all of my friends that are in attendance. So next slide, please. So what is our ongoing rapid response for nursing homes? We continue to receive weekly referrals from CMS, which direct us to increase COVID-19 vaccination rates and to reach out to specified homes with outbreaks. Homes are supported by a dedicated quality improvement specialist from Telligent who aids in completing an infection prevention and control assessment, who helps, based on those assessment results, offer help with conducting a root cause analysis and help with setting specific, measurable, attainable, relevant, and time-bound or SMART goals in order to achieve a 30-day quality improvement plan. We work with the nursing home to integrate these efforts into their QAPI program. So next slide, please. So since April 2020, and please note that date, we were right there with you from the beginning. We've assisted 178 nursing homes in Colorado, some more than once, depending on the number of outbreaks they've experienced. We continue to offer virtual or on-site visits to observe infection prevention and control processes and to offer recommendations. The most common recommendations that we provide relate to PPE, hand hygiene, and environmental services. And here we include a lovely testimonial from Julia Rana at Walsh Healthcare Center. Our facility opted for a virtual visit to aid in the selection of a priority gap in our infection control program. Having another set of eyes is a valuable resource. Our facility used root cause analysis, the Fishbone tool, PDSA worksheet, and the Quality Improvement Initiative plan. Telligent is provided and will continue to provide ongoing support. I look forward to working with them for many more years to come. This really touches my heart. It's why we get up in the morning. So thank you, Julie. So let's go to the next slide. So as a QIO, we are focused on outcomes and results. And here are some results that we can all celebrate. They showcase that together we can accomplish so much. Thanks to the hard work of all the nursing home staff who partnered with us and my experienced teammates to decrease COVID-19 rates, deaths, and complications, we achieved a 34% reduction in COVID-19 infection rates compared to matched control homes, with over 1,800 prevented deaths, over 15,000 prevented cases in residents, and over 5,700 prevented hospitalizations due to COVID. These are tremendous results. A huge shout out to all of you. Next slide, please. So as you know, in December of 2020, the Biden administration launched a 6-week campaign urging Americans to get their updated bivalent COVID-19 vaccine. Telegen immediately responded to this call to action by conducting on-site visits to nursing homes with vaccination rates below 10%. We offered quality improvement support, data reporting assistance, and we facilitated connections to vaccine clinics. We recognize and celebrate nursing homes with high rates with Telegen's Blue Ribbon and COVID-19 Vigilance Award, and more on that award in a moment. We launched a social media campaign across LinkedIn, Facebook, and Twitter. We created our VaxHub website to include on-demand evidence-based tools, resources, and education on COVID-19 therapeutics such as Paxlovid. We offered a national webinar by Denver Health expert, Dr. Anuj Mehta, titled "Don't Be Ambivalent" or "Don't Be Ambivalent" about the bivalent boosters, understanding the emerging science behind the updated boosters. And I gotta give a big kudos to my English major son, Stephen, for that clever title. So drum roll, as a result of this support, we saw a 40% improvement rate in resident up-to-date rates in Colorado. Our efforts continue. CMS has incrementally upped the ante, and now Telegen is receiving CMS referrals for nursing homes with resident up-to-date COVID-19 vaccination rates below 85%. We know this is a high bar, and we're calling referred homes to discuss their successes, but also any continued challenges with increasing rates, so we can offer suggestions for continued improvement. Let's go to the next slide, please. So here's the VaxHub. It's located on Telegen's website. It's listed on slide 19. We update it frequently and would love for you to check out a most recent post. It's a new audio series from CMS called CMS QI Voices, Improving COVID-19 Outcomes in Nursing Homes Across America. So next slide, please. Everything we do is based on the QAPI framework. We support efforts to implement and sustain QAPI methods and instill these practices into daily tasks using the QI methods listed here in order to improve performance. So next slide, please. If you haven't joined us, please consider it. Our Telegen team offers a monthly mini collaborative and periodic workshops to support QAPI. We review the QAPI framework, we align the framework with regulations, and we coach nursing homes to analyze their data, conduct root cause analysis and plan do study act cycles, and to design and deploy a PIP, a performance improvement project. Participants are asked and encouraged to complete pre-work, to attend the sessions, and complete action items between the sessions to share at their next QAPI meeting or QAA, Quality Assessment and Insurance Committee meeting. Participants can receive a certificate of completion upon request. Next slide, please. Here are some examples of enhanced technical assistance. We've supported over 200 Colorado nursing homes with a directed plan of correction for F880 tags since 2021. And that's huge, great work of Courtney Ryan and Mariah Payne. We are trained in the use of the Interact program's tools and resources to assist with reducing avoidable acute care transfers. And our amazing subject matter expert, Kristen Ives, assists homes with questions about reporting to the CDC's National Healthcare Safety Network, or NHSN, and this includes both COVID-19 and influenza reporting. Next slide, please. In addition to support for infection prevention and control, which has been the bulk of my talk, please know that we offer assistance on all of these topics as well. Adverse drug events, facility-acquired infections, opioid prescribing best practices, and we're committed to advancing health equity. And can we offer help related to CMS's announcement in January about audits of schizophrenia coding? Well, the answer is yes. Telegen can support homes with conducting a root cause analysis and performance improvement project. And we'd like you to look at all antipsychotic prescribing and reduce potentially inappropriate use. So next slide, please. The Blue Ribbon is awarded quarterly to nursing homes that complete Telegen's COVID-19 preparedness assessment and have resident and staff COVID-19 vaccination rates of 95% and a resident COVID-19 booster rate of 90%. As of January, 86 unique Colorado nursing homes have received it at least once. So that tells you it can be done. And when nursing homes complete the COVID-19 preparedness assessment, they immediately receive resources via email for identified gaps and a Telegen quality improvement facilitator contacts the home to offer one-to-one tailored support. These Blue Ribbon awardees are recognized on the Telegen website. And this is the great part. They receive access to a comprehensive marketing toolkit that they can share with healthcare partners, trade associations, residents, and families to shout their success from their rooftops. So next slide, please. So new this year is we've expanded the Blue Ribbon Recognition Program to Telegen's Best in Class, which will recognize nursing homes for achieving the Blue Ribbon, completing an emergency preparedness assessment, having over 75% of staff trained in infection prevention and control, reducing unplanned transfers, focusing on preventable ED visits, for which Telegen will provide you the baseline and performance data. And together, the acronym spells BEST, and nursing homes must achieve each of these criteria to be awarded the best in class. So next slide, please. Please reach out to us with questions. If we can't help, we frequently know who can. Here's our contact info. And next slide, please. Thank you. Again, a heartfelt thank you. I hope we can all take some pleasure in these celebrations and successes, and I appreciate the opportunity to talk to you today. And I'm thinking Dr. Palat's amazed that I finished on time.
Yeah. You did great, Christine. You didn't even have our little signs to prompt you. So thank you so much for your presentation. Next up, we have Dr. Jennifer Stevens-Lapsey. She has an amazing bio, and my short introduction will not do it justice. But just a few of her titles include Professor and Director of the Rehabilitation Science PhD program, and she is the Section Director for Research and Development in the PT program at the UC School of Medicine. So we are thrilled to have her give us an update on high-intensity rehab, because a post-acute conference would not be post-acute if we didn't have a rehab update. So thank you so much. Help me welcome her to the stage. Thank you.
Well, thank you to the organizing committee for the opportunity to be here. It is wonderful to see the interdisciplinary representation at this conference. So I appreciate that. How many in the audience come from a rehabilitation background? There's a handful. Okay. Perfect. This talk is designed largely for a non-rehabilitation audience, but I welcome the comments of those of you who are in this field. Let's see, to pull up my presentation here. Let's see. It's right here. Okay, fantastic. All right. So I am the director of the Restore team at the University of Colorado, and also work closely with our Eastern Colorado VA healthcare system. And I'm privileged to have the work that I'm sharing with you is largely a result of a collective team of trainees and faculty and research assistants. So it takes a village to conduct clinical research. My disclosures are federal funding from various sources, but also we receive some supplementary support with the rehabilitation training that we do. None of us receive personal income from it. It all supports the global initiative of trying to get the word out to change clinical practice. So I will let you look through these objectives while I tell you that what I'm going to share with you is a story and a method and a strategy for implementing rehabilitation that resulted in an increase in functional performance, a decrease in length of stay, and a 20% increase in community discharge rates. And so using the rehabilitation approaches that I'm going to share with you, we were able to move the dial substantially on improving the quality of life for many older adults in skilled nursing facilities. So I'm going to start out though with some statistics. This probably will not come as a surprise to this audience, but patients spend only 7 minutes a day up on their feet in the hospital. In addition, 68% of patients are discharged below their pre-hospitalization level of function. And that is considering that they started often in a precarious state to begin with. And we really haven't seen any improvements in hospital-associated deconditioning despite a number of changes in care, in the standards of care over many years. And we've shown that SNF residents about the time of discharge, so this is the optimistic side of things, walk only 849 steps a day. So when we look at functional status or mobility or the ability to complete functional tasks is increasingly being shown to relate or predict rehospitalizations, other adverse events like falls or death. And in fact, it predicts these events better than the combination of many other variables used in predictive modeling. So measuring functional status is really important. So one example of functional status measurement is the FIM, the functional independence measure. And when we look at the relationship between individuals who score well on the FIM and their rehospitalization risk, you see a pattern. And as we go down and we look at individuals who are in the lowest functional independence group, we have the highest rate of rehospitalizations. So this is shown over and over again in the literature. Functional status predicts rehospitalization as well as other adverse events. Now, it's not surprising that physical function is related to low physical activity. But what was surprising was, as I mentioned to you, 849 steps a day in the SNF upon discharge. Well, we looked at this question because we wanted to know how many steps they were going to take when they went home, thinking, oh, it'll grow way up when they go home, right? Nope, unfortunately it did not. Only 922 steps when patients returned home. And so individuals are at such a low level of physical function, but they're also not engaged in the facility or at home in mobility or activities of daily living. So one measure of physical function is gait speed. And gait speed is a very easy measure. Can be measured with a stopwatch, can be measured with a laser light system, can be very easily implemented. And what I'm going to share with you, each bar here represents a different study that tells, with gait speed that was measured, that tells a story of different thresholds for gait speed that can be predictive, again, of rehospitalizations, falls, and adverse events. And on the x-axis here, you see meters per second. So I'll give you some context. I'm going to show you a video of what this looks like in terms of just putting in your head what these different gait speed measurements might equate to in terms of the populations that we're working with. But in red, we call the red zone, if you walk less than 0.6 meters per second, most of the literature says you are in a long-term care facility, you have some significant deficits in your independence. You're at high risk for death and high risk for other adverse events. So this is the red flag zone, less than 0.6 meters per second. If you walk between 0.6 and 1.0 meters per second, you're in the yellow flag zone. And these are individuals that typically are in assisted living facilities or are discharged to home with high levels of care in the home environment. So 0.6 to 1.0 meters per second. So let me show you what that looks like, because you're probably wondering, what speed do my patients walk? This is someone walking at 0.7 meters per second. So it kind of anchors. This is someone who would typically be discharged. This is about the speed at which we might expect someone to be discharged from a skilled nursing facility, sometimes lower than this, but this is 0.7 meters per second, so yellow zone. Now, the green flag zone is anyone who's walking greater than 1.0 meters per second. So the large majority of individuals, healthy individuals, walk between 1.2 and 1.4 meters per second. So these are individuals who are at home, independent in their activities of daily living, still grocery shopping, maybe gardening, 1.0 meters per second or greater. And so we put this all together and it just tells us a story, but we use these thresholds for decision making. So instead of just looking at someone's physical function, we can actually use the data to drive some of our decisions and help inform where patients should be discharging or what type of additional assistance they might need. Now, walking speed is predictive of mortality. So Stephanie Studinsky at the University of Pittsburgh took almost 35,000 individuals and measured their gait speed. And then she followed them over a period of time, over 8.5 years, and classified these individuals on the basis of these red, yellow, and green zones. If you're in the red zone at baseline when you started and you were followed, this is what happens over time. There's a group in the yellow zone at baseline, and then there's the group in the green zone at baseline. So people 1.0 meters per second or greater. And when you follow individuals 3,000 days later, which is 8.5 years, and you looked at what percentage of these individuals are alive, you see that 55 to 60% are alive if you started in the red zone. 70 to 82% are alive if you started in the yellow zone. And 90 to 95% are alive if you start in the green zone. So gait speed is predictive of mortality. And there are additional data that Stephanie Studinsky has highlighted, and you can actually take a 70-year-old and you can look at how fast they walk and you can anticipate how long they're going to live. There are very few outcomes that are that predictive. So the key element though is, all right, so gait speed predicts all these adverse events and outcomes, but can we change it? Can we intervene on it and actually change the outcome? And so this was a study where they monitored gait speed over the course of a year. And they looked at individuals who improved at 1 year by 0.1 meters per second. So a change of 0.1 meters per second is a clinically meaningful amount of change in gait speed. They monitored all these individuals and they looked for improvements. They looked for people who transiently improved. So people who improved but then declined, and then people who never improved. Okay, so when they followed these individuals over 9 years, and these studies are hard to do, right? You have to follow large cohorts and you have to follow them for a long period of time. Over 9 years, what they saw was that if you started in that never improved zone when you were being followed for that first year, only 50% of those individuals were alive. If you started in the yellow, kind of the transient improvement group, 60% were alive. And if you started in the green, you improved your gait speed during the course of that year, 70% were alive. So this tells us that walking speed is a modifiable risk factor. Now, do I sit down with patients and show them how they're walking and tell them how long they're going to live? No. But I will tell you that when you explain to them that this really is associated with how long they're going to live, this is a measure of system capacity that people do inherently have a desire to improve their walking speed. All of you are going to be walking to your cars faster on the way out to the parking lot, right? So how do we improve walking speed from a rehabilitation standpoint? So we have this outcome measure, we're monitoring it. Now we know we can change it and improve the outcomes, but how can we actually do that with our interventions? And I'm going to talk about the concept of failure as a good thing. So this is in rehabilitation. I'm going to tell you why failure can be a really good thing. How many of you have heard of an initiative called Choosing Wisely? Okay, fair number. So Choosing Wisely is a consensus-based initiative amongst different medical disciplines where the discipline has chosen 5 things that we know we should not be doing, but we're still implementing. So the data and the literature suggest the nursing choosing wisely. The data and literature suggests that we should not be letting older adults lay in bed or only get up to a chair during their hospital stay. So this is the nursing on the nursing list, right? We know we shouldn't be doing this. The physical therapy choosing wisely says don't prescribe underdose strength training programs for older adults. Instead, match the frequency, intensity, and the duration of exercise to the individual's abilities and goals. Why don't we see this happening? We know this should be happening. This should be standard practice, but I can tell you it is absolutely not. And one of the biggest barriers for implementation is a fear of adverse events. So we heard some really helpful guidance in terms of discussions around medical errors, but there's also a pervasive culture in nursing facilities, hospital facilities, most post-acute care settings of don't get people up and walk because they might fall, right? So we're so afraid of these penalties and litigation that this concept of negative defensive medicine drives a lot of what we do, right? This is the thought, right? I don't want to have to deal with a fall. So my question for you all is, have we taken the above all else do no harm principle to an extreme? The unfortunate reality is I'm not going to get sued because someone's muscles atrophy because I left them in a chair. I might get sued if they fall. And that drives everything that we do when it comes to mobility, right? We have patients who could get up and move that we define as too high of a fall risk because they might fall. And I understand the consequences, and it's something that we as a community have to figure out how we're going to move forward and address this issue without the fear paralyzing our ability to actually get people up and moving. So a lot of the work that my team has been doing has been really trying to set the stage for more evidence-based guidelines and more evidence that we can be doing this and we can be doing it safely. And it's not an easy task, but at least from a physical therapy standpoint, if we can show people that we can dose and train and intervene at a higher intensity and we can do it safely, then maybe people will feel more comfortable at least taking that step. So one of the most common things I see, I've been traveling around the country visiting skilled nursing facilities as part of a clinical trial that I'll share with you. And one of the most common things I see when I walk into almost any rehabilitation gym, to no fault of the rehabilitation specialist, because a lot of what I'm sharing with you is relatively new, is an individual sitting in a chair or on the edge of a bed with a 2-pound ankle weight strapped around their ankle. And the individual that I'm looking at weighs 300 pounds and is 6 feet tall. And the therapist is trying to strengthen their quadriceps muscle so that the patient can stand up out of a chair independently. Now, you don't need to be a physicist to understand that those forces don't exactly, that math does not add up. 2-pound ankle weight, 300-pound individual, right? And so there's a pervasive problem in almost every facility that I have visited where physical therapy is dosed, and occupational therapy as well, at a very low intensity. Again, with this do no harm principle in mind. I see a frail individual in front of me. I don't want to overload that individual and cause harm. I won't get sued because their muscles atrophy, right? But I will if I cause harm. So we've been trying to change the paradigm. So on the left, you see what I call current rehabilitation, where the foundational premise of most activities and exercise is these general conditioning activities. What do I mean by that? That's the balloon toss that you see. That's the marching in place. That's the slow gait around the facility that you might see. These really low conditioning activities. At the bottom of that list is my witnessing a patient falling asleep on the exercise bike, right? I mean, you don't get any lower than that, right? But this is what's happening. Now, if you take the pyramid and you flip it upside down, because if you look at the top of that pyramid, what's at the very top? Resistance training, right? There's this pervasive feeling that older adults can't get stronger. Can't strap heavy weights, and we can't get them as strong as we can with younger adults. And there are some limitations, but I'm here to tell you that's absolutely not true. In fact, if you make resistance training the foundational basis of a lot of what you do, you will double someone's strength, which means it's twice as easy for them to go up that flight of stairs. So their perceived exertion and their fatigue associated with activities of daily living is dramatically diminished. And I don't have to put them on the exercise bike for 45 minutes to do a cardiovascular exercise program. I can do that in a much more confined, short period of time to be efficient with the time that I have available. So a lot of what we've been doing is really being smarter about how we approach rehabilitation care. So we can do more with less time if we focus on this resistance training. So if you have balloons in your therapy facilities, I suggest popping them. They can be effective, but a lot of times, just tapping, how many of you have seen tapping of balloons back and forth, right? I mean, again, the forces that are transferred, it's a balance exercise. It can be done effectively. It's just not always used in the context of what it's intended to be, what the target is at the right dosage. We watched therapy sessions, and patients are inactive for 41% of their therapy session. That means they're sitting, they're resting, or they're talking, or they're being talked to 41% of that time. That's not a very efficient use of time. And dosing, we know, is traditionally based on time, minutes of therapy. Even with PDPM, we're still seeing this concept of I'm working with this patient for this period of time, even though payment structure has obviously changed. And so the program that we've been really focused on, we call it iStronger, is a framework for safely delivering high-intensity rehabilitation to patients with complex medical needs. So the idea is that we progressively overload with resistance training during every session and across sessions. We don't wait for 2 weeks and then up the load, or even 2 visits, 2 sessions. We do it within and across sessions consistently. So we meet the patient where they are. We maximize what dose we can provide in each and every visit. So this is something anyone can take away. This is a helpful tip. If you want to strengthen muscle, if you want to hypertrophy muscle, more is not better. More repetitions are not better, but more weight is better. So you actually gain more muscle strength and more muscle size if you do fewer repetitions at a higher weight. So when I walk into a facility and I say, I'm here let's work on high intensity intervention, and the therapist says, I do 30 repetitions with every patient. I say, I'm not focusing on endurance. I want to get the muscle that is responsible for getting you out of a chair stronger. I want to increase muscle hypertrophy. And in order to do that, I'm going to do fewer repetitions with more weight. So the idea is our patients fail on the 9th repetition. That means they cannot do that 9th repetition with proper form or technique. And I'll show you what that looks like with the sit to stand activity. So we have an individual who's standing up from a chair here. And what you'll see is the gait belt strapped around her. She has a transient loss of balance, but is able to continue. We see this all the time. Doesn't mean we should stop the exercise. On the back of that gait belt, you'll see a weight. So we can add weights to the back of the gait belt to make this activity more difficult. So what I didn't show you was she did 10 repetitions or 12 repetitions before this set and didn't fail. She was able to continue and do the full set of 12 or 13 without any trouble. What you're going to see here is she's going to start to fail. She's starting to lean forward more. She's slowing down. You know, people will use momentum, they'll use substitution, they'll do lots of different things to accomplish the task. And you can see this is getting harder, right? And so I'm looking for her to physically fail, being unable to do that last repetition. And so the therapist is now helping her do that final repetition. Now you could say she failed 2 repetitions earlier because of the quality and the deterioration of her form. And so there's a little bit of a subjective element to this, but the concept is that you have to actually dose exercise. This is based on the American College of Sports Medicine guidelines for exercise at an intensity where you see failure on that 9th repetition. So how can you tell in your facilities what's happening? Again, this isn't necessarily the fault of the rehabilitation therapist. This is not being done in home health. This is not being done in nursing facilities. This is not being done in acute care because it's relatively new in terms of data and evidence to support the efficacy and the value of specifically this resistance training approach. You can ask a patient, how hard are you working on a scale of 0 to 10? On average, when I come in and I ask patients how hard they're working, they're usually at a 2 or a 3. These are not the ones that are falling asleep though. Those are at like a 1. But 2 or a 3, which means that's way too low. A lot of these warm-ups are taking 15 minutes, and we want these patients at a 7 or an 8 in terms of the intensity on that exercise bike. Even if it's a warm-up, they can quickly progress to that 7 or 8 after initial period of warm-up. We also use heavy weights. We use 10-pound ankle weights. We use resistance machines when they're available. We use body weight, but we add to the body weight something like a weight vest. So this individual is wearing a weight vest, and we put weights in. We incrementally increase the amount of weight. You can take them in and out. You can change the total amount of weight. We change the height of chairs. We change the difficulty performing different activities, but the weight vest often tells us, or helps us achieve that higher overload. And so we have 2 studies that I'm just going to highlight. One was done in a PACE community, showing that this high intensity resistance training approach with 6 weeks of high intensity overload resistance focused intervention was effective. So we used the SPPB, which is the short physical performance battery, and we showed it was safe, and it was also resulted in twice the clinically meaningful change in after 6 weeks of intervention. More importantly, we saw that changes persisted through 12 months. So this is a population where you wouldn't expect that. Once we affected the change and increased their physical capacity, they were able to do a lot more and maintain that strength. We also worked with our partners at the Colorado State Veterans Home on our campus, Anschutz Medical Campus, really wonderful group of therapists. And in over 100 people, we looked at this high intensity resistance training program, and we saw an improvement. I'll focus on the gait speed of 0.13 meters per second. So remember, I told you 0.1 is a clinically meaningful improvement in gait speed. And we saw a 20% increase in discharge to the community, which was not expected. We didn't focus on that. We didn't educate anyone to intentionally increase, but patients were discharging at a higher level of independence, and they were able to go home. And so you see, we have improvement in function. We have a decreased length of stay of 3.5 days. Those two move in opposite directions, right? So that further magnifies the effect of what we saw. So we can get people better, faster, sooner. So what have we learned? We've learned it's safe. We have used this high intensity resistance training paradigm in over 1,000 patients. And it is safe. When we teach therapists to monitor vitals and to monitor the precautions or contraindications to high intensity strength training. Not everyone is eligible for this, but the large majority of patients in skilled nursing facilities are. Patients surprisingly like to participate. So we actually saw a lower rate of refusals using this approach. The therapists, when we first approached therapists to do this intervention, they're like, our patients are going to hate us. They're never going to come back. Our rates of refusals are going to go through the roof. Well, I hate to say it, but I think our patients know more than we think. And they recognized that we weren't pushing them, and they became more engaged, and they wanted to work. They want to go home. Even our long-term care patients, there was a little bit of a culture of, oh, I get to wear the weight vest now, or I get to do this, or, achieve this goal. So, and the last thing that is really important to highlight is our therapist productivity. And working with many different sites, we do not see a drop in therapist productivity. I will say we do see a drop because they're learning the techniques. There's some cognitive overload to learn how to do this appropriately. And we do have to tailor interventions to individual patients that DSAT, patients that have high amounts of pain, patients that have dementia, patients that are not motivated. There are strategies that we have very specifically adapted and taught therapists to use to deal with some of these difficult situations. And so just in wrapping up, we are running a clinical trial. This is one of the largest rehabilitation clinical trials right now. It's funded by the National Institutes of Health. And we're looking at almost 4,000 patients across 32 sites throughout the country, really truly evaluating for whom is this going to work best? Which subgroups of patients are going to respond the best, comparing our iStronger program to usual care. And then we've also looked at mobility. We've asked, if you just have people walk more in a nursing facility, will that improve their outcomes, right? If you just got them up and moving more. And we combined that, I'll just cut to the chase. We combined that with our iStronger program, and we saw in gray a slight increase beyond just our iStronger program compared to usual care. We did this on the tail end of COVID, so our numbers were small, and we have to expand this before we're really going to know what's the magic bullet. Is it mobility? Is it high intensity strength training? Or is it both? So I will conclude there. I will say that our team is passionate about helping spread the word that we need to change the culture. We need a paradigm shift for rehabilitation. So we do spend a fair amount of time educating DPT students in programs around the country, as well as other professionals in a variety of different settings. There's also a really great program through the APTA for education in aging and that can also be sought out, which I highly recommend as well. So if you have any questions, feel free to reach out to me. Thank you so much for your time and attention.
We did have a brief 5 minutes for questions for last few speakers. But if I don't have any takers, we've got a taker.
Yeah, actually, I got a question for both speakers, sort of tie the two together, believe it or not, DNR and exercise. And where'd Kari go? Okay. So the question has to do with the data on the folks who didn't, even in hospital, stratifying this population. And it kind of goes to what you just showed us I have a feeling that the data doesn't exist, but maybe it's something we need to look at, is even amongst the 20% who survive CPR, if you stratify them by frailty, you'd probably see a very different range. And at the same time, this begs the question of combining the work you've done to better stratify and identify the potential based on frailty, et cetera, and the risks. Because at the end of the day, that's what we're trying to do. So actually, it's a question for both of you.
Yes, we have plenty of microphones for you.
On? Is it on? Hello? Hello? Good? Okay. So thanks for the question, Mike. I would say, frailty, of course, is a hard metric to get in big data sets. So we don't have that. We're starting to do gait speed in our clinic. So hopefully we'll have that for loads of folks going forward. No question. So we were seeing a patient that it's folks who are frail are at higher risk of not surviving, of course, CPR. We had a case a few weeks ago where we were talking to somebody in the hospital. And as I mentioned, the in-hospital discussion is sometimes different because they're in an ICU. People are going to come and they're going to resuscitate them quickly. And this person happened to have a cardiac situation. And so it was very likely he was going to need some sort of an intervention, and he had advanced cancer. And so we were trying to have this discussion, and it's a very nuanced discussion when you're pulling in frailty and comorbidities and all the things. And we could fix his heart. We probably could fix his heart, but in the context of everything else, it was a lot. So the bottom line is it's a complex equation. We're doing our best to predict what will happen with this particular person. And I think we actually put a lot of burden on patients and their loved ones to make a decision that's really complex. And so there's probably some amount of paternalism that can come in, maternalism, when we're having these discussions about, you know, when we put it all together, what do we think is the best scenario for that person? So as usual in geriatrics, it's complex.
And because it's complex, is this on?
Just
Not
keep
sure it
singing
is.
it. No,
Just keep singing. Eventually it'll come on.
Yeah.
Because it's complex, we need these large data sets, like the trial that we're running. I'll be the first to tell you, I don't think high intensity works on everyone. I think there are definitely people that are going to respond better than others. I see no reason why people should be falling asleep on an exercise bike. So I think we should be trying to implement it, but who the responders and the non-responders are is going to be a really critical question where we put our time and energy and our resources.
I had a question for Jen. What do the therapists think of doing the therapy? You mentioned they were
Yeah.
still as productive, but what did they?
So, you know, early on, they're hesitant, right? This is not the culture that they have been taught to work in terms of pushing the envelope and really and taking some of these risks. But after a while, you know, one of our first therapists, and I hear this theme over and over again, came back and said, I had no idea how much I was underdosing my patients. My patients not only tolerated it, but they improved much faster. I mean, that's a qualitative, like very just, you know, subjective, but I could just see how much they were engaged and how much they were improving. So, you know, that initial hesitation gets wiped away very quickly by the realities of what they're able to do with this new paradigm.
That's great. Good, perfect.
Any other questions?
I have a question. Thank you so much. That was really amazing. I'm very interested in all of this. I do want to ask, were these same sort of principles of resistance training, are those used for restorative rehab, or can it also be translated into cardiac rehab? And then just really curious, sort of as a, you know, the person perspective, how do you control for sort of the variability in motivation in patients, which I see sometimes in post-cardiac admissions with depression, and so how are you going to control for that? And is there an intervention? Are they responding better to it? Yeah. So unless they have decompensated heart failure, all of our patients that have some sort of cardiac or a recent MI are all participating in this high intensity program. And again, we're tailoring it and dosing it to their individual needs and monitoring vitals and signs and symptoms of pushing too far, too fast. And that's really the key, is to that close monitoring. So we haven't had any limitations that we've seen other than the true contraindications to high intensity resistance training in some of with decompensated heart failure and a recent MI. What was the second part of your question? It was
Motivation?
motivation. Yeah. So motivation is a challenge. And a lot of times we come up with ways to change things up quickly so that we're distracting the patient. So they're doing one activity, then another activity, then another activity. And before we know it, I mean, that's a difficult population to work with. They're a little bit more responsive and a little bit more engaged than they would have otherwise been. But, you know, when someone's in a lot of pain, they're incredibly fatigued, you know, all those things are coming into play that influence our ability to dose the intervention as we would like. And a lot of it also just goal setting and bringing things back to the context of what does the patient want to do? And sometimes we forget as exercise professionals that they don't understand that strengthening the quadriceps muscle is going to help them go home and walk their dog, you know, or get the mail on their own or do things. So really drawing it back to playing with their grandkids or making sure that it's goal centered and very personalized in terms of the motivations that speak to that person. A great question.
And I can't resist, maybe a preview for next year's topics. We have someone who hopefully will be coming to our institution to do research at the VA who has worked on testosterone supplementation in a safe way. Don't panic, in a safe way. And what he's noticed is people who had no motivation, once they are supplemented with testosterone, they will show up and say, I know I'm in the, not the placebo group. I know I'm in the treatment group because I feel really good and I feel strong. So there's probably some amount of what, you know, people come to the table with, and then that they're deficient in certain, you know, hormonal balances that we can help with. Matt, can we get more prednisone? Yeah, mania works. Yeah.
Oh, great. Those are great talks. So thank you so much for your time. Appreciate it. And great questions too, everybody. Just wanted to let you know we have a break starting now until 2:30, and please join us in the back for the dessert reception. And we look forward to starting promptly back at 2:30 for our falls panel. Thank you.
I know.
No. 6 plus. Moderator is 6. That would go.
I'm gonna hide on the answer.
All right.
I'm probably gonna fall off.
So good. I gave you closest to the ground there. Put your shoes in your dress.
All right, everybody, we're going to get started. Please take your seats. Doesn't bend, huh?
It's freezing in here.
I'm too short for.
Oh, man. That's right. Orchard Park, Centennial. Well, this is called. Actually. But I love all this. So I've been in ministry training off.
Hey, Leslie, slide where they are.
have fans? You don't know.
All right, well, Leslie's getting the slides up. I will get us started. So my name is Travis Neal. I'm a PA. I was told that I have to introduce myself. So I have been working in long-term care for quite a while, since I graduated. So well over 13 years. And I have been on the CMDA board for a few years. And I've also had the privilege of helping out with some medical director type duties and doing some teaching at the university. So love geriatrics. And today we're going to be talking about or a panel discussion today about fall prevention, which I couldn't imagine better timing following Dr. Stephen Lapsley discussion about gait speed, which was just phenomenal. I heard a version of that talk a few years ago, and it's one of the talks that has recycled in my head nonstop since. I can't stop thinking about it. I can't stop talking about it. So thank you for that. And it's, you know, it definitely plays into some of what we're going to talk about today in fall prevention. So, you know, I try to add humor to talks, and, you know, you should try Googling seniors falling funny. And turns out it's not funny, and then Google tags you as a sociopath. So it's very hard to make falls funny, but we'll try to add some levity to the conversation. And, you know, I think, you know, we're not trying to make this a comprehensive discussion about fall prevention. That would take days. You know, it's really more about trying to distill it down to some pearls based on, you know, the panel that's up here right here, and give you some things that hopefully you can take away with you back to your facilities. So let me start by introducing our panel. So to the left of me, and I don't know in what order, so I'm just going to move down. So first on the panel is Sarah Stover. She's Director of Nursing at Windcrest, and she's at Erickson Senior Living Community in Highlands Ranch, Colorado. She has 18 years of nursing experience, 16 of which has been in clinical leadership roles supporting seniors in post-acute long-term assisted living and memory care. And then Mindy McCleary is in physical therapy. She earned her doctor of physical therapy from Regis University in Denver. Over 20 years of experience as a PT. She's worked in a whole bunch of different settings: occupational medicine, acute care, home health, private practices, senior living communities. She served as a regional director of operations and director of rehab in different communities. And then we have Dr. Jennifer Connolly, which many of you know. She's the division director of pharmacy for the Veterans Community Living Centers. Since 2012, she's dedicated her pharmacy practice to long-term care, advocating for safe and appropriate prescribing medications. She's received a doctorate from pharmacy from the University of Colorado. Congratulations. And she has held board certs in both geriatric and ambulatory care pharmacy. And then she launched the AMDA Drive to Deprescribe initiative, which I know a lot of you know, in her PALTC communities, and made it her primary focus to decrease the number of meds. We have Lauren Shimp. She is a nursing home administrator. She's been serving as a SNF operations leader for over 10 years. She's currently serving the Veritas Management Group. She works within facilities to collaborate and strengthen their healthcare systems, while also overseeing the system's case management operations. She's a 30 Leaders Under 30 award winner, as well as a recipient of Colorado Health Heroes Distinguished Services Award. And then we have Sonia Wagoner. She's a nurse practitioner, medical provider in long-term care. She's been working in long-term care for the past 5 years. She has a bachelor's in nursing from the University of Colorado. With a nursing background in critical care, she enjoys caring for these complex patients, combined with a passion for working with underserved and disadvantaged populations. And then last but not least, Dr. David Shepard, medical director, internal medicine physician, and multi-facility medical director in Colorado Springs. He completed his residency in medical informatics fellowship in Indiana University, and worked as a hospitalist, and then later transitioned to outpatient medicine before finding a home in long-term care. And he has a passion for process improvement, antibiotic stewardship, reduction of polypharmacy, and maximizing utility, electronic medical record. And that, I believe, is actually the shortened version of your files. Sorry if I cut stuff out. So the primary learning objectives today. So really, like I said, just trying to take the wisdom of the panel and give to you some of the things that do work and don't work in long-term care. And, you know, the primary purpose is the risk of falls, and what I think we all know the impact is on our population. So I would say falls is probably not only one of the biggest adverse events that can change the course of our patients' lives, it is probably one of the most preventable adverse events that can change their lives. The statistics are startling when you look into it. So fall death rates, this is in the US, this is from 2007, 2016, increased over 30% for older adults. You're looking at a rate of about 7 fall deaths per hour by 2030 at the current rates. And then about 75% of nursing home residents fall each year, with an average of 2 to 3 falls per year. About 1/3 of people over 65 and half over 80 fall each year. And what happens? So hip fractures, probably one of the biggest adverse events to happen with a fall. We're seeing, the numbers are higher than this now, about 350,000 hip fractures each year. For people over 65, it's estimated that between 30 and 50% end up institutionalized or dead within 1 year. 30 to 50% of people over age 65 that fall and have a hip fracture are dead or institutionalized after 1 year. So more than chronic illnesses, more than, you know, managing, you know, all of our the complexities of our patients, avoiding a fall and particularly hip fracture might be one of the best interventions we can put in place. Falls among adults age 65 and older are very costly, each year costing about $50 billion spent on medical costs related to non-fatal fall injuries. About $750 million is spent related to fatal falls. So they're expensive. They change people's lives more than almost anything else that we see. So I'm gonna start, we're gonna go through a couple case studies, and then I will go down the panel and we'll ask some questions. At the end of the 2 case studies we're gonna go through, we're gonna leave a few minutes for audience questions, so you can ask the panel at the end of that time. So first case study, Emma Fallen Down. She is an 85-year-old female resident, admission to long-term care, who was living with her spouse in assisted living when he passed away a little over a month ago. She's had 2 unwitnessed falls since admission, where she was found on the floor in her bathroom. She's ambulatory with no assistance devices and has not used her call light since admission. She wears glasses. She has arthritis in her shoulders, hands and knees, and occasional back pain complaints. She reports feeling dizzy at times. She has a past medical history of possible TIAs, hypertension, reflux, and depression. Her family filled her room with all of her personal items to make her feel more at home. This is Emma's list of medications. You can see this, you know, tried to formulate both cases really with, you know, pretty common scenarios I think that we run into. So you see the list of medications there. So first question, and I don't actually have a particular strategy for which one of you to start with. So I will start with Sarah, arbitrarily, as a director of nursing. So, you know, all of our patients are at high fall risk. You know, I guess one question I have, you know, are they screened for fall risk on admission? And then can you kind of summarize how you would approach someone like Emma, who is a new admission, family's trying to do the right thing, make her feel more at home, filled her room with a lot of things, but now she's already fallen twice. And kind of give us your initial, as a director of nursing, your initial approach.
Absolutely. I think we can all envision the little rug around the toilet right now. Do we all envision that? That's what I'm envisioning. So really meeting with the family and building that relationship, that is one of the things that I found those missing pieces along the way. You have a family that's engaged, a family that cares, a family that wants to really fill this apartment with love. Are they also filling it with rugs? And so making sure that we are balancing the interventions that we have available and really partnering with the family, because if we partner with the family from the beginning, we can offer interventions from the beginning and have those conversations about what would be meaningful and what do they see themselves using or not using. That way we're picking and strategizing what interventions are the most appropriate.
It's great. Thank you. And, you know, I think on that, you know, it's a transition, right, from one environment to another there, whether that's, you know, a assisted living to nursing home or, you know, home to nursing home or home to assisted living. And, you know, can you speak to any of the things that you do that help as it relates to transitioning from, you know, one environment to the next?
Absolutely. I'm probably at a little bit of an advantage working in a CCRC model. Getting to see what somebody's apartment looks like in independent living or assisted living before they move between levels of care is fascinating. You see the compensation techniques that they've already had in place. And so I think that's one thing that we can learn and really ask the right questions. What are you already doing, or what have you done previously? And let's make sure that we already have those interventions in place in that long-term care environment when they get there.
Thank you. Mindy, for physical therapy. So let's say Emma is referred over for physical therapy. Can you kind of summarize your initial approach to her fall risk, including the resistance exercises she'll now be doing a lot of? And what kind of immediate interventions could be employed to help reduce her risk?
All right. So yeah, we would not be doing seated resistant exercising. I will say that, but I will. We want to, you know, obviously look at their strength, gait speed, tug, do a full assessment to see kind of where this patient is. Specifically, I know you guys know a lot of what physical therapy does, but I just want to, in this particular case, just point out something that we saw as a barrier for potentially maybe decreasing a fall risk for a patient that had disease spells when they first admitted to our facility, was that therapy was getting, you know, nursing, CNAs, when do you guys do vital signs? First thing in the morning when patient is supine, right? So therapy gets in there and we get the patient up and out of bed, blood pressure drops. So we're seeing like more of the orthostatic issues, more of the blood pressure complications and things like that. We're picking up on that. So I was kind of keyed into the dizziness spells, like when is that occurring? And are we getting that information to the providers to make a timely change in potential medications? Because the providers, when they're in the building, seeing multiple patients at multiple facilities, aren't going to be able to track down the therapist to see, yes, you know, I am seeing this documented blood pressure change when all that's listed in PCC are their vital signs when they're supine. So I wanted, that was kind of something that kind of cued me, is that we need to make sure the therapists are putting that information in PCC. So when the providers are reviewing that new admission, that can be something that they can make an immediate change on and act upon to try to prevent a fall again. So, but obviously continuing to work with the patient to get him as strong as possible, and you know, just providing that feedback to the nursing staff on how to best transfer the patient, making sure the CNAs on the floor staff know what the safest way to transfer the patient is, and just, you know, I think communication is the key.
Thank you. And then Jennifer, this is the med list. So one question. Do facilities notify you right away, at a meeting later? How often do you get notified, and when do you get notified after a patient has a fall? And how might you approach Emma's med list?
They should notify me right away.
but that doesn't always happen, as many of my colleagues out here can probably vouch for. That a lot of times we don't know about these falls until we're in our QAPI meetings, or maybe we're fortunate enough that that facility has a falls meeting that we're able to attend and be a part of. But many cases we find out after the fact, or at worst, we would find out in our chart review when we're doing our monthly review, and then we notice that they've had a fall. So pharmacists should be in the front line of your IDT when there is a fall and notified when that happens.
So that was for everyone. And then, so Emma's medications, can you give us a feel for how you would approach her medication list? And, you know, either specific to the medications that are on here, or even generally, do you have categories of meds or things that you identify early on or try to flag as a greater risk for fall risk?
Yeah, absolutely. We've heard earlier in presentations, Dr. Wasserman, Dr. Levy, they both talked about person-centered or patient-centered care. And you take a very patient-centered, person-centered care approach with medications as well. So I can't look at one list and say it's the same for every resident every time. You have to look at more of the details. This list here, 9 medications deep, concerns me. For one, anytime we have more than 5 medications, we should be thinking polypharmacy and how can we deprescribe. First thing I look at is duplication of therapy. I see there's 2 blood pressure medications on there. I want to know what is her current blood pressures, her heart rate. Does she still require these 2 medications? I pair that with the diagnoses that I find in the chart, and on her past medical list, it was listed as hypertension. So if she just has essential hypertension, do we still need both of these? And that's a place to start and look at. Another thing that I noticed is that she had mild back pain or once in a while back pain complaints, and she's on tramadol twice a day. So when was the last time that this was reevaluated, and does she still need this tramadol twice a day? She has a PRN Tylenol. Could she be transitioned to that Tylenol, and could we schedule it? I know that everybody was thinking I was going to go straight for the sertraline and the antidepressant, but see, I fooled you all. I started somewhere else. And then I guess I would go to the sertraline and I would say, all right, well, I empathize that she lost her husband, and I do empathize with that. Maybe the antidepressant isn't the answer, because unless she has clinical depression, it may not be helping her. And so I'd want to know, when did her depression start? Did it predate this, or did we initiate this medication? 100 milligrams suggests to me that she's been titrated up, or at least I hope she has, from a smaller dose, or that maybe we could trial a gradual dosage reduction and see how she does. As you can tell, there's many steps that I could do, but I need to go back to my person-centered care, and I need to evaluate when was her depression started, or what is the basis of her back pain, or does she have other pain? What is her blood pressure? I need to take a step back.
That's great, because I would have gone straight for the tramadol, particularly with the dizziness, which again plays to how important the team approach is, right? So, you know, I think we all have our own bias and our own, you know, medication, you know, do's and don'ts. And so getting the information from, you know, pharmacy, hearing from the nursing staff and the DON about, you know, what's happened recently, what they've noticed, you know, in terms of the, you know, with the 2 falls since the patient got there, and putting that all into context.
I don't want to forget the gabapentin trauma, or the,
Well, the gabapentin would have been
Right,
stopped by Dr. John before they got.
I mean, that's a no-brainer. That's why I didn't mention it. We were just going to stop that no matter what.
So Lauren, as an administrator, how might you approach and sort of direct your team to provide interventions for a resident like this?
I think that what stood out to me the most, and what I would encourage my team to focus on, would be a little bit more of the non-prescribing team interventions here, because we know that we have a patient who's reacclimating to a new setting. We also know that she is probably grieving and at the very early stages of her grieving process. What I would encourage is what Sarah said. I'm going to piggyback off of her. A lot of family involvement, really getting information from them on how she was living previously. When we're setting interventions in place for someone with a similar story, asking them if maybe they've implemented interventions in the past that they found to be effective. I'm a huge advocate for case management and activities being heavily involved when we're seeing the acclimation process to a new facility or new level of care take place. Maybe an early on care conference, and no reason to stop with just one care conference. There's no reason why we can't have another follow-up care conference 7 days after, just to implement interventions and make sure that what we're putting into place is working. I think that in a situation like this, similar to what everybody said, the more communication that you have with the family and the more that you can get them to be involved, the better.
Thank you. And then Dr. Shepherd, as medical director, I think one question that came up, in some of our discussions, are there fall risk assessment tools that you've known about or found that are helpful in preventing falls in nursing homes?
Yeah, I think most of the fall assessment tools that are available were validated in a community setting, an outpatient setting. So that's a very different population than we have, right? We basically have a high-risk population, and figuring out who is the highest risk among a high-risk population is very difficult to do. So I usually lean pretty heavily on physical therapy and the nursing staff and the CNAs, and I find that they pretty quickly figure out who's our highest risk people.
That's great. And do you think it's reasonable to ask providers to do some documentation around fall risk? For example, a question that sometimes come up is, can you document that they're a fall risk no matter what? That there's, they're going to be high risk no matter what interventions are put in place. So kind of what kind of sort of direction might you give providers, particularly for frequent fallers?
Yeah, I think it's certainly reasonable to ask, especially if it's their first fall. Really, we should have a good clinical assessment, and a good neurologic exam looking for, was it a stroke or something, a good metabolic workup to make sure we're not missing something reversible, your hypos and your hypers, right? Hyponatremia, hypoglycemia, and electrolyte abnormalities. We want to make sure that we're not missing a reversible cause for delirium that might lead to a fall. So I think it's just good medical practice that when someone does fall, you do a good evaluation and then write a good clinical note that's, maybe given an idea of what you think is going on and why they fell, and whether or not there are interventions, non-pharmacologic or pharmacologic, that we might be able to use to help reduce that risk. I think that's just a smart thing to do it's the right thing to do for the patient, number one. And then I think it probably lowers your liability as a provider. And then it certainly helps out the facility as well.
Yeah. So on that, Sonia, as a provider, if you're like me, you just get the notification that, someone fell, but typically not any more than that. How might you approach, a case similar to this?
Well, when I was first looking at this case, I thought, well, good, she doesn't have a diagnosis of dementia, so I can ask a lot more questions about what symptoms she's having and what exactly is going on around the time of the falls. But then I thought, well, this might be, one of our first signs that she's having a cognitive decline. So if she's having some trouble answering those questions, then that's going to point me in a little bit of a different workup as far as, is this a sign of dementia onset? But of course, looking at those red flags, like her dizziness, asking more about when that's occurring and are we having other symptoms associated with that, chest pain or palpitations, that might lead us more towards a cardiac workup. And then looking at her problem list and her major medical diagnoses and kind of using that as a framework, how might any of these diagnoses be playing into her falls? We know she has hypertension. Obviously, we're going to look at her blood pressures and her medications. How is her pain maybe playing a role in this?
she's got glasses. Does she need a new visiting exam or an updated prescription? And then obviously her depression is something that we're going to look into, and just kind of going off of the problems that we know that she already has. And then also working up, she's having these falls in the bathroom. Is she having any urinary symptoms or GI symptoms? And that might be a new problem that we need to take a closer look at.
That's great. All right, this is case number 2. Julie's tip over. Again, falls aren't funny. I even debated to put the names like this in here. So Julius is an 80-year-old male. He has advanced dementia, lives in a memory unit, long-term care. He's having an average of 2 to 3 falls a month. He's ambulatory with a walker that he only uses when he's reminded to do so. He is impulsive, difficult to redirect. He sundowns, has erratic sleep patterns, and often refuses attempts at care. His past medical history includes CHF, osteoarthritis, macular degeneration, and kidney disease. He has a surgical history of a right hip fracture and right total knee replacement. He's incontinent of bowel and bladder and has recently lost weight. Again, I think this is a somewhat common patient that we run into. This is Julius's medications. Right. All right. So, Sarah, kind of back to you here. So what approaches from nursing and as a DON might you take for, and we can just broaden this to dementia. But, this is a pretty common scenario of for dementia patients, and kind of, you give us an idea of how you initially approach this and what you might do, particularly with somebody who is having pretty frequent falls.
So frequent falls are probably happening in the community as well as in the room. So I think that we really nail interventions in a room, but we don't always look at the community. What is his favorite chair when he goes and sits in the living room? Is that the most appropriate chair for him? Can we replace that chair with a different chair? So looking at that full community experience versus maybe just narrowing it down to his room, especially again, if he's impulsive everywhere that he goes. Also really partnering and supporting the caregivers. It feels really defeating when you have that person that is falling all the time. Our caregivers giving up. How can we support them to continue to come up with unique and creative interventions? Somebody comes up with a creative intervention, thank them publicly. Create a situation where somebody wants to be creative. And for me, when my nurses come up with interventions that are not as creative, let's stop re-educating that person with dementia on call light use. That is a private conversation or maybe a private email. But we want to make sure that we're really nailing those interventions and we're making it unique to them. It's having the right staff that know all those little details about that person's care that can make all the difference, and sharing all those unique little things that that person does that can help really tailor the care and make sure that we're picking up on those subtle cues that that person maybe needs to use the restroom or they're bored. And so really sharing those with the community.
That's great, particularly the sharing the success and not the failure, not just the failures, and sharing it publicly. For morale and understaffed and dealing with, patients that are that difficult, I feel like particularly with dementia patients, I mean, you're very special when you have the patience to deal with all that. So celebrating that, particularly with trying to put in interventions that take a lot of energy. So that's great. So Mindy, any strategies, or assistance devices that could be used to reduce fall risk in frequent fallers with dementia like Julius?
Well, I would say, making sure like a low vision assessment of his environment. Maybe he needs to have some bright tape put on his walker. Guess he does, forget to use it, but maybe maybe he has visual deficits where he can't see it. So if there's something that's bright, that might be helpful. If he does have that dementia, maybe he's not going to, use that or remember to use it. So we continue to work on balance with him. One thing that's super important that I find in trying to figure out good interventions with a patient is really knowing what happened with these falls. Was it really, as Sarah kind of mentioned, was it related to, was he having to get up to go to the bathroom frequently? And talking about bright colors, this is something that we use in our facility that we give out to our nurses to remind them to ask all these questions. Oftentimes I get a report that, oh, so-and-so fell last night. Well, all my questions are, where was the wheelchair? Where was the walker? Did they have shoes on? Did they have non-grip socks? And sometimes it's not in that information. So if we have these bright colored things out all over the place for the staff and hand it out all the time, then that will help to cue them to put that information in the notes so you can put in proper interventions for them. So I've got some to hand out, but just, really having that knowledge of what exactly happened, and then continually to get in there and see that environment and make that as safe as possible, and help to educate the staff. The other thing with dementia, I think is, and I was excited to hear that that's going to be something that's going to be provided as dementia care training specialists in our communities, because I think that really empowers the staff to understand where these patients are coming from, to understand why they are falling, and they're scared and can't see or whatever it may be. But unless you experience that yourself, you have no idea where they're coming from, and so it's going to be hard to find those important interventions that will help make a change.
Thank you. And those cards, can't see them. So on one side is the 4 Ps, which I have a slide on that to kind of define that. And then the other side is a list of basically a whole bunch of interventions that the staff can put in place. And it's, especially with staff turnover and, with the frequent falls, having these things literally everywhere, right? So that everyone can see it is super helpful. Okay. Jen, you have the difficult task of telling us which ones of these we should keep. No, how might you approach Julius, with assuming he has dementia and having frequent falls, how might you approach his med list?
Oh, goodness, where to start with him? I go back to my patient-centered approach, my person-centered approach, and I'm looking at the diagnoses and the medications and trying to match them up. And I see erratic sleep, but I don't really see a justification for the use of Seroquel. So I'm questioning what behaviors with the dementia do we have that render the use of Seroquel an antipsychotic for him, knowing that Seroquel will have side effects very similar to a strong Benadryl and could very well lead to these falls. The other question that comes out first is also the digoxin, and he's got CKD. Maybe I want a DIG level on him, or if that's not appropriate, maybe I just suggest that we go to every other day dosing or consider stopping it with that renal disease. So that's where I would start.
Are there any preventative medications for patients similar to this that have been shown to reduce the risks of, say, fractures or falls for that matter, or are associated with a reduced fracture risk or falls?
Yeah, there's been evidence to support the use of vitamin D and calcium, especially in our elderly population that are known to be vitamin D deficient. And patients who are not vitamin D deficient, they're shown to have better muscle mass, better muscle function, and therefore have better balance. And with better balance, reduced falls.
And I think the recent JAMA article, I think it's pretty recent, was talking to, at least looking at whether or not vitamin D specifically reduced fracture risk. And I believe the conclusion was if they did not have osteopenia or osteoporosis, then it did not. But I think what you're referencing, which is helpful, is sort of a correlation between normal levels of vitamin D and, stronger bones, patient, probably stronger muscle mass, who are moving around more. So was that a flag for time? No, okay. Damn it. So Lauren, particularly as an administrator, the patients like this take up a lot of time and attention. how kind of do you help sort of guide, the team approach to handling patients with dementia that are frequently falling?
I would say if you have a community that has a memory care unit, you're probably really focusing on activities and social work presence in there already. But I would challenge you to take a look at your system to ensure that you have the right people in the right roles, to make sure that we're being really creative when we're managing patients that are bordering, sometimes needing maybe even one-to-one care. And then my overarching philosophy is that management is not exempt from helping out with these patients. I think that the expectation and the requirement should be there for everyone who's a part of the team, whether you're a nurse or a CNA, no matter what your position is in the facility or within the company, that you should be ready and willing and able to help out when you have situations like this, where one fall for this gentleman could be fatal. It's really important that if you have the time, that you're giving it to the patients. And a really cool model that I saw recently, only a select few folks within the facility had actual offices. Everyone else, even if you were on the management team, had mobile laptop devices so that they were able to work out with the nurses at the nurses' stations, up and down the hallways, just providing these folks an extra layer of care and another set of eyes.
That's great. Can you, or actually Sarah, can you give us an idea of kind of the documentation requirements around falls? Not go into detail, but just give us an idea of the burden on staff. And then are there any different requirements for patients that are frequently falling?
So I'll start and then you can wrap up. So nurses, sometimes one of the biggest motivators is just the documentation required, all the different forms we have to fill out, especially in skilled nursing, when a resident falls. And then really making sure that we are circling back to the care plan and making sure that the care plan gets updated, that we're not missing anything. There's just so many little steps that we have to make sure that we nail every single one of them, especially with frequent fallers. You think about that person that has a fall and then heaven forbid they have a fall another hour later. I mean, this is the documentation on top of documentation on top of documentation. It gets very overwhelming. And again, very discouraging for the staff.
I would say, and I'll circle a little bit around to one of my pearls, so don't get angry. Okay. I think that if you're as an administrator and on a management team, knowing that when you have a patient who falls frequently, you're probably getting a lot of redundant charting that's not giving you accurate information. Your nurses are really bogged down. They're just clicking. They're probably not putting much thought into the responses that they are giving you. So I would suggest, and one of my pearls for in a couple minutes is having a really positive outlook on your surveys, having a really open dialogue with the surveyors. Maybe show them what your fall tools are. You don't have to hide them. It's not a secret. What you're working on, they're going to see it anyway. So you might as well sit down. Exit interviews are a good opportunity to do that, to say, hey, here are the things that we have in place for falls. Are there any of these that you would suggest we could get rid of from a regulatory standpoint? Is this redundant? Do we really need to be doing this? And seeing if you can sparse down that charting that you have the nurses doing so that you're really capturing only what you need.
Yeah, thanks. And I really appreciated that in our pre-discussions, for this panel, your mindset about a collaborative approach and to learn from each other with the survey team. So it doesn't feel, that, you're defending yourself or, that it's a punitive thing, that you can learn from each other. You can learn from the things that they've seen and make that more collaborative and carry that over to different surveys. So I thought that was a great tip. Sonia, as a provider, I know what I often think, other than the med list, is, I sort of put up my arms and go, I have no idea how to help folks like this, but how might you approach a patient like Julius, particularly as you're getting the calls saying that he's been falling often?
Well, I think we know we're not going to probably get a great history from him as far as what symptoms he's having and what's going on when he's having these falls. And so again, we need to do a really good physical exam on him and look for any new abnormalities, a foot exam, make sure he's not having any wounds that he's not aware of or calluses that could be causing some issues. But more than likely, we've done a lot of workups. Of course, we're going to look at his CHF diagnosis. We're going to look at his problem list and kind of go off of that for a framework. But if he's not having any new symptoms, his vital signs look okay. This sounds like, he's having an overall decline in progressing dementia. And so I think the real take home here is that it's time for the clinician to step in and have some expectation conversations with the family. Talk about, what advancing dementia looks like. Talk about advanced directives, talk about what we're going to do if and when he has a fall that leads to a fracture or a head injury. Are you going to want him to go to the hospital? And then explain what that's going to look like for somebody with advanced dementia to be in the ER, possibly having a surgery, undergoing anesthesia. Just get those conversations going with the family so that they can start thinking about that a little bit more and, hopefully moving towards comfort-focused care if we're not finding any reversible causes of these falls.
Yeah, that's great, particularly with, the weight loss, but just even the frequent falls can be an indication of a decline. And having those conversations early or getting, even getting someone on hospice care can avoid unnecessary hospitalizations. So Dr. Shepherd, as medical director, how would you like to see the facility approach to the evaluation of falls?
Yeah, so, I do see facilities that kind of, it seems like they reinvent the wheel every time with every fall. And, it's kind of frustrating for everybody. And I just don't think that's the approach that we want to take. A lot of the things we've talked about up here could be encapsulated in a process, right? So I like processes. So I think they can keep us safe if we do them right. So I would like to, I guess ideally, I'd like to see like a continuous quality improvement process of some kind where you formalize your process, start with, maybe a very simple process, but you formalize it. This is what we're going to do for each fall. And every time you have a fall, you do that and you look at it and you evaluate it and you improve the process and you do it again and you just repeat it over and over and over again, ad nauseum, right? And over the course of time, you develop a pretty good solid process, I think. I think that's going to work much better for most places than kind of reinventing the wheel every time you have a fall. And that's, things like this are great, right? This is guidance. This is kind of part of a process that we can use to kind of keep us on track as we look at each fall.
Great. I'm going to open it up to some audience questions and then, go through a couple of these pearls. I did want to put a couple of these slides up real quick to show you the 4 Ps, which is, some of you may be aware of, or most of you, but I thought these were really great. So these are on the laminated cards to give you an idea of, some good mnemonics and ways to approach, the fall risk strategies in the nursing facilities. And then the I hate falling mnemonic is another one that came up in our discussions that's particularly helpful. And, as a provider that's been working in this environment for quite a long time, it was really great to have these discussions. And I not only learned a lot, but I just realized how important the collaboration piece is, and how important us talking to each other is. And so, picking up on some of these, new tools, and not just for nursing homes. So I'm, moving these into assisted living facilities, which, quite frankly, there's less staff and, those patients look like nursing home patients. And so, trying to take some of these tools that, we learn, which I think most of us do work as providers in both settings, and transitioning those into assisted livings to try to help keep those patients from falling or out of the hospital. So real quick, I want to open it up to questions from the audience. You have an experienced panel here. If you have a question, just come up to one of the mics. And
I'll ask a question. I don't know if this will be unpopular, but thinking back, I'm not currently a nursing home medical director. I'm a hospice medical director. And Travis, I appreciate your point in suggesting the second patient could be a hospice referral. But I'm wondering if there's a place for the conversation with families of patients like this, saying something's going to happen. We're going to do everything we can, yet some falls are unavoidable. And it's important for families to understand that people are in our facilities because they're frail, because things happen, because we want staff to be there for them when these things happen, but to facilitate that process of thinking, what am I going to do when, or what's our plan for that situation? And maybe you talked about that already and I missed it, but is there a role, and how do you address that, and how do you document that if you have those conversations?
I'll take it. I would say that because we're running nursing homes, we should probably have a really good, strong presence from hospice in the facility. If we don't have a really good collaboration, we might want to reevaluate. And again, that connection with the provider and the team is so important, because they could jump into care conferences and make really blunt statements like that. And it's a really easy way for us then to come in and use a process that we've already seen work with partners that we know are tested and true. So palliative to hospice, getting those providers involved, as long as we have a really good relationship, even inviting that hospice team or the palliative team to come in and meet the family, maybe not in a formal setting, but just because they're already there. They probably already do have a really strong presence in the building. So it's just how, as an administrator or a director of nursing, or as a medical director, how often are you tapping into that resource that is oftentimes right in front of you?
Thank you. And I would probably just add that, collaborating with families, and that it is so, particularly on the first case, new resident, asking them, more details of the environment they were in prior to that transition and what worked for them. A lot of times these patients were living with their family members. And so just asking what they were doing at home, and can we, try to replicate that in this environment. But it also just brings them into the problem solving, as opposed to just telling them, here's what we're doing. They fell again, that type of thing. It's, you bring them in and try to get them engaged as well.
Yeah, thank you.
Hi, so my question is that as a provider, I have been involved in some great organizations where we have great interdisciplinary teams like what y'all are talking about. But what I find a lot of times is we're spitfiring all these ideas, and the communication level between the floor staff and the IDT team, there's a big disconnect, going both ways. The falls happen, we don't have the good communication there. We have the IDT team, but not the good communication downward from there. And that a lot of the times those communications are buried in an RIS or deep within the electronic chart. Do you guys have any pearls or tips on how that fluidity could happen a little bit easier and be more open from there?
I can field that one. So what we've implemented is a daily huddle. It doesn't always happen at a perfect time on every level of care, but every level of care determined what a good time was for them. And then we reviewed what interventions we have put into place for that resident day after day after day to make sure we got to every single staff member. We've also taken that opportunity to say, not just who has fallen and what interventions have we put into place for that person, but who are you concerned about falling? and asking that question ahead of time, because often the care staff see those small changes and we could maybe put in an intervention ahead of time and avoid a fall because they've noticed a change in condition early.
Actually, just follow up, great comment on the huddle. Have you done, and I know one of the, I think the QIOs would tell you, one of the best practices is, in addition to the daily huddle, is the immediate huddle after a fall. Have you had experience with that? Because that's probably your best moment in time, even with folks with dementia, who may, their short-term memory may be 3 minutes, you could actually get information from them.
Yes, we've done that too. And so along the line of the 4 Ps, we have a pea green form that we use right after a fall. And it really, it prompts the staff to look at the environment, and it really prompts all those things that we often miss, right? Are we asking the questions right away? Also, sometimes appropriate, sometimes not appropriate. Can we ask the resident to show us what happened? Because if they can show us that toilet transfer, we can sometimes pick up on those things that they didn't do as successfully or what they were trying to grab onto. And then it has a signature line for all the staff that participated in that huddle immediately post-fall. So we make sure that we're capturing the right staff members, and it's not just nursing. It is also housekeeping. It is also that interdisciplinary team that might have been in that environment right after the fall.
And that actually leads right into one of my questions, because I love how interdisciplinary this panel is. But I was going to ask, what of your processes include the CNAs, which, I mean, I gather my best intel from the CNAs. And so that it partially answers it. But I'm wondering if you guys have any other processes in place where you do incorporate your CNAs.
I can answer that. Okay. We have implemented falls committee meeting where we include the CNAs and kind of rotate them through. So it's not the same CNA giving us the information, the nurses, the housekeeping, and maintenance. And what I found is kind of, as Dr. Wasserman mentioned, is the consensus management piece of it, including the whole team and letting them give us information as to what they're seeing, and then obviously making those decisions and implementing them. It helps decrease fall risks because you're getting a bigger picture of what's going on. And it also increases employee satisfaction. So they feel like they're buying, they're a piece of that solution. So I think the fall committee piece has been helpful for us because we just are able to get some actionable items and implement them. And then like working on those processes, like Dr. Shepherd mentioned, and, developing like a system and sticking with that each time. So we're following up on that.
So I think we're out of time. The fall prevention pearls on the last 2 slides you guys have, you can read those. I do think especially the last couple comments really highlight kind of one of the goals of this was to illustrate, because falls, they do happen often. They are, probably one of the most frustrating things that we deal with. And I think whether it's the documentation requirements or the staffing burdens, or, even a sense of helplessness sometimes, as a provider, I can sometimes feel that, to realize that there are things we can do and that we do have to collaborate. And if we make it this sort of really good open communication team approach, that there are actually strategies that can be implemented even in our frequent fall population. So thank you.
Yes.
So next up, we have Erin Vignier, and she is the Medical Director of Clinical Affairs for AMDA, where she oversees the development of the society's clinical resources. She serves as the staff liaison for the clinical affairs subcommittees and is the quality improvement specialist for Moving Needles, a cooperative agreement initiative with the CDC.
Prior to her work at AMDA, she was a research intervention nurse for the University of Maryland School of Nursing, where she spent a decade educating and learning from frontline staff and leadership in nursing homes and assisted living facilities throughout Maryland. Most of her intervention work has involved function-focused care and managing behavioral and psychological symptoms of distress. In 2022, she was an American Hospital Association Next Generation Leadership Fellow, where her project focused on developing practical and effective strategies to address the current staffing crisis in post-acute and long-term care. So welcome, Erin.
Thank you, everybody. We're in the last leg of this wonderful conference, so stick with me, okay? Stick with me. All right. I have to put my glasses on now. Is that ear? So I'll start with a little story. And first of all, I want to thank Leslie and Allison and Singh for inviting me to join you today. I am from Big AMDA back east, and I'm thrilled to be here. Don't tell any of the other chapters this, but Colorado is my favorite chapter. This has been a tremendous conference, and I invite all of you to submit abstracts to our national conference, which will be in March of next year in San Antonio, Texas. So not too far from here. So you have no excuses, right? All right. Many years ago, when I used to work in Washington, D.C. in my 20s, I was taking the subway, we call it the Metro, to work one morning. I was focused intently on a lengthy book I'd been trying to finish before it was due back at the library. As I sat reading, I was aware that a man had sat down next to me. Now, the morning DC train commute culture is that you're expected to be very quiet. But this man was clearly not aware of this unspoken rule. For every few minutes, he would make a comment like, "I know that book. It's really good. And that book is very well sourced." I briefly glanced at him, nodded and smiled, and quickly looked back to my book to indicate that I was not interested in talking. A few stops later, he got up, said goodbye, and walked off the train. It was then that I looked up to politely nod goodbye and realized what an enormous mistake I had just made. This was confirmed by the smirk on the face of a fellow commuter who saw my expression and said, "Yep, that was him." In fact, the kind man who was trying to talk with me was the author of the book I was reading, Mr. Carl Bernstein. Having been a journalism major in college not too long before that, with All the President's Men being one of my all-time favorite movies, I knew I'd missed a great opportunity and have regretted it ever since. For those of you back there who don't know what I'm talking about, Google Watergate. We probably all have a similar story where we've been so focused on a situation or problem at hand that we miss the opportunities, the solutions that are all around us. Oh, sorry. I'm skipping ahead. Skip ahead if you, okay, the solutions are all around us. The resources, people being most important of all who can help us. Skip ahead a few decades, and as the clinical affairs director at AMDA, I decided I was too thin-skinned to be a journalist. I was sitting in meeting after meeting, listening to AMDA members and others talk about the overwhelming staffing crisis and being at a loss for what to do. But what I wasn't hearing were solutions yet. But when I looked at articles online and started listening in on other meetings with different groups, I found that some people were talking about solutions, that there are evidence-based strategies for increasing staff retention and recruitment, and people were trying to implement them as best they could. Coincidentally, at the same time, I was the next generation fellow of the American Hospital Association. I was just excited to be considered part of the next generation, where I was asked to create a project to improve care in post-acute and long-term care settings, while also incorporating the 4 M's of the age-friendly health system. Now I will show you that. A successful evidence-based initiative of the Institute for Healthcare Improvement and the John A. Hartford Foundation. One afternoon while I was walking my dog, I had a light bulb moment. I stopped thinking about the overwhelming staffing crisis that we had been talking about on that morning's call and looked up. What many of the discussions about solutions to the staffing crisis were lacking was a framework to effectively collate these solutions to strategies, to share them, and to implement them for real impact. But there was a way to do this, and it was right in front of me. What if we took the same 4 M's that we use to improve patient care, what matters, mobility, mentation, and medication, and expanded them to apply to our staff? After all, how can we have an age-friendly health system if we don't have an engaged, fulfilled, and healthy staff? And there were ideas and solutions all around. Lori Porter of the National Association for Healthcare Assistants was working on career mobility for CNAs. What matters to staff? We had learned during AMDA's Healing Together campaign with Lea Watson during the height of the pandemic about how critical trust, respect, and having a voice is to our frontline staff, in addition to increased pay. Mentation, we talked about a lot, compassion, and mental health during the pandemic as well. And what about medication? What about the physical well-being of our staff who often don't have health insurance, don't have opportunities to exercise regularly or access to healthy food, or don't have enough food at all? What if we got stakeholders around a virtual table to talk about these ideas, develop and share strategies that have already been tried and found to be successful, and create a way for leaders in post-acute and long-term care to access these strategies and implement them? And so, more of a good thing was born. We were really honored to have Joanne Reifsnyder, who was my mentor during my fellowship, be the moderator for a series of 6 roundtable discussions that started last April and ran through September. And with additional funding that we may be getting soon, we hope to continue those roundtable discussions. So today I'm going to talk to you a little bit about some of the highlights from those 6 roundtable discussions, especially the last one where we talked about the role of medical leadership and our next steps moving forward. Our philosophy for these roundtable discussions was the ECHO model of all teach, all learn. And we also borrowed IHI's small tests of change philosophy, meaning what can we do by next Tuesday? We're understaffed now, so we're limited. Our budgets are limited. How can we collate and disseminate these insights that we share during the roundtable discussions in an effective way? So we had Joanne Reifsnyder, as I said, who had been the chief nursing officer at Genesis Healthcare during the height of the pandemic and is now a professor at the University of Maryland School of Nursing, teaching nursing leadership. I was excited as I listened to a lot of the sessions today because so many of them touched upon some of the things we're touching about here. They all interweave so well. These were the 6 roundtable discussion topics, and each of them addressed one of the 4 M's that I mentioned that we expanded for staff. In April, we did a kickoff of the 4 M's with Emily Nicole, who's an NP and Chief Nursing Officer at United Healthcare. In May, we did a very special session. It's the only one we didn't record, and I can show you at the end of this where you can find the recordings to the other sessions. We did a modified Schwartz round, which I'll talk about in a few minutes. In June, we did career mobility and shared governance, which I think we talked a little bit about today. In July, health promotion and stress management. August touched on trauma-informed care for our care force, which Lea Watson did a wonderful presentation on earlier, except this was for our care force rather than just the residents. Finally, in September, we did developing leaders for the future. Our first small test of change really came and was inspired by Lori Porter, who I mentioned is the CEO of NACA, where she coined the term care force in place of workforce and actually introduced it to the HHS secretary when she went to meet him, and he really liked it. So we started using it at AMDA. We actually have a new workforce development committee that has adopted care force as its name. So I see 2 people who have attended the roundtable discussions in their emails and in other articles are referencing the care force. So we consider that a true small test of change. As I mentioned, our second session was a modified Schwartz rounds. Is anyone familiar with Schwartz rounds? In there? They're tremendous, and I really encourage you. You'll see a link at the bottom of that slide to a YouTube video, which does an overview of what it is. I don't really have time to go into it extensively today. The idea was founded. It's the Schwartz Center for Compassionate Healthcare, which was founded by Ken Schwartz back in 1995. Ken died of cancer, and before he died, he journaled and he talked about the compassion that was shown to him by his doctors and nurses and others in healthcare, and what a huge difference that made in his life as a patient. And that doctors and other healthcare providers should never forget the role that compassion plays in healthcare, no matter what role of an illness they're in. And so with these Schwartz Care rounds are regularly scheduled, structured conversations. Oh, I think I skipped. Oh, there are conversations that happen monthly at hospitals. Generally, they've been in hospitals, but I really would love to see them done more in long-term care, where employees come together and talk about issues and things that have grief, trauma they've experience with a patient, the loss of a patient, and they can really open up. And those are moderated by someone who's been trained to moderate it and support that person, along with the other people in the room. So we were really honored to have Dr. Beth Lone, who's the Chief Medical Officer at the Schwartz Center for Compassionate Healthcare, came and did a modified Schwartz rounds with us on our second term. So on our second roundtable discussion, we had a medical director join us, a nursing assistant, and a nurse. And each of them shared their story about how compassion affected them personally during COVID-19 and how it had a positive impact on their lives. Dr. Lone also talked a lot about the cultures of compassion and how they're built on social support, and really made the roundtable attendees think and consider the role. I don't know how I keep hitting that. The role that compassion plays, and if whether or not their facility really has a culture of compassion and how they can begin to build that. During Schwartz rounds, they found that caregivers who participated in multiple rounds found that there was improved teamwork, there was improved interdisciplinary communication, decreased feelings of stress and isolation, and increased insight into social and emotional aspects of patient care. Someone here who gave me permission to use this quote participated in this very special session. And Dr. Leslie Eber was a medical director who joined us and shared her story. And I'll read the quote that she had. It was in that moment in December of 2020, when we were talking about the vaccine and the CNAs and nurses were telling me about their fears, what their families were worried about. It was then when I realized we were trusting one another and developing something authentic. It was my proudest moment as a medical director. The next week, those same CNAs and nurses lined up to get their COVID-19 vaccine, and I thought to myself, building these trusting relationships is everything. Our third roundtable discussion focused on career mobility and shared governance. And one of the most important things that was discussed, which I think a lot of our attendees found really interesting, was to talk about career mobility. We think of career mobility being only upwards, when in fact it can be downward or lateral, and we need to support all of those options. And she gave the example of a DON who maybe had a lot of responsibilities going on at home, had young children or an older parent to take care of, and really didn't want to have the responsibility of being a director of nursing. Well, rather than let her go, they offered her a position as a floor nurse. And she stayed, and they retained that person with all of her knowledge and expertise and knowledge of the residents as well. So rethinking what we think about career mobility, in some cases, we need to destigmatize if someone needs to step down to a position of low responsibility, that's okay. And we can encourage that and make that a reality for people. Allowing career flexibility, which I think was mentioned earlier, noting the skills and talents of our staff. Some staff that were working in dietary in the kitchen, they noticed one of the women there was really interested in talking with the residents and doing activities with them. So they offered her an opportunity to lead activities and other times during the day, or to come in and earn extra hours by leading activities. So just being creative in how you can use the staff that you currently have. Again, something also mentioned today, kudos to us, make it visible and tangible. Where's my DON who mentioned it? Make it public, elevating employees through recognition, celebrate achievements, large and small. I know the presenter here, Erin Woodford, was talking about how embarrassed she was to learn that one of her CNAs had been going to nursing school at night and was almost ready to graduate, and she had no idea that was going on. No idea at all that she'd been going to nursing school. So they put up a bulletin board, and when anyone achieved a new certification or a personal goal, they made that public so everyone can see it. Another thing they did was they used name tags. Simple things that you might think now might be a big deal are a big deal to CNAs who often are overlooked and not recognized. They knew one CNA was so organized and knew exactly when they were running low on supplies. So they made her the supply clerk and put that on her name tag. Or someone who's a mentor to other nurses became an official mentor. So things like that, and being creative of how we can acknowledge some of those extra things that our staff are doing. We also had a session on health promotion, and we had a great presentation by Kelly Duran, who's done a lot of research on corporate wellness programs and building them. And her key highlights were to stress to start small with one program that staff has indicated is their priority, not management, asking staff, what's important to you? What can we start with? And start small. They found that the most successful programs started small, and those were the ones that were able to sustain it over 5 years. So don't try and do everything at once. Pick one thing. Maybe it's diet or smoking cessation or physical exercise, and see what you can build. Allow flexibility. One facility allowed staff to use the residence gym before and after shifts. They made it fun. Staff said in her studies, that's why they stay engaged. It was fun. They weren't competing with each other. They enjoyed competing against themselves and being a team. Education was often needed around health topics. They realized when they started talking about a healthy diet, then they needed to take a few steps back and really start at the food pyramid and teach them about what is healthy food and what makes a healthy diet before they even can begin to go further with that. They also noted that only 20% of employees offer mood, stress, and depression programs for staff, yet staff consistently say that is what they want most help managing. And there are a lot of free resources available about that. They want to make mental health visible, destigmatize it, and prioritize that. And I think post-COVID, talking about the trauma-informed care, that's something we need to remember. How can we expect our staff, who a lot of them are in lower income areas, they have issues at home, struggle with transportation. I know one of the pilot sites, even in our immunization project, they're losing staff because they're in a rural nursing home. And if they don't have a car and there's no public transportation, how are they going to get there? So they're dealing with all these other things, and we can't expect them to drop all of these things at the door and then come in and put 100% towards our residents if we're not acknowledging that they're going through stuff too and doing the best we can to help them. Leadership is critical as well, as we know, and has been echoed throughout the day here. These were some of the things on a pilot worksite heart health promotion improvement project that the CNAs noted were, this is their feedback that they found helpful. Constant education and tip infusion, low pressure, teamwork and support, making it fun, having prizes and competitions were important. Some of the barriers, as you can understand, here's the vicious cycle. We're talking about staff shortage, right? We don't have enough staff, and now you want that to take them out so they can do these programs. But in the end, in the long run, building this trust and showing that you are caring, that's how you build trust, is caring, showing the staff that you care about them. I know we learned a lot during COVID with immunizations that they felt that, thank you. How many minutes? I have my readers on and out. 5. All right. Showing, so the staff that you care about them, they would tell us 1 minute we're heroes, and now you're telling me you're mandating a shot. You didn't care about anything else. You don't care that I have enough food at home or I can't get to work, but now all of a sudden I need to get this shot. So we need to start at the foundation of trust and showing that we care about all of their health, not just getting that COVID shot, but we care about their physical well-being as a first step to building that trust. These are some of the slides she showed with a lot of the free resources that are available out there as well. The mentation, trauma-informed care was another special session we talked about with grief as well. And I won't go too much into this because Dr. Watson had a terrific session earlier, but we did have Paige Hector, who she mentioned, and Nancy Cosmal presented on trauma-informed care for staff and how important that is. And then finally, our last session was really focusing on the role of the medical director and others in leadership in the staffing crisis. When I first mentioned that this was going to be the topic of my fellowship project, I actually had some of our AMDA members who are medical directors tell me, this isn't our thing. Staffing, that's that we're out here doing this. Staffing, that's really a DON, that's administrator, that's not medical director. Fortunately, there were enough other people to say, whoa, yes, it is. If you're not part of the solution here, you're part of the problem. And so everyone has a role in here. And to be visible, we had Nancy Istanes, who's a CMO at Sabre Healthcare, and Shauna Asanzadi, who's a new geriatrician, come on and talk about the role of leadership, holding medical director hours to encourage staff to stop by and get to know the medical director, be visible, create an intersection between frontline staff and leadership, encourage those CNAs. I have a special place in my heart for CNAs. Encourage them to speak first during team rounds. It helps them feel heard and valued. We heard over and over again, yes, they want to be paid more. They do, but they also want their voices to be heard and they want respect. Build relationships with them, search them out. As is mentioned earlier today, they are the first ones often to notice when something just isn't right with a resident. They may not be able to pinpoint what it is, but they know something's off. And we've had countless examples where that's led to the discovery of infection and other illnesses. So have lunch in the break room with them. Stay on site to do your documentation instead of leaving and doing it from your office. When you ask employees questions, they'll start to ask you questions. Show them you care about them. Talk about personal stuff in the lunchroom, your families, hobbies, things like that. And then AMDA is working on raising awareness of staffing needs at the national level. We all can be involved in political advocacy about this. We mentioned staffing mandates are coming, so we need to be ready. How many of you, got it, I'm right there. How many of you have tried any of these, any of the things I talked about of the 4 M's for staff in your facility? Anybody, any one of them, name tags, bulletin boards, anything like that? Not yet? All right, if you have, and Dr. Wasserman alluded to this, you have people that stayed, right, during COVID. How many had staff that stayed with you, didn't leave? Why did they stay? Do you know? Have you asked them? That's where we start with appreciative inquiry. So instead of focusing on who we don't have and the staff we're missing, let's take a minute, look at the staff we do have and ask them why they stayed. That's appreciative inquiry, which is a philosophy. It's not a technique, it's a philosophy. Focus on the strengths. What are their dreams and plans? What made their best day so great, and how can you make more of them? It creates an atmosphere of possibility and it brings excitement back. People want to talk about their successes. They want to actively engage in conversation and focus on what works. So look at pick one thing I presented today and try it, and keep trying it and tweaking it till it works. And that's what you can build from. Whether it's sharing positive stories, people gain confidence in their ability to deliver. And it's their experiences that they can build upon, not someone telling them what to do. But if they start these experiences and have successes with retaining staff, then they're going to be more apt to keep doing it and build upon that. Who knows who that is? Yes, look up, that's a reminder. Key takeaways: evidence-based strategies to grow and strengthen the PALTC care force. They're out there. They're out there. There's been a lot of research about them. The issues, we aren't doing it. We aren't sharing it in a consistent and effective way. Start tomorrow. Each of the 4 M's we discussed includes something you can begin doing immediately. And I want you to think, as I leave the stage, what of the 4 M's will you choose to focus on Tuesday? Which idea presented can help you most? And then here, you can register for the series. We're going to be picking them up again this summer. And also that PALTC.org good thing is where you can find all of the recordings of the 6 roundtable discussions that we did and the slides. Thank you.
Good afternoon. It is my pleasure to introduce our next speaker, Dr. Heather Heiser. She's a neurologist and a 2nd-year movement disorder fellow at the University of Colorado, and she will be talking to us today about the best ways to care for our Parkinson's patients who are living in PALTC. Please give a warm welcome to Dr. Heiser.
Hi, everyone. Yep. Okay.
As she said, I'm Heather Heiser. I am a second-year fellow at the University of Colorado for movement disorders, which our big disease is Parkinson's. So that's what I'm going to focus on today. I have a lot on my slides. I hope they're great references. I'm probably going to fly through a lot of it and focus on the pearls that I really want to bring up with all of you. So these are the objectives. Again, I'm going to kind of fly through because there's various different things I want to get to by the end. But I hope that with this, we can get our patients looking less like the left side and more like the right side. If you didn't know, Alan Alda actually has been diagnosed with Parkinson's and still out there winning awards. So kind of just getting the base of the pyramid, quick review, Parkinson's is a clinical diagnosis. And I will say there are several instances where I've had patients who've been living out in the world and their family doesn't notice these slow incremental changes. And then they finally have to move in because they've had too many falls or something else has happened into LTC, and everybody says, whoa, whoa, whoa. Has anybody ever told you that you have Parkinson's? So this, I always bring up that it's important that we can diagnose right there in the clinic, and that it's really not a tremor disorder. It is a bradykinesia disorder. It is slowness of movements, and people don't get into LTCs because their tremor is bad. It's because they start having falls, is because they're starting to move slower and having more difficulties with mobility. Obviously, there's a lot of supportive features, and I will say that a lot of these components are actually some of the worst for our patients when it comes to quality of life. And again, my highlights are kind of my pearls. The DAT scan is not necessary for clinical diagnosis, and I'll go over that briefly. So do not think that you need to be spending that kind of money for a diagnosis. My other big thing is red flags for atypical Parkinson's. Vast majority of patients are going to be Parkinson's, but about 10 to 15% of my patients have an atypical Parkinsonism, and they're going to have a much different trajectory. So it's important to note various different things. And this is really supposed to be the trigger of there's plenty of primary care docs and people out in the community that can diagnose with Parkinson's, but these are the red flags to really say they need to get in with a neurologist and really see if this is not just Parkinson's disease. My last thing is also with diagnosis, they cannot have concurrent exposure to neuroleptic drugs. If you have something that is blocking dopamine, they will look like a Parkinson's patient. And I would say about 25, just on my personal note, about 25% of my patients that come in for a diagnosis of Parkinson's, it's actually drug-induced Parkinson's, which is a lot nicer conversation to have than telling somebody they have a neurodegenerative disease. I can tell them that they probably just need to get off a med. So again, briefly, DAT scans, because I think there's a lot of confusion with this. So DATs are a SPECT scan, a spectroscopy scan. They're looking at the dopamine transporter protein. This is known to be decreased in Parkinson's patients. So instead of a comma, they'll look more like a period. FDA approval is for differentiating Parkinson's from ET. I will argue that a neurologist can do that and does not need that scan for that. Most Parkinson's docs actually use it to differentiate idiopathic Parkinson's from drug-induced. If we're really having a hard time differentiating that, like we take them off meds and they're still looking pretty Parkinsonian. Again, just a few drugs have to be halted prior to this scan if you're ever thinking about ordering it yourself. And the FDA lists all of those. So I wanted to kind of blow through that because I think I really want to focus more on, a lot of these patients are coming already with a diagnosis of Parkinson's. And their big question is, what does my future hold? And your big question is, what does this patient's future hold? So lots of studies about this, and it's obviously always changing. People typically live, this is a chronic disorder, they live fairly long periods of time with these diseases. I will argue that the 6 to 14 years that's been recorded in a lot of our meta-analysis has a huge heterogeneity. That curve, that tail goes on pretty far. I have patients that I've been taking that have had it before I was born. So they, it's very, very different. And really, I think it's important to kind of differentiate the difference. There's these subcategories of Parkinson's, and I think that's important for you to, in LTCs, you're seeing these patients for long periods of time. You're really going to be the ones that are going to be able to differentiate that mild motor predominant living with this disorder for decades versus our kind of more malignant ones. And really, there truly are, these patients are very, very different in their paths. I also think it's important because everybody, when I diagnose them with Parkinson's, one of their first things is, I'm going to die from this disease. And I have to kind of backtrack and talk to them about, really the death that's listed on the death certificates of Parkinson's patients are no different than their colleagues that don't have Parkinson's. This is a chronic disease. It's disabling. I do not reduce what that means to them, but they're probably going to die from something else. I will say, though, I always tell them my two biggest things that can lead to mortality, which we've already obviously talked a lot about, is falls and dysphagia. So I'll kind of get into both of those a little bit later. So I am so happy you guys asked me to come to this one, because I think kind of like cross specialty interactions is really important, but also this was a learning thing for me, because I was like, I haven't really looked at the literature that's coming out of like LTC literature. And so with that, I kind of reviewed it, did a little PubMed search. There's not as much as I was that we all hope for research, but there was a literature review. I believe it came out in 2014. This was through the CMDA journal, I believe. So this was really looking at kind of a demographics, more of the population of Parkinson's and LTC, but they did focus a little bit on different, what do I want to say? Other interventions. That's what I was trying to look for. But kind of from a demographic standpoint, this is very common to have in a long-term care community. Anywhere from a quarter to a half of patients with Parkinson's will live in LTC at some point, typically on the older age, with the average age of diagnosis is in the mid-60s for our Parkinson's patients. Typical stay is 2 to 3 years. 50% are wheelchair bound, which is very different than the rest of the community, which I think kind of rolls into that compared to their non-LTC colleagues. They report more off time and less dyskinesias, which I will kind of get into the importance of that when I talk about medications. I was very surprised to see that only 23% of Parkinson's patients were on levodopa in LTC. I think I have a lot of grain of salt with some of this reported, because they also said 2 to 3% with hallucinations and delusions, which I know is vastly lower than what I've experienced with any of my patients living in LTC. So I do think the dementia side is very, very important. I'm going to talk about that as well a little bit later. And then I also just bring up 37 were on dopamine blocking agents. So even if they did have a diagnosis of Parkinson's and they ultimately were put on on these medications, they're worsening their Parkinson's with these. And I'll talk about alternatives for those. So this review also looked at some studies that did some improving on outcomes, and they saw that we were talking about hip fractures, so that if they have continued neurologic follow-up, they have a lower risk of hip fractures, and they also have a lower adjusted likelihood of death, probably a lot because of those hip fractures. So I just kind of, again, kind of that cross specialty, please make sure they're seeing their neurologist still. I love seeing all of my patients throughout their entirety of their care. But also, I mean, we have to take into account there's not enough neurologists. I always hear that. So there's a lot to be done with just education at the staffing level. There was a small little study that looked at PD specific curriculum involved in education for staff, and that their outcomes were much better as well, improved quality of life for the patients, decreased falls. So even just doing it, even if they can't get into a neurologist, making people more aware of it, which is why I'm so happy to be here today too. I went backwards. Okay, so talking about medication, and I could literally spend 3 hours on this. But there is essentially like the initial medical therapy, which has really changed over the years. Levodopa used to be held onto because you only had so many good years. That's really, really fallen out of favor. We start levodopa as early as possible. But I kind of want to talk about the later advanced times, because that's probably when we're seeing a lot more of the patients getting into LTC. One, I always want to bring up that it doesn't necessarily mean that they are no longer a candidate for advanced therapies. Advanced therapies being DBS, advanced therapies being focused ultrasound, which is getting a lot of jazz right now. But also that sometimes it's this is where really the art of medicine comes in as opposed to the science of medicine. And those medications become very, very finely tuned. I always harp on my patients who are getting provided their medications by another person. They are no longer in charge of their medications, how very important it is for them to let them know that they need to get these medications on time. I have a lot of patients who are getting their levodopa BID at 6 in the morning and 6 at night, and they're off for the rest of the day. So I always just kind of harp on that. The other thing is, I often have to talk to patients about it's okay if we need to back off on medications eventually. Typically there's an escalation. And at some point, as we'll kind of get into, they start developing dementia, they start having more falls, they're getting a lot of delirium. A lot of my medications actually worsen that. And we have to have that talk with family. Is it better for them to be less delusional, less psychotic, or walking at this point? And a lot of times families are like, maybe they should spend a little bit more time in the wheelchair. So it is a really, really hard topic because patients have had such great benefit for their meds for so long. It's difficult to have that discussion, but it's important. This is just getting into, I really wanted to emphasize that do not wait to start levodopa therapy if you diagnose somebody with Parkinson's. There is a lot of historical inaccuracy with this in that levodopa causes dyskinesias, the disease causes dyskinesias. Whether patients are started at the beginning of their disease or 6 years into their disease, at 6 years of having disease, whether they were diagnosed or not, they're going to develop dyskinesias, which are those kind of writhing movements. And I also emphasize they are not inherently problematic. This is very classic that a family member comes in to talk to me and they're like, he won't stop moving. And I'm very bothered and disturbed by that. He's constantly wriggling all over his seat. And I talk to him and he's sitting there wriggling all over his seat. And I say, hey, are those bothering you? And he's like, I feel great. And I say, if it doesn't bother you, it doesn't bother me, unless it's leading to falls. And dyskinesias can get so bad that they do lead to falls. That's obviously a different discussion. But if they're just a little too moving around and people are like, he's just so fidgety, it drives me crazy. I'm like, but it doesn't drive him crazy. And they do show that they've actually shown that people with levodopa-induced kinesias, at least in the mild form, have an improved quality of life compared to those that don't with Parkinson's. So they're not always bad. Briefly, advanced therapeutics, please get them in to see a neurologist if they're having a lot of fluctuations with their drugs, because these really help with fluctuations. And that's really when we trigger to do this. So we have deep brain stimulation, which can be there for the rest of their life. I have several patients in LTCs that are still coming in for their battery changes on clockwork. Enteral suspension, which I'm not going to get into because we're having a lot of troubles actually having that anymore in LTC because insurance is not paying for it. I'm really hoping that down the line, we're going to have a change in this in getting the phoscarbidopa, levodopa, which is the subcutaneous form. FDA is kind of slowly moving forward with this. We're hoping by the end of next year that we're going to have this as an option, which hopefully will be a lot less invasive than a G-tube. So wait for that. So again, whirlwind. This is one of my favorite pictures because truly most of my life is actually underwater with my patients than above water. So the motor symptoms are what we see and what family sees and what ultimately gets them diagnosed. But what affects their quality of life is what we don't see. And they're not going to talk about this unless you ask about it. So I'm going to go over some of my big ones. Dementia. So everybody's probably very familiar with this. Parkinson's disease dementia is very common as we get farther along in the disease. And this is honestly, I mean, it's not not giving the diagnosis of Parkinson's that make my patients cry when I give them that diagnosis. It's the fact that they often, if they have any familiarity with it, is that there's a very high chance of dementia. I always preface that it can be just mild cognitive impairment that they're not even aware of. Maybe they can't drive anymore, but our quote unquote kind of really difficult patients will have pretty severe dementia. And it obviously looks very different than Alzheimer's, very much more in that executive function. They're having a lot of impulsivity. Visual spatials, they're having a lot of hallucinations. They're very well formed. They look like their family members are in the hallway, so they're walking out of their room in the middle of the night. They think there are squirrels crawling. Squirrels are like the thing. Like, that's the animal that everybody mentions. So they're like batting away at squirrels. And they're falling because of that. I always just highlight that these are the patients that acetylcholinesterase inhibitors actually work in. So I know a lot of people, and obviously we're trying to focus on polypharmacy, but these are my patients that are actually having improvement on that. So really consider it in these patients. Obviously not our more severe ones, and we'll talk about that. But just to remind that rivastigmine is approved for Parkinson's disease, dementia, and dementia with Lewy body. Though to reduce pill burden, I often actually just personally used an Episil, just because patients are more willing to take one pill as opposed to two. But our patients, sometimes that's not enough. We do have to involve, kind of the heavy hitters. And this is, again, I just kind of really harp on, please avoid olanzapine, haloperidone, risperidone. I have so many patients that come in on this and they're just looking so much worse and they're not walking anymore because they're on these. I will say, from most of my colleagues that I've been trained with, we probably use quetiapine as our most common one. Seems to very much have less effect on their Parkinson's compared to a lot of those other classic, especially the typicals. Pimavanserin is the only one that is actually FDA approved. But I will say that we find that quetiapine, from just a clinical standpoint, we've had a little bit more success on in our patients. I will also mention clozapine. I wish I could get everybody on clozapine. It actually helps with a lot of Parkinson's motor symptoms. It's just convincing family members and patients who are already psychotic to get weekly blood draws, which is pretty hard. But it is very helpful for Parkinson's patients. Okay, really run through constipation, urination. Don't forget to ask them about this. My one takeaway with urination is I strongly caution against antimuscarinics. I really like using Mirbitrek because it has a lot less CNS penetration if insurance will cover it. And then also consider, again, Botox has a lot of use in my world, and I don't do this, but I very frequently refer to urology for Botox injections once every 3 months. Patients really love it. And then they don't have to worry about taking a pill about it. Dysphagia, probably my biggest thing. It's first visit. I always ask about it. I always really focus in on it because I tell patients this is, if you are going to pass from your Parkinson's, it is likely going to be this or a fall. So I get speech involved early and often, and most of the patients are going to say no, they don't have any problems, and it's not true. So when they do swallow studies, many patients who say that they didn't have issues do in fact have some level of oropharyngeal dysphagia. Again, I'm not going to belabor all of this, but orthostatic hypotension, which we talked about, so going over polypharmacy, Parkinson's in and of itself is kind of its own blood pressure med, so they probably have to go off of all of those meds eventually. And then, obviously we start non-pharmacologically, but I do have plenty of patients later on in the disease that are on midodrine, fludrocortisone, and that's necessary for them to be able to walk. So sorry, that was kind of whirlwind because this is my most important slide, I think, personally. And this is my last slide. Great. Okay. So palliative care has really become one of the, we talk about, like, Parkinson's was found many years ago, and we pretty much have the same drugs that we've had since the 1960s. But there's a lot of things that we can do to improve our patients' quality of life. And that's really what I got into this for. And palliative is, I like to think of myself as everything I do is palliative for these patients. I don't have something curative. So I think there's been a really big push, and I really recommend everybody going to the website that's like down at the bottom there through the Parkinson's Foundation. They've been really pushing this in the Parkinson's world. I don't bring it up necessarily on my first visit, especially when I'm giving a diagnosis. But, within that first year, I think people should be having their first palliative visit. And that's for patients who have palliative available, but, we all do some degree of palliative. So really making sure that you're talking about maybe on that year anniversary of meeting them, make sure that all their advanced care planning is in line. Providing caregiver support. So this is actually my main interest in research is caregiver quality of life and outcomes. They are extremely burdened. And even when they go into LTC, there is no decrease in any kind of burden to that wife or husband or children. So especially at the advanced stages, I'm spending a lot more time with families as opposed to the patient themselves. So never forget about kind of that they're part of this dyad. And then we mentioned too, having a really strong relationship between our LTCs and hospice and getting them in earlier. There's been studies showing that patients only last about a couple of weeks with Parkinson's in hospice, and we actually consider that too late. We'd really, really like them to have it months and months in advance. They can keep up with most of their meds. We can keep DBS on. So I think one of the things is kind of stepping back and looking at what is it about this diagnosis that really affects our patients from a palliative standpoint. And I really love Dr. If you guys have ever heard of Dr. Kluger, he used to be here. He's very much involved in Parkinson's and palliative care now on a national level. But in one of his articles, he really talks about how Parkinson's challenges personhood. These people's bodies slowly shut down. They become quieter, they become smaller, they become frozen in their body, but they're still having so much of that internal life. So really kind of addressing with them that you recognize that their personhood is still there. And even though they're the quietest and maybe the caregiver is talking your ear off, ask them questions to make sure that they're not just a wallflower, because they often feel like that. It affects their social relationships, and patients typically isolate because they're fearful that people are going to notice that tremor or notice that they hunch over or they have troubles walking or they're freezing. And isolation affects quality of life, and isolation affects mortality. People die earlier when they isolate. So socializing is critical. And I think that's really important because a lot of my patients have apathy, that those in their LTCs are actually pulling them out of their room and getting them involved in those social activities because they're not going to do it themselves. And then always, really consider the spiritualism, existential crisis. This is something that my patients don't bring up, but I'm always surprised how much of they spend a lot more time with the chaplain in our palliative clinics than anybody else. So making sure that they have access to that as well. And I think I'm just coming in under time. These are my references. Please feel free to review these. There's a lot of really great pearls in here. And I thank you so much, guys.
Okay, we're in the final stretch here. I'm very happy to introduce our last presenter, Dr. Sunny Lenneber. She's a pharmacist and a professor in the Department of Clinical Pharmacy at the University of Colorado School of Pharmacy, and she provides clinical pharmacy services in geriatrics at the University of Colorado Hospital Seniors Clinic, where she also precepts students and residents. And she also serves on the expert panel for the American Geriatric Society updated Beers criteria. Today, Dr. Lenneber will be talking to us about the very important topic of deprescribing. Please welcome Dr. Lenneber.
Thank you so much. I'm going to summarize the whole meeting right now with working in geriatrics is tough. I've heard some of the other speakers mention things, and deprescribing is also a really tough topic. And I do want to say that I'm going to present today some tools, hopefully, that you can utilize. I'm going to present some shared decision-making principles, and we're going to talk a little bit going through a patient case. So let's talk about shared decision-making. One of the things that I think is really helpful when we think about deprescribing, and when we think about deprescribing in general, that could mean stopping a medication, it could mean thinking about stopping a lot of medications, and it can mean tapering down or just reducing doses. But when you think about doing that, and especially as a pharmacist, I'm just looking at black and white. I'm looking at the patient's medication list. And that's really something that is leaving the patient out of the discussion. And so one of the most important things is having that discussion with the patient or with the family members and with the medical care team, because the team may often have their own thoughts about this as well. So I think it's really important to start first with that discussion about what is deprescribing and why am I using that term with your patient? And this is part of the normal prescribing process. So when we think about prescribing, you know, we are adding medications, but part of the normal process is actually reducing medications. And when we think about that, the first question I like to talk to patients about is, what is the medicine that you want to stop? Because if the patient already knows that they fell and they're on gabapentin and they don't feel good when they take it, maybe they already know one of the medications that they should stop, and they're more likely to be able to help you do that if they have been the one to choose that medication. So knowing that options exist is really important. One option might be picking a better pain medication, like Jennifer mentioned in her presentation, Tylenol. Maybe Tylenol is a better choice and it can still treat the pain. Maybe no drug is a better choice. Maybe physical therapy is a better choice. So what are those options? It's also really important to discuss the benefits and the harms. There are benefits to drug therapies. There are harms to drug therapies. There are benefits to stopping drugs and harms to stopping drugs. And then really discussing what are the patient's preferences. So I want to show you a picture of my grandmother. She was a legend since August 1919. This was on her 100th birthday where we had a party, and she made it much past 100, living in an assisted living setting only at 101. And then she passed away, ironically, after today's discussion from a fall. So she fell, broke her hip, and made it through the surgery, but then her heart stopped after the surgery during recovery, 1 month short of 102. So she lived a great life. She lived on her own in a farm in Kansas for a long period of time. She also hoarded drugs. I found penicillin ointment in her fridge that had expired in 1965. But you know, she was very functional. So you see that you see that functional person, and that's a lot different than a 100-year-old that's more, you know, that has dementia or that has more comorbidities. And so the goals of care for those patients, the time to benefit may be different. So when we think about goals of care, and I'm speaking to the choir here, but how frail is the patient? How do we know that? Is the patient more interested in palliative care? I love the idea of having palliative care right away in those Parkinson's disease discussions. What are the patient's quality of life goals of care? Is it that they want to be able to do an activity without having urinary incontinence? Or is it they're past that now and they have different quality of life goals? But unfortunately, it's not a one-time stop that you can ask these questions. It has to be a continuous discussion because goals can change. And when we think about medications and other treatments, time to benefit is really important. So when you start that or that intervention, or you think about starting it, when is that intervention actually going to provide any benefit to your patient? And are they going to live long enough to benefit? So one of the tools that's really awesome for this is ePrognosis. This is a University of California, San Francisco website, but how many here have used this before? Okay, great. So some of you have used it. I would encourage all of you to check it out. And it doesn't really matter what setting you're in, because this website does have tools to help estimate prognosis in the ambulatory setting, excuse me, in the nursing home setting, with patients with dementia. So it has a lot of different tools. This specific one here, the Mitchell Index, I typed in some information for a patient who's living in the long-term care setting. And this particular tool you can see on the right-hand side, there's red and green. And this is really where you can move the bar on the life expectancy you get on the left-hand side with the treatments. And you can move the bar to where that patient fits. And you can see in the red, nope, not a good option for this patient. Green, yep, it will be a good option depending on where that bar hits. So for example, it has colorectal cancer screening based on a 1-year life expectancy. That's not worthwhile. And, you know, these kind of things like, for example, hospice discussion is worthwhile. When you think about these discussions, there are also tools here that can help you have that discussion with your patient using pictures and graphs that are really well written and helpful in order to really think about, is this something that the patient and I both want to do? And this is just an example where the time to benefit is often different than the time to harm. Frankly, with most medications, the time to harm is immediate. So they can get side effects right away, right? But the time to benefit can really vary. So with statins, for example, it often takes at least 3 years to reach the benefit. With bisphosphonates, it takes about 12 to 18 months to reach the benefit for osteoporosis prevention. Immunizations work in 2 weeks though. So when we think about giving immunizations, that makes sense for our patients. And often these are actually published time to benefits, but you can also look at the Kaplan-Meier curves and graphs that you'll see in clinical trials, and you can see where the line of benefit starts to differentiate itself significantly from placebo or from no intervention, and you can kind of estimate that even yourself. So when we think about time to benefit, also we have to think about what are our goals of care. Oftentimes, this is a diabetes example, we may be overly aggressively treating our patients. So the American Diabetes Association didn't have this in the last 20 years. They have developed older adult guidelines more recently, and these are so helpful because guess what they say with older adults? We need to be thinking more about harms of treating diabetes because it really takes 5 to 10 years at least to prevent the micro and macrovascular complications. So in those 5 to 10 years, is the person going to live that long? And are they really going to benefit from tight glucose control? Most of the time, the answer is no. And so the ADA goals are very different for an older patient. You might not be able to read it here, but if you go to this reference and they're updated annually, the patients that would be in the long-term care setting down at the very bottom, those that are complex or have poor health or have dementia with a limited remaining life expectancy, they don't even recommend getting an A1C or adjusting drugs based on it because it's often inaccurate due to things like anemia or other health conditions. And so they really recommend relying on just glucose control. And most of the time, that's just getting a morning glucose fasting and an evening bedtime glucose. And the goals are much different. And so recommended here is having a fasting blood glucose goal less than 200, having a bedtime, or 180, sorry, having a bedtime glucose goal less than 200. That's much different. And sometimes the family members need education on why it's going to be a different goal than they had 3 years ago when they were treated in the outpatient setting. And I cannot tell you enough how many patients I've had to educate where they were really happy to not be in what some have called diabetes jail, where they were checking their blood sugars all the time, almost like a home continuous blood glucose monitor, but with their finger. So, patients are happy to not be monitored as much. And really, you're trying to prevent hospitalization from hyperglycemia, like with, concerns about dehydration and HHS or DKA, and signs of hypoglycemia and an admission from hypoglycemia. So part of that is also not checking as often. It's also not reacting immediately and looking more at trends. They also have a simplification of therapy for older adults, which is really awesome. One of the first things that I always do is switch basal insulin to the morning. It doesn't make sense if there's a peak in some of our patients to give it at night, but that's how it was studied and that's how it sort of came out, and everyone started bedtime insulin, but it makes much more sense to give it in the morning when your patients can eat during the day and then not get hypoglycemic during the night. They also say stop sliding scale insulin. So we've been saying this for about 10 years, but sometimes stopping sliding scale insulin means you have to stop the checking of the blood sugars. So you have nothing to react to, right? So if the ADA says it, we can do it. So in addition to some of these goals of care and quality metrics and stuff, we also have the Lone Institute, which came out with medication overload and a really nice report and things to consider. So they recommend things to consider deprescribing would be never necessary medications, those that are indicated but not beneficial, drugs that are no longer necessary, OTC meds and supplements, the bane of some of our existence in Colorado because so many patients want their OTCs and supplements. Also, drugs causing side effects, drugs that the patient is interested in stopping. Again, we should be asking our patients every time, what are you interested in stopping? And then trading drugs for non-pharmacologic approaches. So let's first look at the never necessary. This is what you'd think of as the Beers criteria drugs. So like if it's on the Beers criteria, we want to try to avoid it if we can. Sometimes we can't, sometimes we need those meds, but in general, those are never in the never necessary category. They have a high risk and a low benefit. Then we think about drugs that are intended to be short-term, but are continued long-term. A lot of times I see that's albuterol. Albuterol is awesome for an upper respiratory infection cough. It helps reduce that bronchospasm. It makes people feel better, but then we just keep them on it when we really need to discontinue the albuterol. They don't have a chronic condition. Also, we think about PPIs. PPIs are used frequently for an acute GI bleed or maybe GI prophylaxis in the inpatient setting, but it doesn't mean they need to continue that long-term. So we have to look for the indication. And then drugs as part of the prescribing cascade. Just as an update, the AGS 2023 Beers criteria has been accepted for publication. It should be out within the next couple of weeks. So a little bit about the prescribing cascade. I try to explain this to my patients with the book, There Was an Old Lady Who Swallowed a Fly. Most of them know that book. So when you think about There Was an Old Lady Who Swallowed a Fly, she thought she might die. And she wanted to catch that fly. So she swallowed a spider. But then she's like, oh my gosh, I got to do something about the spider. I'm going to swallow a bird. Then she needed to catch the bird. So she swallowed a cat. And then she needed to catch the cat. So she swallowed a dog. And it just goes on, which is a crazy thought. However, that's what we do with drug therapy. We start a drug. We treat the side effects with another drug. Then we start another drug to treat the side effects of that drug. One really easy example is amlodipine. Amlodipine works so well for blood pressure, but in a lot of older patients, it causes edema or swelling. And the edema and swelling is common, so we think, oh, we need to add a diuretic. This person's uncomfortable. Well, that diuretic is the spider catching the fly. So we think about then now they are hypokalemic. Darn it. So we add potassium instead of stopping the furosemide. Then they have heartburn from the potassium. And so now we're adding a PPI. And now, oh my gosh, they have C. diff. We have to treat them with vancomycin. This actually happens, and it's actually been studied in a JAMA Internal Medicine article where they found that older adults prescribed calcium channel blockers like amlodipine are 3 times more likely to get a diuretic in the next 90 days than if they're started on an ACE inhibitor or an angiotensin receptor blocker or a hydrochlorothiazide. So it's well described, but it happens a lot, and we have to rethink that cascade and relook at what we're doing, and potentially we could stop 5 meds. So really, when we see that prescribing cascade potentially, or any patient who gets a new symptom, we should be looking for a drug cause if possible, because there are so many side effects. They're very rare. Sometimes with older adults, you're seeing it in that population, and you may not have seen it in a younger population, but we should be thinking about, is this a drug? Do we need to adjust? And if there's a temporal relationship where the drug was started and a new drug was started and the side effect happened, we really need to look hard and see if it was from that medication. Other examples of prescribing cascades, sertraline does work as an antidepressant, but it's the most common cause of diarrhea among the antidepressants. So it's not on my list. I don't really like it because I'd rather choose another agent and not worry about getting diarrhea. But you'll see sertraline, you'll see diarrhea occur, and then you see loperamide. So that would be a prescribing cascade. Another example is spironolactone and lisinopril. They went to the cardiologist and boom, they're on 2 drugs increasing potassium, and now they're going to the ER and getting Kxalate. That one's probably more frequently caught. One that's not caught is carvedilol. Carvedilol is a great drug. It is studied well for both hypertension and both for heart failure. And so it's a good choice. However, it is a beta-1, beta-2 blocker. So it blocks the beta receptors in the lungs, which causes bronchoconstriction. It's not cardioselective. It also is an alpha blocker. So in men with BPH, it might be a winner. But in women who have urinary incontinence, it relaxes the urethra, and boom, now the women have more stressed urinary incontinence. So while it's a good choice for the heart, maybe a cardioselective beta blocker would be a better choice. And then we have cholinesterase inhibitors, our friends for dementia. And you all know this, but those can increase acetylcholine effects all over the body, not just in the brain. So we often see oxybutynin or detrol, tolterodine, or another drug being used to treat urinary incontinence when the patient really needs to be reevaluated for their donepezil. Moving on, indicated but not beneficial prescribing. These are drugs that have lost their effects or only provide modest benefit. And so often these are the cholinesterase inhibitors or memantine for dementia. But other drugs like sulfonylureas can often wear down and really not be effective if the person's pancreas is not working as well and they've had diabetes for a decade or longer. And so often then we can stop that medication and nothing will happen. Drugs that will not be effective or show benefit in the remaining lifespan, that's something like statins for primary prevention, may not be necessary any longer. And then drugs that have drug-drug interactions, so they're not even absorbed, those are medications that are low-hanging fruit for stopping. So for example, in patients who are on a PPI and they're on calcium carbonate, the calcium carbonate's probably not going to be absorbed. So we either need to stop it or we need to switch to a drug that is absorbed when there's no acid, like calcium citrate. Drugs that are no longer necessary based on certain timeframes, but are never stopped. And I'm sure you guys know all of these medications, but bisphosphonates we have to think about. Maybe they're indicated for 5 years, and then the patient can have a drug holiday. Oftentimes, if they're not very high risk, that 5-year treatment with the bisphosphonate is enough. We also think about drugs like antidepressants. Perhaps the patient's depression is in remission and they are able to actually stop their antidepressant. Or antiplatelets. Maybe it's been 6 years since they got their stent placed and wow, maybe we don't need their antiplatelet anymore. And you may have to take up a discussion with the cardiologist, but it might be worth it to get them off their antiplatelet. We also think about drugs that are no longer necessary due to changes in goals of care. So I bring up the vitamins and minerals here. If your patient has had changes in their quality of life and goals of care, let's get rid of their extra supplements. Those supplements were to prevent an illness. If we have moved on from prevention, we may not need vitamins, minerals, and supplements. And I say we may not need, but the kids still may need it. So we may have to talk to the family members as well. So unnecessary OTC and supplement use, those that can easily cause harm in our older adults would be things like aspirin, ibuprofen and naproxen or other NSAIDs, diphenhydramine, pseudoephedrine is really tough for men with BPH. It makes it hard to urinate. It can also cause insomnia. And then we think about omeprazole and PPIs. Those that are often not indicated anymore or don't have any data, multivitamins, as I mentioned, fish oil, which is often better replaced with dietary fish if possible. Probiotics may have been indicated short-term after a hospitalization for C. diff or with an antibiotic, but they may not be needed long-term. And then vitamin C may or may not be indicated depending on the comorbidities. There are a few exceptions I list up here, which sometimes are fine, sometimes may not be needed as well. AREDS too drives me crazy because I see many patients on it for prevention of macular degeneration. It's not for prevention. It's for treatment of moderate to severe macular degeneration. So if a patient is not diagnosed with that, I often recommend discontinuing their AREDS 2 vitamins. So a lot of things can be used instead of some of these riskier drugs. Sometimes it's drugs, but oftentimes it can be non-pharmacologic approaches. So I heard great things about the physical therapy talks today, and I know that physical therapy often has good non-pharmacologic recommendations, so we need to be able to reach out to those practitioners and come up with them. Counseling, cognitive behavioral therapy may or may not be appropriate, and virtual reality is really cool. There's a lot of data now for virtual reality goggles to try to help improve pain, to try to help improve anxiety and depression. And so our clinic, for example, has some virtual reality goggles that we can loan to patients. Music therapy is amazing. Exercise. I really love heat. Heat works so well for muscle pain. Heat works so well even for osteoarthritis. We forget to use heating pads. Now there's, pros and cons, burns, fires, but heating pads are often things that we forget to utilize. So we're quick going to talk about deprescribing. I know I'm running close on time. Deprescribing, one of the great quotes here from Doug Danforth, starting medications is like the bliss of marriage and stopping them is like the agony of divorce. Some general tips. At least once a year, we should be reevaluating our patients' medications. And what I recommend is having an entirely new column in your electronic medical record or your charting where you have just the deprescribing column. Have a straight up deprescribing column where you can say goals for deprescribing. In April, I'm going to try to stop the PPI. In March, I did stop their diphenhydramine. So you have a record and you kind of see what that progress is. You can see if you stop something that, oh gosh, I got to monitor for that. And again, we want to be talking about this with the family so that they're on board as well. Some common drugs to deprescribe. PPIs, of course, have pros. They do help reduce GI bleed risk, but they also have a lot of cons. We think about pneumonia risk, we think about C. diff risk, we think about vitamin and mineral deficiencies like B12 deficiency is very common with PPI use. It's also magnesium deficiency is common. So those are on definitely on the top of a lot of people's list. Benzodiazepines, of course, in the nursing home setting on the list for sure. NSAIDs have a lot of side effects as well, anticholinergics. Insulin is almost always on my list. It may often be on the patient's list as well. Can we reduce? Sometimes we can't stop the insulin, but can we reduce the dosing so that we are eliminating hypoglycemia? And sulfonylurea is for the same reason. FYI, they're on the Beers list now as a do not use if possible, because there's data to show increased risk of cardiovascular events with sulfonylureas compared to other agents. And that's not even hypoglycemia, it's cardiovascular events. So they may be on the new deprescribed list for many people. We also think about, of course, CNS meds, sedative hypnotics, antipsychotics, cholinesterase inhibitors, statins, and aspirin. Cholinesterase inhibitors and memantine are probably on a lot of your lists for patients who have severe dementia because the benefit may not be there. It's probably not there. And the risks are still there. So when we think about some of these meds, generally, there are certain meds that are best to taper. The best to taper ones may have more likelihood of side effects if they are cold turkey discontinued. So that would be things like beta blockers and clonidine. They can cause rapid tachycardia if they're cold turkey stopped. Clonidine can also cause great increases in blood pressure. This is even evident with non-adherence, where you'll see really rapid increases in blood pressure if clonidine is abruptly stopped. Anything that has withdrawal side effects should be tapered if possible. Benzodiazepines, antidepressants, antipsychotics, opioids, pregabalin, gabapentin, all could have withdrawal symptoms, kind of like they were on cocaine, and now they're withdrawing. So we think about headache, nausea, vomiting, rigors, fever sometimes. They feel terrible. So we do want to taper to prevent that. We also, for example, if they're on something for seizures, we don't want to precipitate another seizure, so we need to taper off, but we have to know what the indication of those medications are. Estrogen, we've all seen our patients have hot flashes come back when they never even had hot flashes. It's a crazy medical miracle. So tapering estrogen is also helpful, but I say best to taper because frankly, if they're having a really bad side effect, they're having something that is not worth tapering, then don't taper. Just abruptly stop and monitor for harm. If they have harm, you can start back at a lower dose so you can stop that withdrawal side effect or that really bad side effect. Now, other meds where you generally don't have to taper would be things like ACEs, ARBs, and diuretics, statins, anticholinergics, NSAIDs and aspirin, insulin, sulfonylureas, metformin. But again, like insulin, for example, if you stop abruptly their insulin, they could have hyperglycemia. So you have to monitor for that. So sometimes tapering is better in that indication. Cholinesterase inhibitors are another drug that the data in severe dementia are pretty, there's quite a few studies now that we may not need to taper cholinesterase inhibitors because there is not an increased, compared to continuation, increased risk of patients having behavioral problems or aggression. But oftentimes clinicians may taper cholinesterase inhibitors because they've had patients who they abruptly discontinued, and it was such a problem in the setting with nursing care and patients' family members that they now want to make sure they taper all of those patients. So it's really up to you, and you could frankly taper any medication. The downside of tapering is that it takes longer and you might forget about it. So if you're going to taper something, I would recommend doing it in 1 month intervals if possible, because that's better for the pharmacy. They give a 1 month dosing amount, and it's easier to document on a monthly basis what that dose titration is. But for example, donepezil 5 milligram, there's no lower dose. So you could just discontinue it. Donepezil 10 milligram, you could go to 5 for 1 month, make it easy on the pharmacy and nursing staff and patient, and then discontinue if you were to taper. There's some great resources. The Drive to Deprescribe uses these same resources. So when we think about deprescribing.org, Canada is crushing the United States with deprescribing resources. And so many of them come out of Canada. These websites, if you haven't used them, are awesome. They have patient tools for ambulatory use. They have studied these in real clinical trials, and they've been very effective. They also have patient monitoring plans, what to do if they can't sleep once they stop their med. They have algorithms for clinicians, and they recommend how to taper. Tapering is tough, and so what is recommended may not fit for your patient, so you may have to adjust, but they also have good goals for what to monitor. The US Deprescribing Research Network, or USDEN, which has an annual meeting associated with the AGS annual meeting next week, is also making a lot of headway. So we're trying to catch up to the Canadians. And they also link to Australian and UK deprescribing resources, which sometimes are with drug classes that the Canadians haven't covered. So there's extra resources on those sites. And then medstopper.com, I kind of like, for it describes how to taper things. It gives you a number needed to treat link, and you can assess your patient as frail or not frail, and then it'll give you different recommendations. This is an example where it has faces. So it's like smiley face is good, frowny face bad. But it gives you some tapering recommendations on what to monitor for. Taper MD is also, it's a paid program, but you can also get free resources here. And they also link to some of the Australian options for deprescribing, but this has a dashboard with EHR integration with point-click care. How many have this availability for clinicians at your site or pharmacists? Okay, so no one here has it, but this is available to integrate, and it has a tracking and exporting of reports available. So I don't know how much expensive it is, but this does have free resources that you can go to the website and get some algorithms and tapering guidance. Another one is Med Safer. Who's heard of Med Safer before? Okay, so Jen, a couple people. So Med Safer actually has two clinical studies that have been published related to their work, but it is available with point click care in Canada. But right now, I don't think many facilities in the United States are able to access this. Canada, again, is really much ahead in terms of that thought process of deprescribing. And so they have these resources and they have a lot of evidence to support the use. So for example, the Med Safer study, electronic decision support for deprescribing in hospitalized older adults, they have a randomized cluster clinical trial that was recently published. So let's look at a case, for example, deprescribing. We have an 89-year-old man with dementia and AFib. So what are some deprescribing considerations for each of his drugs? I didn't even give you his drug list, but if we did have his drug list, is the patient receiving benefit from the drug? Is one of the first questions. The patient may be receiving benefit, but it may be difficult to know. You may not know until the medication is stopped, and then there's a negative response, meaning that the patient shows symptoms of the condition you were treating. That means they were benefiting, and that means you may need to add that medication back on, potentially. Do the harms outweigh the benefit of the drug? Let me give you an example from clinic. We have a patient we manage with high blood pressure. He's on labetalol and rivastigmine because he has Parkinson's dementia. He has bradycardia. His heart rate is in the 50s. I called his wife yesterday. The highest he had last week was a heart rate of 60 and lowest was 54. And for weeks, I've been wanting to reduce his labetalol dose, but his blood pressure has never been so good. His blood pressure is stable. And so even though I wanted to decrease his labetalol because his wife and he wanted him to stay on the rivastigmine, which also lowers heart rate, we kept him with that heart rate in the 50s. So we're monitoring. But it was a consideration. If I'm treating the numbers, heck yeah, I'm lowering his labetalol dose. But if I'm treating him and he's doing well, he's stable, his blood pressure's finally good, it's not 190, we kept him on the labetalol. So sometimes the harms might not outweigh the benefit at the moment. Are the patient's symptoms stable? Is the purpose of the drug for prevention or treatment? That's a really important factor. Will withdrawal symptoms or disease recurrence occur? It could with many drugs. Is tapering required or recommended? And how should the patient be monitored? So when we look at his meds, we review it, and he has two first low-hanging fruit to deprescribe. One is simvastatin 40 milligrams, and one is omeprazole 20 milligrams a day. So we want to look, what's the indication? Sometimes that's hard to find. His statin indication, there was no cardiovascular disease, so he has primary prevention. That means he's at low risk of another event in general. He has no stroke history. The PPI is for GERD, and he's currently asymptomatic. So we want to look at his life expectancy, and we do that looking at the Mitchell Index. This is with the UCSF website. So we go to the UCSF website, we look at this, and he has a 28% chance of mortality at 6 months estimated. So that can impact our thought process on these medications. So we want to consider, what are the benefits? There's less pill burden with 2 different meds being gone, less muscle pain, perhaps with the statin, less GI side effects. Often they can cause some nausea or vomiting that are hard to know if the patient is having that from statin or not. Less drug-drug interactions, lower risk of C. diff, pneumonia, and magnesium and B12 deficiency if the PPI is gone. So a lot of benefits. What are the risks though? He could have a return of his GI symptoms. He has potential increased risk of GI bleed if he's also on an antiplatelet or he's on a DOAC for his atrial fibrillation. Maybe that PPI is helping reduce GI bleed risk. What are his risks if he stops his statin or his aspirin, for example? When we look at statin stopping, cardiovascular events can increase So there are 3 retrospective studies with thousands and thousands of patients that showed increased risk of cardiovascular MACE events after stopping a statin, and they occurred between 2 and 5 years after stopping the statin compared to continuation of statin. So there are data to show that there are harms, but may or may not apply to your patient. Earlier in one of the falls cases, digoxin was on the list. Digoxin is, of course, on the Beers list for years, but we had to respond to cardiovascular specialists who, in that process of updating the Beers criteria, pointed out there were new data to show that stopping digoxin in people who were doing well on it and have heart failure actually have increased risk of heart failure hospitalizations. So sometimes new data come out and we have to relook at the data and decide if we're going to DC the digoxin or not. And the same is true for statins. There are 3 studies looking at stopping it and increased risk of CV events. And do the meds need to be tapered? So we discontinue the statin. We look at the omeprazole and we decide to taper it. Tapering omeprazole is kind of hard. If you don't do it like every other day, there may only be 1 lower dose, so it may be complicated to do that. So sometimes it means we just abruptly stop the omeprazole. But one thing that's helpful, this deprescribing.org algorithm, I really like some of their algorithms because they actually bring up, it's really hard to see, but a monitor at 4 and 12 weeks. What do you monitor if you deprescribe it? And they have monitoring criteria for nonverbal patients. So let's say this patient has severe dementia. What do you monitor? They're not going to tell you that they have heartburn, right? And he's on it for GERD. They describe here, if nonverbal, you should look for loss of appetite. You should look for weight loss, and you should look for agitation. Maybe the agitation's not his dementia med being stopped. Maybe the agitation is heartburn from abruptly stopping the PPI, or he needed the PPI and we didn't know. So what's great about this is that you can kind of think about verbal and nonverbal patients. All right, thank you so much. I know I talked really fast. And are we having questions or not? Are we doing panel questions or we're done? Okay. Okay, perfect.
So I'm going to tell you guys a joke while they pull up the slides. So I shouldn't have told you it was a joke. Okay, so I was walking outside at lunch and I saw a person walking a clam, and he had a harness on it and he's just dragging it behind him. And I thought, man, how hard to walk with a pulled muscle. And the reason I tell you that, groaner, is because we're going to talk about pearls. All right.
Well, first, congratulations. You made it through the entire conference. You are smarter. We so appreciate that you're here. This is the last 10 minutes and we're going to pull it all together. These are the best pearls from the conference. We read everything in advance, and then these are the things that we thought were just awesome. Okay, here we go.
And also, if you stick with us, we'll do the raffles soon. All right, pearl number 1. If you remember all the way back from this morning with Dr. Wasserman, consensus leadership style. It gets input from everyone in the IDT, allows, and then works with the group's input to influence the decision making. When I do it, then it just falls and it's a thing. Okay, and what this leads to is decreased staff turnover, better patient outcomes, and better survey outcomes, which we like all of those things.
Okay, pearl number 2, out of hospital CPR outcomes for patients over 70 years old. Overall survival to discharge 4.1%. If you're a nursing home resident, if you have CPR, only 2.2% are discharged alive from the hospital. The take-home message here, CPR rarely leads to a good neurological outcome in nursing home residents. And we want our residents and our families to be aware of this.
All right, pearl number 3 from our 4 M's, or the 4 M's. Destigmatize stepping down from a higher position to one of less responsibility. Because if that's what's right for that person, your colleague at that time, it's better, like she said, like Erin said, to keep them on the team and have them still around, and don't make them feel bad about stepping down from that role.
Okay, pearl number 4, walking speed is a modifiable risk factor. That is so rare. We never have modifiable risk factors. So walking speed is predictive of life expectancy. Older patients with slow gait are at increased risk of being severely frail, becoming dependent, and have a higher risk of death, hospitalization, and falls. That's a big list. So older adults with faster gait speed have increased independence, self-care, are able to do more household activities independently, and are less likely to be hospitalized. The take-home message, walking speed can be improved, which can improve mortality.
All right, number 5, which is a bonus because it's actually a 4-parter. The 4 Ps of fall prevention, and we actually got ourselves on this screen. That's one of the highlighted things from the fall panel, that green sheet they were holding up. But checking about the patient's position, their personal needs, are those all being met? Are they in pain? And how is their placement? Asking these 4 Ps will help prevent the patient from trying to correct some of these things themselves and potentially leading to falls.
Okay, pearl number 6, the American Thoracic Society and the European Respiratory Society no longer recommend a fixed cutoff for diagnosing COPD with the FEV1 FVC ratio. A LAMBA and LAMA is a preferred initial inhaled medication regimen for all symptomatic patients with COPD.
I think it's pronounced llama. I'm just kidding. Get it? Llamas. Okay. Pearl number 7, she prescribed me. She's never going to do this with me again. All right. This is a fresh one because we just had this awesome talk, and I'll just skip to the red part because honestly, it's my favorite. Starting medications is the bliss of marriage. Stopping them is the agony of divorce. I think about that a lot because how many times as we try to deprescribe, it's a constant conversation and a give and take, trying to get both the patient and their families buy-in, but also the staff buy-in. So I think anytime we start a medication, we should remember that saying. And the other 2 that are on here, I will let you guys read on your own.
Pearl number 8, the 5 pillars of heart failure therapy. There's the ACE, neprilyzine inhibitors, beta blockers, mineralocorticoid, receptor antagonists, SGL2 inhibitors. There's a lot of SGL2 inhibitor anxiety out there for providers. I am one of them. I'm going to raise my hand. So it's time that we try it out.
All right. And then going back to our trauma-informed care talk this morning with Dr. Watson, her 2 key questions kind of when we're seeing behavior in residents is asking ourselves, how could this behavior make sense as a reaction to past trauma? And what might this person need to avoid reliving their trauma in the future? And I think it's a great point because we manage behaviors all the time and we're always trying to think of where are these stemming from? Is it unmet needs? Is it pain? But also maybe remembering that these could be coping mechanisms that they've been using throughout their life.
This is one of my favorite ones. Remembering the difference between equality and equity. If you give everybody a bike and it's the same bike, it may not work for folks. So considering people's circumstances is essential.
And also with this one, when we were talking, we were like, oh, we should have put the iceberg up for this one because that was also a really terrific slide. So many great pearls, so it was hard to choose. But remembering our initial medical therapy for tremor and or bradykinesia, you can have the levodopa preparations, dopamine agonists, the monoamine oxidase B inhibitors, and then if they have tremor only, the anticholinergic agents. And don't forget our therapy friends at all the times, PTOTST. Yes, always. And I actually think that was the last one. Yeah, here are our fuzzy friends. Thank you guys for all joining us today. And of course, we want to remind you to save the date for next year. We're already planning. Oh, well, when it goes back up, it's April 19th. Okay. 2 other things. There's a pair of glasses left in the exhibitor hall. If you're missing your glasses, you'll probably want those for the drive home. They're at the registration table. And please don't forget to fill out your survey to claim your CME credit. It's very important. The survey or the survey is required to get the credit. And now we will do raffles. Thank you to our vendors for all these awesome raffles. Okay.
So we have a lot of gifts to give away. So you have a great chance of going home with something good. So we are going to give everything away. Okay. Yeah. Okay. Yeah. Oh, does anybody have any last sheets to turn in? Oh, you see? Yeah. Come on down. Right. Okay, we have a pickleball basket and this is for
It's Marley.
Marley Housted? Marley? Okay, we're gonna pick somebody else then. James Archuleta. Eh. And this is from Calabria, so we want to thank them. Okay, this is from Vivage Beacon, and the lucky winner is Sherry Reed. Sherry Reed? Yay!
Are you 21 and up, Sherry? Because I think there's a champagne in there.
And we're gonna have to take the noisemaker away from Travis.
This big one is from Forte.
Okay, the next one is from Forte, and the winner is Lee Annenberg. Hey. Oh, and by the way, not that I'm tooting my own horn, my 2 dogs are right behind in the back, and you can go say hi.
Didn't bring mine.
This is a gift certificate from Singulab. It's an Amazon gift certificate for $50. And it goes to Heather Ross. Oh, no, it's 100. There you go. And so this is another Amazon gift card from CMDA. Becky DeMark. Yay. So this one is from Longevity, and it's a gift certificate to a beer spa, kind of the combination of everything you could love. Oh my gosh, it's from Sweta. Sweta, you won.
This one is also from Longevity. It's a 4-pack of tickets to the healthcare appreciation game with the Rockies. I think they're playing a team I don't remember, so not helpful. Phillies, thank you. Josh Hill. Did he go home? Oh, no, okay. Jill Beacom. Right. Oh. Okay. And our last one, I believe, it's from the AMDA Foundation. Oh, we still have more. This is from the AMDA Foundation, and it is a free registration for the Tips from the Pros, Basics of Psychiatric Management in the Nursing Home. So this is free CME right here, you guys. Who's it go to? Kelly Johnson. Woo-hoo.
I've watched this. It's amazing.
And I think this last one is this basket, and who is it from? We aren't sure, but it looks awesome. Kathy Frenetti. She left. Oh, wait, no, she didn't. Even-
Left like 2 seconds.
Oh, you could catch her in the parking lot, yeah? Also for the folks who have the longevity ones, there's a business card. Please email Donna to help transfer the gifts to your name. Okay, is that everything? Yeah. Thank you, everyone, so much for coming. We hope to see you next year for the April 19th.